A warm good morning all. Distinguished dignitaries, respected faculty members, honored guests, delegates, researchers, students, and my dear ladies and gentlemen. With immense pride and great pleasure, I extend a warm and cordial welcome to each one of you to Kachcon 2026, Annual State Conference of the Karnataka Association of Community Health. I am Dr. Aishwarya, Senior Resident, Department of Community Medicine.
I'm Dr. Mahima, postgraduate from the Department of Community Medicine.
We are here to host the conference for the day.
Check, check, test, check, test, check, check, test, 1, 2, 3, check, 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 test, check. So,
Hello, sound check. Hello, hello, sound check. 1, 2. Hello, hello, sound check. 1, 2. Hello, 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 hello. Hello, sound check. Hello, sound check. 1, 2. Hello, 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 sound check. Hello, sound check. 1, 2. Hello. Hello, sound check. Hello, 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 hello.
Arvind bro.
Hello, good morning. Mic testing.
I request the delegates to kindly come forward and sit.
Kindly occupy the front row seats.
A warm good morning to all. A warm good morning to all, distinguished dignitaries, respected faculty members, honored guests, delegates, researchers, students, and my dear ladies and gentlemen. With immense pride and great pleasure, I extend a warm and cordial welcome to each one of you to Kachcon 2026, the 36th Annual State Conference of the Karnataka Association of Community Health. I'm Dr. Aishwarya, Senior Resident, Department of Community Medicine.
I'm Dr. Mahima, postgraduate from the Department of Community Medicine.
We are here to host the conference for the day.
We are honored by the gracious presence of our distinguished dignitaries, whose guidance and vision will continue to inspire the public health fraternity. Today's program comprises of 6 scientific sessions interspersed with the inaugural ceremony. We look forward to a day of insightful discussions, enriching learning and meaningful interactions.
We begin with the first scientific session on understanding the Sustainable Development Goals forward. Chairpersons being Dr. Prithvish Sir, Director in Academic Training, Sri Shankara Cancer Hospital and Research Center, Bangalore, and Dr. Prasanna Kamath Sir, Professor and former Head, Department of Community Medicine, SDMC. I request Dr. Prithvish Sir and Dr. Prasanna Sir to come over the dais and introduce the resource person, Dr. Praveen Kulkarni.
Good morning, friends. Nice to be in this excellent hall. I heard yesterday all the workshops went on very well. So we are starting with today's conference first day. Esteemed Honorable Vice Chancellor, all the senior public health specialists here, all my friends, well, we'll be starting this first session, and at this point, I would like to mention a few things before I introduce Dr. Praveen Kulkarni. Dr. Praveen, kindly sit down for a minute, come here. I want to, come, Bani Kutholi. 5 minutes Kutholi. I just wanted to especially congratulate the organizers for having chosen Sustainable Development Goals as the theme. I have a small thing, especially to mention to all the postgraduate students here and the faculty here. See, this theme which they have chosen is something very good. And just to recall ourselves, these Sustainable Development Goals, after the first session, entire 2 days will be devoted to different aspects of Sustainable Development Goals. In this context, just to recall, Sustainable Development Goals are 17. They are the global objectives adopted by the United Nations in 2015 to end poverty, protect our planet, and ensure prosperity and long peace. It is part of the 2030 Agenda, Sustainable Development. It is the universal call to all nations to work together in global partnership to achieve peace, prosperity, and environmental sustainability. I would request all my colleague participants and our students to keep a track of this SDGs from now onwards till the end of tomorrow, so that we will be able to analyze no poverty, zero hunger, good health and well-being, quality education, gender equity, clean water and sanitation, affordable and clean energy, decent economic growth, industry innovation, infrastructure, reduced inequities, sustainable cities, communities, responsible consumption and production, climate action, life below water, life on land, peace, justice, strong institutions, partnerships for goals, integrated approach, leaving no one behind, global participation. All these make blueprint for sustainable future. Friends, India stands 94th in the rank of the 167 countries. Karnataka stands 5th among the various states. I would request each of the postgraduate student and faculty here, whatever happens today and tomorrow, just look at the 17 indicators which form the framework for the Sustainable Development Goals. I'm extremely happy to introduce the speaker of the first session. He is our own person from our own state. To the left of me, Dr. Praveen Kulkarni is working as Scientist E-Medical at ICMR National Institute of Child Health Research, New Delhi. He was previously working as Professor of Community Medicine and Vice Principal at JSS Medical College, Mysore, Karnataka. A Fellow of Foundation for Advancements in International Medical Education and Research, FAMER, and alumni of Leadership Management Program offered by Incline Trust and IIHMR, New Delhi. He conducts regular workshops on research methodology, biostatistics, qualitative research, questionnaire designing. His areas of work include delivery research in child growth, nutrition, and non-communicable diseases. He has received several research grants from Government of India, Indian Council of Medical Research, Bill and Melinda Gates Foundation. He has been recipient of Presidential Appreciation Award from Indian Association of IAPS, Indian Association of Preventive and Social Medicine, Young Scientist Award from Karnataka Association of Community Health, Best Reviewer Award from Association for Physicians of India, Karnataka Chapter, Best Teacher Award and Research Excellence Award for 3 times from JSS Academy of Higher Education and Research, Mysuru. He was the principal investigator of Covishield, Covovax, adult and pediatric, and booster dose vaccine trials against COVID-19. He has more than 180 publications in various national and international journals with H index of 20. We welcome you, Dr. Kulkarni. Look forward to your disposition, please. Dr. Kulkarni, you have about 30 minutes time, and after that, about 10 minutes we can spend on the discussions. Thank you.
Thank you very much, sir. Very good morning to everyone. At the outset, I would like to thank the leadership of SDUAHER, Honorable Vice Chancellor ma'am, and my mentor, Dr. Vinuta Shankar ma'am is also there here. Very good morning to you. So, and my dear colleagues from the Department of Community Medicine, Prasanna sir, Pradeep, and Dr. Sunil sir, and all my teachers who are sitting here, and my dear colleagues. When it comes to catch and when it comes to Kolar, I have wonderful memories. In 2010, I think SDU has organized the conference, Karnataka Association of Community Health, and I was representing Kempegowda Institute of Medical Sciences as a second-year postgraduate, and I presented a study on naked eye single tube red cell osmotic fragility test for detection of beta thalassemia among antenatal women, and that was the first time I won the Catch Millennium Award. So my memories are very, very precious with SDUAHER and my association with this institution. I am a part of their internal quality assurance cell and part of their board of studies in community medicine. So it is wonderful to be over here and deliberate about my experiences on how institutions contribute towards achieving sustainable development goals. Respected chairpersons, I'll be restricting my talk only to the context in which we are speaking on how, as institution, we can contribute towards achieving or attaining sustainable development goals. I'm not talking more of theory. I'll be sharing my experiences because I closely associate myself before I joined ICMR to JSS Academy of Higher Education and Research, where I was a part of the Times Higher Education Impact Ranking for attaining the Sustainable Development Goals. And the institution, JSS AHER, has done tremendous job in terms of contributing towards Sustainable Development Goals, and they stood number 1 in the country, number 1 in the world for SDG 3, that is good health and well-being, in Times Higher Education Impact Ranking on SDG. So I'll be sharing my experiences on how we provided data and how we connected all the activities of the institution towards the Sustainable Development Goals and what you can do in your own institutions so that you can bring some change in the institution so that you can contribute to the larger goal of Sustainable Development Goals. Dr. Prithvish sir has made my life very easy. He enumerated the Sustainable Development Goals. He has put the context in place, so I'll not be spending time on it. The story is long back. It all started with Health for All, and then came Millennium Development Goals, and then came Sustainable Development Goals. The context is same, to ensure good health and well-being to everybody, but the names are different. And the components that are added are different, and the components that are added are more related to the contemporary problems and the practices. Considering that, the Sustainable Development Goal document is more holistic and it is more comprehensive compared to rest of the documents that were before. Okay? Because as the problems which were there in 70s were different in 90s, and the problems in in 21st century are totally different. So our goals have to adapt to the new changes, new norms. So you may be asking, there was Health for All, there was Millennium Development Goal, there is Sustainable Development Goal, nothing has happened before and nothing is going to happen in future. After 2030, they will change the name of, they will bring another set of goals. The problem is our thinking. We cannot say nothing has happened. The global policies, guidelines were aligned to the contemporary goals, contemporary principles of well-being. And the major principle is being optimistic. We need to be optimistic in accepting the changes. We should be optimistic in moving forward. Only those who are optimistic are going to survive. And Sustainable Development Goals are the goals for the optimistic people. If you are not optimistic, I request you to be optimistic, change your mind, or I don't want to say the other part. Point is being optimistic. The goals have been enumerated. It moves across. The medical education institutions, as it is a university in which we are talking, I did not restrict myself to the medical education. I kept more promising word, that is health profession education institutions. The reason why health education or health professional institutions can contribute highest towards achieving the sustainable development goals is, number one, they are very optimistic. They adapt to the change. And they move, they have everything in them. They have students, they have healthcare, they have patients, they have hospitals, they have communities, they have leadership, they have management, they have governance, they have best practices, they have quality system in place. Why can't they not contribute? If they do not contribute, who can contribute? So the health profession institutions in which you are all belonging currently, or in future you may belong, so they have a very, very large role to play in attaining the sustainable development goals. When I talk about health profession institutions, in India there are more than 19,000 health profession institutions as of now. We have more than 820 medical colleges, we have dental colleges, we have large number of nursing colleges, and we have allied health science programs, physiotherapy, large number of these organizations. If they contribute towards attaining sustainable development goals, then we are going to cover a larger population and large number of people who can contribute, who can actually do something to the sustainable development goals. We can get the targets and we can achieve the indicators. I'll be addressing the leadership of SDUAHER at afternoon, maybe sometime they are going to fix maybe between 11 to 1 or afternoon. I'll be talking to them about what is the role they as specific can play. But now considering the larger audience, I'll be restricting myself to the context of postgraduates and other medical education institutions. As I mentioned, why medical education or health professional institutions? These institutions are knowledge hubs. They do not impart knowledge, they generate knowledge. So SDG 4 is health, quality education, which can be imparted by the medical education institutions. And they have a role to play, major role in research, publications, patents, innovations, transformation. They can act as agent of social welfare and social justice by providing health care to everyone on their territories. And they provide quality health care to the people, and they are equipped and they are mandated to provide quality health care. They act as collaborators, regional, national, international collaborators. Again, SDG 17 is all related to collaborations. They are factories to generate human resource, a quality human resource who can contribute to the nation and to the world. Academic institutions drive economy. They generate economy, and they are going to help in sustaining economy. And these are the institutions where they are having the gender diversity among students, among faculty, and among the patients whom they are catering to. And the most important thing the academic institutions have got is communities with them. And here where the community medicine department comes into picture. So we have the field practice areas, we have the outreach, and we have ability to cater to the people who are underserved, who need to be given more importance. Reducing inequalities is one of the important agenda, Sustainable Development Goal 10. We have urban field practice areas which can contribute towards urban health of people. Sustainable Development Goal number 11, sustaining the cities and communities. And we have, ample of opportunities to deliver. And the higher academic institutions have potential for conducting translational research, and they can act as role models for the best practices, and they can inculcate the concepts of ethics, equity, and morality among students and the communities. These are all the reasons I could just list from with my experiences, why the academic institutions are the major drivers for attaining the sustainable development goals. Let me go goal by goal, and we can just enlist how institutions can contribute. When it comes to no poverty, we used to think what a medical college can do for poverty. We are private organizations, We do not have any, powers or ability to give money to somebody or alleviate poverty. But when you go in depth, you have a large component to learn. Large number of people go for catastrophic health expenditures and enter into poverty. As medical education institution, as healthcare institution, you have a larger role to play in providing healthcare at a reasonable, affordable cost. If you are putting your institution in global forum and you want to say, I am contributing to poverty alleviation, if they ask you how, your answer is, I am providing, quality health care to the people at an affordable cost. I am lifting so many people. I am preventing so many people to go from catastrophic health care expenditures. So that is how you are contributing towards poverty alleviation. If you have some system in place, it is very important. We are the one who implement the national programs for universal health coverage, health insurance schemes, social welfare schemes. And all these schemes may not directly give money to the people, but definitely help in improving their economic status. And next thing is, we have ability to do the outreach camps. If there is a person suffering from tuberculosis, residing in some remote rural, urban areas, you do a camp and detect that person and give a treatment, ensure a person receives the treatment. You have improved the dialysis. You have improved their quality of life. There is a 35-year-old person, 40-year-old person having premature cataract. You go to the community, detect him, and give treatment, ensure treatment. So you have not only improved his health, you have improved his economic productivity. So as medical education institutions, we have these responsibilities to play. We can establish the satellite centers, healthcare centers to serve needy, and institutes can fund for underprivileged people. Lot of educational institutions, and the institution which I was serving before, they have something called as Poor Children Fund, where the faculty contribute towards poor children and their education is taken care of. I can quote some examples. Amrita institution is having so many outreach units at various parts of the world, of the country. And you have St. John's St. John's provides quality health care to the people in underserved areas. So I can quote Manipal for that matter. So they have large number of centers, healthcare outreach activities where they can help in detection of illnesses early and provide care to the people. Can we provide scholarship to the students who are there in the institution? Acha, how much money we are taking from one MBBS student, as I am talking in the context of deemed university. Can one MBBS student or one PG student fees will be able to support, say, 15 nursing students for their annual fees? 10 nursing students? So we need to think in that way. Because we have a responsibility to play. We have a responsibility to deliver as academic institutions. And institutes can also establish scholarship for poor children. And there are some models of medical college social responsibility initiatives. Now, medical education institutions have not remained only as academic institutions, they have entered into corporate. So you agree, do not agree, or you completely say you are talking nonsense, I accept it. But now we are in a situation where the medical education institutions are not only the education institutions, they have entered into the corporate sector, they have entered into the economic generation hub zone. And when we have that, we have corporate, as corporate responsibility initiatives, we have the social responsibility initiatives. So we need to take those initiatives and we need to provide care to the people. So with every SDG, I have tried to put some, take-home message. So for SDG 1, what you can contribute: cut healthcare cost, prevent catastrophe, and serve underserved. These are the 3 important things with which you can contribute to Sustainable Development Goal. Second came hunger. Again, think of what can you do to alleviate hunger. When we think in a very plain context, medical education institutions, you don't go and cook food to anybody. Neither we are producers of food, nor we store food, nor we distribute food. But you have a larger role to play. SDG 3 ensures food security. Are people in your campus, the students, having food security? Second, are your patients coming to the hospital have got food safety and security? If that is the case, you have won the war at the first level. Second, we have a larger role to play in prevention of undernutrition, stunting, growth-related problems among children who are nutrition-related. SDG 2 is not only providing food, it is also preventing undernutrition. So what can you do as an education institution to identify the burden of the problem and come out with sustainable solutions? It could be either you give a, I can give example of Savita Medical College. They take care of, generating, they have a partnership with the industry, food industry, and they make sustainable food products, and they are tested among the field practice areas following all ethical guidelines. How can you contribute in that? How can you help communities to implement research, implementation research towards improving the nutritional status of children across all age groups? It could be children, it could be adolescents, it could be pregnant women, lactating women, elderly related, nutrition related problems are plenty. Yesterday I submitted one of the project which I was working with JSS, was related to micronutrient deficiency, hidden hunger among elderly in the tribal areas. Almost 60% of tribal elderly suffer from hidden hunger, micronutrient deficiency. Can you do something related to that? If it is for elderly, there will be much more for children, much more for women in reproductive age group. And we can conduct food and nutrition awareness sessions. And Department of Community Medicine at JSS, they used to conduct complete nutrition week, where every outreach center used to have a cooking competitions, preparing healthy foods, and nutrition awareness campaigns. I think many institutions would be doing that. So that spreads awareness among people. Nutrition and hygiene related information that you can provide to the people. And can we have a kitchen gardens in the hostels, in the hospital premises? So that will definitely help in food production, storage, and providing care to the people. The summary is ensure food safety, security, and prevent undernutrition. One tagline. A question was asked when I attended one of the conference in Bangkok related to SDG impact ranking. Tell us one reason why we should rate you higher in no hunger component. The tagline is, as an academic institution, nobody in my campus, including students, including patients, and including anybody who is there in the campus, will sleep with empty stomach at night. If you ensure that, it is a food security. If you are able to achieve that as a part of institution within your institute, then you are able to provide care to the people. Coming to the good health and well-being. Good health and well-being, you have medical education institutions have large role to play, providing comprehensive, preventive, promotive, curative health. Again, all theoretical underpinnings. So make healthcare available, affordable, which I was talking from slide 1. Medical colleges have got a role to play to provide healthcare care at all levels, starting from primary with your field practice areas. Secondary, now we have internship program where students are posted to the secondary tier healthcare systems, and you yourself are the tertiary care. And you have a role to play as a specialty, super specialty institutes also. Okay? So strengthening that component is more important. Providing advanced diagnostic facilities for people in need in the hospitals. And more important is assuring quality. When we want to compare ourselves with the global standards, ensuring quality is more important. Going for accreditations. There is still a lot of hesitation to go for accreditations. It could be NABH, NABL, NAC, whichever national or international accreditations the institutions should go. As medical institutions, we should go for it so that we'll be having our quality benchmarks. Reaching the unreached, I gave several examples related to that. Another important thing is adopting the communities. I'm very fortunate to be a part of Adopt a Village Rural Rabies Prevention Project. Dr. Sudarshan sir is sitting here and Dr. Ashwath Narayan sir is there and Dr. Ramesh Masi sir is there. I think I was addressing one of the forum first week of this month, and they wanted to talk on, they wanted to project their institute for One Health. I told, now you are talking about One Health. KIMS has actually demonstrated One Health in 2009 when nobody had even thought of it. So the institutes have started working on it. So you need to work on those areas. So One Health is something that we need to go for, and we need to adopt communities, provide the care to the people, have established the cohorts, and quality research. Now, as I belong to ICMR, the research goes in 4 domains according to our system. Number 1, set of research called as descriptive. Second are developmental. Third are delivery. And fourth are discovery research. So you can contribute at all 4 domains of research in improving the healthcare of people. Partnership with communities for providing healthcare and education. And health education awareness components are the major part of this ranking framework, whichever ranking framework you talk. So they may not bother much about any other thing rather than spreading awareness to the people. As community medicine departments, as postgraduate students, you have a very, very large role to play in spreading awareness among communities and groups. And innovations in healthcare through technology, and now AI has become a buzzword, you can contribute to large extent in providing healthcare to the people, making people feel the healthcare is required, understanding the felt needs, providing the care to the people. AI can definitely support in providing that. Contributing effectively to implementation of national programs, development of national and international health policies and guidelines, and contributing towards focused awareness for various health problems. These are few things we can contribute. Quality mother and child care services, reproductive care services. It could be your OBG department in a private medical college. If you are providing free delivery to the people, free delivery services, free antenatal and postnatal services, I am talking more of a person sitting on the other side. So some institutions have done it. Being a private medical institutions, delivery services are free. If not free, can you provide in a subsidized cost? Less than any corporate. So in that case, you are contributing so much to the maternal and child health. You are providing care to the children. You are reducing infant mortality. You are reducing maternal mortality. You are reducing neonatal mortality. Contribution towards vaccine development. How many medical colleges have got the clinical trial units? You may not develop the vaccine, but you definitely have ability to test the vaccines. So I was born and brought up in the place in KIMS where all rabies-related vaccines are trialed and tested and undergone human trials. If I'm wrong, please correct me, but I'm being more optimistic. And I was grown in an institution called JSS where all COVID-19 vaccines have undergone either phase 2 or phase 3 trials. So as institute, can we work towards vaccine development or vaccine trials and pharmacovigilance? Injury prevention, injury surveillance, and substance abuse has become a major problem now. And the tagline is provide quality healthcare, equitable, affordable, accessible, which is powered by research and innovations. Fourth is quality education. As academic institution for medical education, are you providing quality medical education? By the set of rules that are established by international standards or national guidelines. Is there any compromise between what is expected and what is existing? Is our curriculum aligned with the SDGs? I get surprised when I see 3rd standard, my daughter's textbook of, social, environmental sciences. Each topic has been linked to the SDGs. In 4th standard, in your medical education institution, is your curriculum aligned to Sustainable Development Goals? It is definitely aligned. I'll tell with all confidence it is aligned. But are you documenting it? Are you practicing it in the way it should be? Think about it. Undertake faculty development programs for the faculty to learn, enrich their knowledge. Innovative teaching learning methods. Vinuta Shankar ma'am is there, and the health profession education unit of SDU is very strong. I'll be seeing a lot of webinar alerts and a lot of activities that take place over here for faculty development. So we need to ensure our teachers learn well and encourage teachers to undergo specific teaching, training in teaching learning activities, and curricular mapping and curricular revision. Educational research is another important thing, whether you are identifying the learner's needs and providing the teaching, learning according to their requirements. And then, are you giving award to the teachers who perform extremely well? These may all look very simple, but when it comes to the framework, when it comes to getting your institution in top, in ranking, all these components are very important. And when you talk about quality education and you do not recognize the quality among your teachers, what is quality education? You may be giving scholarship to the students, you may be giving awards to the students, give gold medals to the students. Who made that student to get the gold medal is the teacher. Are we giving recognition to the teacher related to that? So that becomes a part of your equitable, ensuring quality education. And holding the teachers in the academic institutions, not letting them outside, is another important problem. So support teachers to attend the conferences and provide financial assistance to them. How do you address slow learners and advanced learners is another important thing that we all need to think about. And how we support our students' progression as an academic institution. And holistic development of students is another important thing that we can think of. The tagline is quality health profession education through tailored curriculum for Sustainable Development Goals, empower teachers and competent students. If we are able to achieve it, then we are able to provide quality education. So I'll be talking more summary of the slides now, considering the time. As part of achieving the gender equity, is gender equity ensured in your campus? What is the proportion of women staff compared to men staff? We do not have a control in selecting the students as medical education. It is all decided through NEET. But in your recruitment policy, do you have the gender equity in place? And how many women are in leadership positions? Are the women given opportunity to take the decisions in the institution? Are they part of multiple committees in which they can serve? Is there any grievance redressal cell in the institute? Whether there is a functioning internal complaints committee that looks after the gender harassment, sexual abuse, or POSCO-related components, whether there is any. So we need to be very specific when we talk about internal complaints committee. So I was part of, as I was in the leadership position in the institute, and when we put it is internal complaints committee, and you should register your complaints of internal complaints committee to so and so person. One girl called up at, say, around 10:30, 10:45 at night and told, today, one of my teachers scolded me very badly. I want to register complaint against him. I told, come tomorrow to the office and we will discuss. When she came to the office, she said, I asked whether it is a complaint related to teacher or it is complaint related to any gender or sexual harassment. No, sir, nothing of that kind. He just scolded me, I wanted to bring it to your notice. So there is a difference between complaint and internal complaint committee. So you need to tell your students very clearly, broadly during their induction program. So if it is this complaint, you register to this committee. Otherwise, sometimes students are very crazy. What they do is, they will not come and inform you. They will directly write to UGC. Now, UGC portals are open. Students write to UGC, and then the letter comes from there that you need to inquire. If you get some complaint from there, you need to do investigation within 24 hours and do go for police station, register, and other take approval from them and put all those details back to UGC. So all these things are very important. Spreading awareness related to gender equity and sexual harassment are major components. Equal rights, equal growth, opportunities for everyone, and no place for violence and discrimination. As community medicine departments, we have a larger role to play in ensuring clean water and sanitation. Whether water is safe for everybody in the communities as well as in the academic institutions. Spread awareness on hygiene, spread awareness on sanitation, have proper biomedical waste management rules, guidelines. So Prithvish sir is sitting here, and entire MS Ramaiah has done a wonderful job in the area of biomedical research, waste management. So we have lessons to learn from those institutions and move forward. Whether you are following any water conservation policies and investigating outbreaks, clean water, personal hygiene, environmental sanitation are the key for health and well-being. Ensure access to affordable, reliable, and sustainable modern energy to all. Whether institutions have got their energy policies, whether the solar panels are in place in your institution, whether rainwater harvesting is done, whether you are spreading awareness to the students and following it in maintaining the clean and sustainable energy, whether there is a biogas plant. People say there is a biogas plant in the campus, and when we ask how much can you utilize it for? Making 10 cups of coffee tea, is it sufficient? Having a plant and using it adequately, and which is of capacity, is very important. Using LED lights, I'm finishing. So, I'm finishing. So, don't take so much of pain, I'm finishing. Yeah, so point is how we can support energy consumption and providing clean energy. Economic growth, now as I told, medical education institutions are economic hubs. They generate economy, they help in sustaining the economy. Whether your institution is economically stable, whether your people there in your institution have got a decent life, whether you have opportunities for promotion, whether you put your employees in place for the growth. Okay, fine. Thank you, sir. Yeah. So, I thought you asked me to finish faster, so I told I'm finishing. So there is some more other message. Thank you so much. So the point is, economic growth is a very important component that we all need to keep. Whether you are keeping, as Vice Chancellor ma'am is there and the leadership of the Registrar sir is there, so I want to keep it an important tagline, whether you are keeping your employees at the center of your institution's growth. Whether the growth of your employees is in line with the growth of your institute. So if you are able to answer to this point, and if you are able to put your policies in place, keeping employees at the center, then your institution is going to be the best one in that. And we as medical colleges may not have a direct role to play in resilient infrastructure, but whether our infrastructure is resilient. Whether we have the green building, whether our campus is green, whether we have a startup promotion culture in our institutes. Now, every institute, universities are expected to have pre-incubation centers, institution innovation councils, whether we do have, whether you conduct hackathons to your students, whether you conduct Shark Tank to your students. Students are very innovative. Lot of research, Animesh sir is going to endorse me, lot of research that comes out of Manipal is student research. I think, sir, please tell me if I'm wrong. It is his own, thought that we shared sometime. Students are involved in research, innovations. So how are we going to tap this resource? More important is having a resilient, strong, innovative infrastructure that provides care to the people. reducing inequalities is again in line with gender equity. Here the inequalities is related to the regions, different age groups, different social groups, and whether you are going to provide your care, your support, your outreach activities targeting all these population. And more importantly, whether you have got good policies in place for zero discrimination. So everything should be provided to everyone and something more to the people who are in need. That is what I purely do not agree with the word inequality. It should be inequity. I think sir put it up during his initial thought. It is not equality. It should be more of a equity-based principle that we need to think about. And as I was making a mention, we have urban field practice areas. Whether you are going to provide care to the people in urban field practice areas in a more adequate manner, whether you are able to detect problems which are very specific to the urban areas, whether you are able to provide care to the people in the urban areas in need, because the problems are very unique. Substance abuse, mental health related issues, and gender-based violence, domestic violence, these components are very specific to the urban communities. Are we providing care to these vulnerable people? Health promotion, disease prevention, prompt care, and protecting the vulnerable are the pillars of improving urban health. Are we wasting food? How many of you wasted ghee roast and a sweet that was given? If you are wasting it, are you measuring it? If you are wasting it, how you are recycling it? Medical college, academic institution, hostels waste lot of food. How is it documented? How food security, how consumption in the hostels and how consumption in the hospitals are taken care of? And whether we have standard procurement guidelines. We should not waste food. Measure how much waste we are generating and contribute with responsibility. Coming to the climate change, I think again there are some sessions related to climate change. I think they'll be focusing more related to that. I'll not be budging into that areas, but climate change is something the globe is calling. The globe is calling and telling, see, so many things are happening with me and you are not seeing it. The sea levels are rising, the temperature is increasing, and there is increase in the melting of ice, tips of the world. What are you doing for it? The carbon imprints are increasing. Are you doing have you taken any measure in your campus to prevent carbon footprint? Are you practicing carpooling in the campus? Are you providing the cycles to the students to avoid the motorcycles in the campus? So all these things come into play to contribute towards climate change. So we have a larger role to play in measuring the impact of climate change and taking measures to improve it. As I belong to the Child Health Institute, there is something called as a concept of endocrine disruptors. So this is a major topic. I think if you are planning to do some PhD in the endocrine disruptors among adolescents, these are microplastics and other environmental things, kind of the snow powder we put. All those things have got the chemicals that can disrupt the endocrine system in the body and leading to a lot of problems among adolescents and children. So are we addressing those kind of problems to the research and innovation? So a lot of things we can think of, and more importantly, spreading awareness. This is the only place I am not very optimistic, life below water, where medical education institutions cannot contribute much unless you are in the coastal areas. Okay, and if you are working for submarine areas. And life on land is more related to the ensuring of biodiversity, zoonotic diseases. One Health is a key. One Health was there in past, is there today, and it will be the principle for future, ensuring health for everyone's health being put in same place. And next is promoting the peaceful, inculcating the value culture among students is a major component an academic institute does. Zero discrimination policy, strong recruitment policy, retention policies, and your ethics committees should be very strong enough to promote the justice to the research participants and ensuring the ethical research, ethical medical care and research are very important components in ensuring the peace, justice among the communities. And last is related to the strengthening of the collaborations. Collaborations can occur at any level. It could be regional, national, international. The collaborations could be academic, it could be research, it could be related to infrastructure building, it could be related to translational policies, policy development, development of economic zones, innovations, capacity building. Whether you are contributing, whether you have MOUs. When we talk to the institutions, they say we have 116 MOUs. How many among them are functional? How many among them have given outputs? Whether you are mapping your MOUs with the outcomes. So that is a very important thing that we need to think about, and we cannot live in silos. SDGs is all about collaboration to learn, unlearn, and relearn many things. And there are some recognitions for the institution if you are doing extremely well in contributing to sustainable development goals. So there is something called as Times Higher Education Impact Ranking. If you are confident, you can apply your institute for this ranking. There is an elaborate, framework for this particular ranking. You can apply for individual rankings also. If you say, I want to apply for only good health and well-being, so I provide data only related to that. So that is fine. So you will be measured based on the institutes which have applied for good health and well-being. And you will be ranked. And now NIRF has also started SDG ranking. So there is a separate set of questions that are asked to the institute for sustainable development goals. I congratulate Sri Devaraja University. They are taking SDGs very seriously and focused, and they are planning to apply for various rankings related to the sustainable development goals. That should be done by many institutions. So if you are able to do it, then you are benchmarking. Why should we apply for rankings? The rankings are going to tell us where do we stand in the global setup. We are benchmarking ourselves, and we are able to find out how best we can progress year after year. So green rankings are there in place, and there are many other private rankings. Outlook gives its own ranking, Times gives its own ranking related to the sustainable development goal. Ultimately, if you apply for ranking and get it, it is a matter of great satisfaction. So you are contributing something to the world. To conclude, health is the center of all sustainable development goals, and health profession education institutions have got a larger role to play in providing healthcare. And we have got infrastructure, we have got people in place, we are very much aligned to the principles of sustainable development goals. And most importantly, I will end where I have started, we are all optimistic. If at all, if you want to comment tomorrow, nothing has happened in sustainable development goals, my first question is, what have you done? If you have done something, then you have rights to comment. If you have not contributed yourself, or you have not linked yourself to the sustainable development goals, then you do not have anything to ask. So I keep that thing in mind, and then urge all academic institutions. In Kannada, there is the saying, I belong to North Karnataka. So in last catch, I think in Mysore catch, there was some resolution that there should be one talk in Kannada. So I will end by saying one Kannada phrase, Mane geddu maar gedi anta heltare. First, you win your own home, then win the world. So if you want to win the world, if you want to bring some change in the world in sustainable development goals, bring change in your own institute and contribute yourself. And if you do that, you have all ability to bring great amount of deal to the future. So with this, I would like to thank all of you, and thanks Chairperson. Sorry, I took a bit more time, but I wanted to be I wanted to just disseminate my optimism among people sitting over here, so that let us all be optimistic in ensuring sustainable development goals, and think whether we are transferring the world to our next generation in the same way the past generation has passed it to us. If we are able to do that, we are done in achieving the sustainable development goals. Thank you very much.
Thank you, Dr. Kulkarni. I think there is very limited time for questions, but still questions, clarifications, curiosities, we can have few minutes for that. questions, clarifications? Yeah, please.
Praveen, a great presentation, very comprehensive, and having been part of the health ministry, I could relate to some of my experience there. One of the key observations I could actually make when I was there in health ministry was that the way the new scheme is implemented by a state department or a ministry is by and large very in a fast track mode. A new scheme is actually designed and implemented in about 6 months, and then scaled up in about a year's time maximum. And then with each year, there'll be a very drastic change in the way it gets done. But on the other hand, the continuum of the evidence generation and the integration of that evidence into policy in the academic setting actually is more on a slow pace. So by the time a grant is completed, the policy would have actually gone farther ahead. The whole ecosystem would have changed, and the whole context would have changed. So there is a need for actually aligning how the academic fraternity actually operates the research and other activities to the needs of the state health system and country's health priorities. And even the metrics may have to be relooked into of the faculty members and the departments. So more comprehensive, not just mere peer-reviewed publications, but also contributions in terms of the technical expertise as experts in various committees, and other even the complementary activities to the local health system could also be a meaningful contribution from either the faculty, PGs, or the department. So I think great to see such a topic actually coming up in Kachcon forums, and this actually setting conversations further ahead. All the best for everybody. Thank you.
Thank you so much. I agree to you to a great extent, sir, but I have some points.
Sure.
I actually beg to disagree for a few things.
Sure.
Academic institutions, we may consider their slow pace in implementing things, but if they understand what to implement, they implement it very fast. You ask them to change their infrastructure to realign to 250 MBBS seats, it will be done in next say three months, whole thing will be set up. Yeah. But point is making them realize it is important. Yeah. So how many of you agree that we are not doing any of them, I put in almost 25, 30 slides. Is there anyone in the hall say that we do not do all these things? We all do everything. Our basic job is to do that. But we are not putting things in frame, aligning them, connecting dots.
Yeah, I think that's what
if we make medical colleges, academic institutions learn about it and align their activities with sustainable development goals and give them the targets, they are the best one to deliver. So I can, with my experience of working 13 years in medical college, and I can easily relate it to it. So if you give them task, give them, these are all the things you need to do, they will definitely do. May not be everybody. There are some institutes which definitely come up and do a lot of good things. So I urge that the point has to be more clarified to the people, and they should be brought in the decision making and partnership for achieving the goals. Yeah,
just to continue, getting into some specifics about the very research process, maybe more and more workshops on implementation science.
Yes.
Health systems research,
yes.
Some, the new designs like adaptive trials and things like that could actually come in the training initiatives.
At this, thank you very much. Well taken. We have a provision for 2. One is Professor Pai will take, then our doctor will take.
Pai sir will not ask questions, he will bless me.
We are grateful for the hospitality, but there is a very clear thinking regarding the academic thing. Today, I'm 80, I don't have to please anybody, I don't have to pass any examination. One of the biggest things behind the scenes we are having is, AB karo, OB karo, OB karo, AB karo, AB karo, and do research. Publish papers. You are whipping a horse and telling that, bachon ko, You are talking about that particular student complaining about the teacher. The teachers say, अब हमने सभी correct करना बंद कर दिया. जाओ भाड़ में अंत. Now my basic question in the context is, your orator is fantastic. I am senior to you biologically, legally, or cosmetically. But one of the things is that institutions should go for the equivalence, or they may have to give the students that if you are a marathon runner, run a marathon. If you are a researcher, let him write papers. If he is a good teacher, don't force him to do administration. Let him not be the HOD. We need to talk more about it. There is one particular paper, WHO, which MS Ramaya had done many years ago. Prathish is evidence for it. And my Guruji is here, Gurus are here. But the question is that social accountability of medical schools, quality, relevance, equity, cost consciousness. PGs, please read the article. Thank you.
Thank you, sir. It is a matter of great debate what should be the primary responsibility and how we allocate the time for the medical college teachers. So definitely, I cannot definitely answer this question at this point in time, but I think it requires more debate. Yes. Yes. I fully, okay, as you told, I'll fully agree with you. So you need to assign the roles specifically. If someone is very good in teaching, so we should give them more opportunities to teach and excel in teaching. If somebody is more good in clinical practice, you should give him more opportunities to work. I don't say. Yes. So
Okay,
everything should be done. So
It was
proportionate.
a very energetic, enthusiastic, participatory presentation. And we were a bit worried that since it has been delayed, how will people receive? After having witnessed and you having breathed optimism in every line of yours and your explanations, we are all optimistic definitely to relate every SDG towards our healthcare institutions. Even those who had doubt that, how we will be able to relate this poverty or hunger with, we are only providing the health. Now we have all been convinced fully well that we are definitely, and we have to document, and that the missing link or the dots have to be provided. And we have got a few, 2 or 3 questions which were well answered and appreciated. With this, I think we would like to thank you and for having set up a high landmark for the other subsequent speakers to have the same energy, sustain it for the entire day. Thank you very much, sir.
Sustainable development. Thank you.
Thank you, sir, for that insightful session. Now I request Dr. Prithvi sir and Dr. Prasanna Kamath sir to felicitate Dr. Praveen Kulkarni. Now the official inaugural ceremony will start within 5 minutes. Once again, I extend a warm and cordial welcome to each one of you to Kachcon 2026. May I now request our esteemed dignitaries to kindly grace the dais.
I request all the delegates to please settle down. We're beginning the inauguration in few minutes.
I request our esteemed dignitaries to kindly grace the dais. Dr. Girish N. Rao, President, Karnataka Association of Community Health. Chief guest, Dr. Shivram C., Senior Professor and Founder President, Catch. Dr. B. Vengamma Ma'am, Vice Chancellor, SDUAHER. Dr. Muninarayana C., Registrar, SDUAHER. Dr. D. Vilan Prasad, CEO, SDUAHER. Dr. Hanumant Raju, Secretary, SDUET. Dr. Prabhagar K., Principal, Sri Devraj Aras Medical College. Dr. Rajendra, Vice President, SDUET. Dr. Mahesh, KMC Observer. Dr. Krishnappa, Medical Superintendent, RL Jalapa Hospital. Dr. Sunil BN, Organizing Committee Chairperson. Dr. Pradeep TS, Organizing Committee Co-Chairperson. Dr. Rangana TS, Secretary, Karnataka Association of Community Health. And Dr. Dayananda M, Secretary, Organizing Committee. May I request everyone to welcome our dignitaries with a warm round of applause.
This prestigious gathering brings together eminent academicians, public health specialists, researchers, policymakers, healthcare professionals, and students committed to advancing community health. The theme for this year's conference, Sustainable Development Goals, Way Forward, reminds us that achieving healthier communities requires collective action, innovation, evidence-based practice, and strong partnerships. We are honored by the gracious presence of our distinguished dignitaries whose guidance and vision continue to inspire the public health fraternity. To invoke the spirit of patriotism and unity, may I request everyone to kindly rise for the national song.
वन्दे मातरम् वन्दे मातरम् सुजलां सुफला मलयज शीतला सस्यश्यामला मातरम् वन्दे मातरम् शुभ्रज्योत्स्ना पुलकितयामिनी पुल्लकुसुमित द्रुमदलशोभिनी सुहासिनी सुमधुरभाषिणी सुखदां वरदां मातरं वन्दे मातरम् वन्दे मातरम्.
Thank you, but requesting the Assembly to please remain standing to pay tribute to our beloved state anthem, Nadagite.
जय हे कर्नाटक माते जय सुंदर नदी वन कलनाडे जय हे रस ऋषिಗಳ ಬೀಡಿ ಭೂದೇವಿಯ ಮಕುಟದ ನವಮಣಿಯೇ ಗಂಧದ ಚಂದನ ಹೊನ್ನಿನ ಗಣಿಯೇ ರಾಘವ ಮಧುಸೂದನರವತರಿಸಿದ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜನನಿಯ ಜೋಗುಳ ವೇದದ ಘೋಷ ಜನನಿಗೆ ಜೀವವು ನಿನ್ನಾವೇಶ ಹಸುವಿನ ನೀಗಳ ಸಾಲೆ ನಿನ್ನಯ ಕೊರಳಿನ ಮಾಲೆ ಕಪಿಲ ಪತಂಜಲ ಗೌತಮ ಜಿನನುತ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಶಂಕರ ರಾಮಾನುಜ ವಿದ್ಯಾರಣ್ಯ ಬಸವೇಶ್ವರ ಮಧ್ವರ ದಿವ್ಯಾರಣ್ಯ ನನ್ನ ಷಡಕ್ಷರಿ ಪೊನ್ನ ಪಂಪನ ಕುಮಿಪತಿ ಜನ್ಮ ಕುಮಾರ ವ್ಯಾಸರ ಮಂಗಳ ಧಾಮ ಕವಿ ಕೋಗಿಲೆಗಳ ಪುಣ್ಯಾರಾಮ ನಾನಕ ರಾಮಾನಂದ ಕಬೀರರ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಕೈರಪ ಹೊಯ್ಸಳರಾಡಿದ ನಾಡೆ ನಂಕನ ಜಕಣರ ನೆಚ್ಚಿನ ಬೀಡೆ ಕೃಷ್ಣ ಶರಾವತಿ ತುಂಗಾ ಕಾವೇರಿಯವರ ರಂಗ ಚೈತನ್ಯ ಪರಮಹಂಸ ವಿವೇಕರ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಸರ್ವ ಜನಾಂಗದ ಶಾಂತಿಯ ತೋಟ ರಸಿಕರ ಕಂಗಳ ಸೆಳೆಯುವ ನೋಟ ಹಿಂದೂ ಕ್ರೈಸ್ತ ಮುಸಲ್ಮಾನ ಪಾರಸಿಕ ಜೈನ ಉದ್ಯಾನ ಜನಕನ ಹೋಲುವ ದೊರೆಗಳ ಧಾಮ ನಾಯಕ ವೈದಿಕರ ರಾಮ ಕನ್ನಡ ನುಡಿ ಕುಣಿದಾಡುವ ದೇಹ ಕನ್ನಡ ತಾಯಿಯ ಮಕ್ಕಳ ದೇಹ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ.
Thank you. Please be seated.
Every auspicious beginning is made meaningful by seeking the blessings of the Almighty. May I now invite Dr. Chandida to present the invocation.
ಮೊದಲೊಂದಿಪೆ ನಿನಗೆ ಗಣನಾಥ ಮೊದಲೊಂದಿಪೆ ನೈನಗೆ ಗಣನಾಥ ಬಂದ ವಿಘ್ನ ಕಳೆ ಗಣನಾಥ ಮೊದಲೊಂದಿಪೆ ನಿನಗೆ ಗಣನಾಥ ಹಿಂದೆ ರಾವಣನು ಮದದಿಂದ ನಿನ್ನ ಪೂಜಿಸದೆ ಹಿಂದೆ ರಾವಣನು ಪೂಜಿಸತೆ ಸಂಧರಣದಲ್ಲಿ ಗಣನಾಥ ಮೊದಲೊಂದಿಪೆ ನಿನಗೆ ಗಣನಾಥ ಆದಿಯಲ್ಲಿ ಧರ್ಮರಾಯ ಪೂಜಿಸಿ ನಿನ್ನಯ ಪಾದ ಆದಿಯಲ್ಲಿ ಧರ್ಮರಾಯ ಪೂಜಿಸಿ ನಿನ್ನಯ ಪಾದ ಸಾಧಿಸಿದ ರಾಜ್ಯ ಗಣನಾಥ ಮೊದಲೊಂದಿಪೆ ನಿನಗೆ ಗಣನಾಥ ಮಂಗಳ ಮೂರ್ತಿ ಗುರು ರಂಗವಿಠಲನ ಪಾದ ಮಂಗಳ ಮೂರ್ತಿ ಗುರು ರಂಗವಿಠಲನ ಪಾದ ಭೃಂಗನೆಂದು ನವಿಪೆ ಗಣನಾಥ ಮೊದಲೊಂದಿಪೆ ನಿನಗೆ ಗಣನಾಥ ಮೊದಲೊಂದಿಪೆ ನಿನಗೆ ಗಣನಾಥ. ಥ್ಯಾಂಕ್ ಯು.
Thank you, Chandida, for that soulful invocation. To formally welcome the gathering, I now invite Dr. Sunil B.N., Chairperson of the Organizing Committee, to deliver the welcome address.
Good morning, all. I stand before you to welcome all the delegates and resource persons for the 36th State Level Conference, Kachcon. Welcome to the city of milk, silk, and world-famous mangoes. So this is the 40th year of our existence. This institution was started in 1986. So we are very happy to host 36th Kachcon in this year. So to this function, so I welcome Sri Rajendra J, Vice President of Sri Devaraja's Educational Trust. Sir will be presiding over this function. I welcome you, sir. I welcome Dr. Shivaram C., the founder president of Kachcon. Kachcon was founded in 1984. Sir was mainly responsible for getting this association. I request everyone to give a big round of applause. I welcome Hanmant Raju sir, Secretary of Sri Devaraja's Educational Trust, to this inaugural function. I welcome Honorable Vice Chancellor Dr. B. Vengama Madam to this inaugural function. I welcome Chief Administrative Officer of the Academy, Dr. D. Vilan Prasad sir. I welcome the President of Catch, Girish N. Rao sir, to this inaugural function. I welcome Secretary of Kachcon, Rangnath sir, to this inaugural function. I welcome Honorable Registrar of Sri Devaraja's Academy of Higher Education, Dr. Munnarana C., to the inaugural function. I welcome Principal and Dean of Sri Devaraja's Medical College, Dr. Prabhakar sir, to this inaugural function. I welcome Dr. Mahesh V., KMC Observer, for this 3-day event. I welcome Deputy Medical Superintendent of R.L. Jalapa Hospital and Research Center, Krishnappa sir. I welcome Dr. Pradeep T.S., Organizing Secretary of 36th Kachcon. I would also welcome Dr. Dayanand sir, the co-chairperson for the 36th Kachcon. I would also like to welcome the dignitaries of the dais, the Vice Principal, Dr. Vinita Shankar Madam, to this inaugural function. I welcome Ashwath Narayana sir for this inaugural function. I welcome Dr. Sudarshan sir for this inaugural function. I welcome Sudha Chandrasekhar Madam for this inaugural function. I would like to welcome Dr. Gangboraya sir. I welcome Dr. Kirdanya Matt sir for this inaugural function. I welcome RP Pai sir, who has been active for the past one day. I welcome you also, sir. I welcome Prithvi sir for this inaugural function. I welcome Sridhar sir to this inaugural function. I welcome Dr. Ravindra Reddy sir, Vice President of Kachcon. So I welcome all the resource persons who will be there with us for the next 2 days, and I also welcome all the delegates from various parts of the state who have made their time to be with us for the 2 days. And I would like to thank the sponsors for this event, Jagdale sir, the chief sponsor for this event, and DAMS, JP, and Marrow, who have supported us in this event. So I welcome all of you for this Kachcon 36. Thank you.
Thank you, sir, for your warm words of welcome. We welcome Dr. Sunil B.N. sir, Professor and Head, Organizing Committee Chairperson, Kachcon 2026. We welcome you, sir. May I now request our esteemed dignitaries to come forward to light the lamp. The ceremony lighting of the lamp symbolizes the triumph of knowledge over ignorance and marks the auspicious beginning of our conference. Thank you, dignitaries.
A souvenir is more than a publication. It's a lasting reflection of the vision, achievements, and collective efforts that make a conference memorable. It's now my privilege to announce the release of the Kachcon 2026 Conference Souvenir. May I request our honorable chief guest and dignitaries to come forward to kindly release the conference souvenir.
So now we have the JCBS launch. I request Dr. Kalyani ma'am to come over the dais for the launch of the JCBS. The Journal of Clinical and Biomedical Sciences, all 60 abstracts have been published. Give them a warm round of applause. Thank you, dignitaries. I now invite the Secretary of the Karnataka Association of Community Health, Dr. Ranganath T.S. sir, to present the Secretary's report.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. Good morning. Today's chief guest, Sri Shivaram sir, Devaraja's Education Trust Trustees, Vice President, VC Madam, CEO, Registrar, Principal of this Devaraja's Medical College, Kolar, senior mentors, advisors of CACH, professors and my young colleagues and dear friends. I welcome one and all for this 36th annual State Conference of Karnataka Association of Community Health. It's an immense privilege to stand before you on behalf of Kachcon, the organization that played a pivotal role in advancing the public health across Karnataka for nearly 4 decades. Our association is founded since 1984. The first conference was held under the leadership of Armugam sir and other stalwarts, Dr. Sudarshan, our today's the chief guest Shivaram sir, and many other public health senior professors. Along with us, across the Karnataka, from Bangalore to Bijapur, all the states, all the districts have hosted this annual conference regularly. This Devaraja's Medical College, it is the third conference, if I'm right. The first conference was in 1992 under the leadership of Dr. Shantaram sir. Then 2010 and now the 2026 under leadership of Dr. Sunil. This third CACH conference 2026 is organizing here. This with a growing membership of more than 1,009 life members from the day one till this. The association has nurtured the specialists who have made a remarkable contribution to building their healthier communities. The core mission is to inspire and support the next generation public health leaders. Association remains committed to provide young doctors and community health professionals, providing a platform to present their research and engage with the experienced mentors to gain the recognition and their contribution. Last year, the annual conference was held in the Gulbarga Medical College under the leadership of Dr. Ajay Kumar in the Government Medical College. There are more than 300 delegates across the country have participated and they presented the paper. In the month of March 2026, Dr. Balu from the Subaya Medical College has conducted the PG refresher course called Sparkle for the young budding doctors. It was a wonderful experience felt by our public health trainees. CACH being an academic body in Karnataka, it was a partner with Swami Vivekananda Youth Movement, Sargur, Mysore, in association with the CACH, was part of this pediatric TB mentorship program in Mangalore, Dakshin Kannada, Mysore, and Tumkur districts. Some of our CACH members were part of this initiation in organizing this. Association, along with ICMR and NIMR Bangalore, has observed this World Malaria Day in the month of April 2026. There are more than 60 public health trainees were attended, and they felt it was very good field workshop for the public health, good exposure. Catch has initiated the Best Thesis in the Community Medicine Karnataka Award to encourage more budding community physicians to do more field research. Achievement of Catch are reflection of this dedication and the hard work of our members. As we look towards the future, Catch remains committed to leading in the way in a community, encouraging innovations and advocating for healthier communities across Karnataka. Lastly, I would like to express my heartfelt gratitude to the organizers for giving opportunity to address you all and for your unwavering commitment to the public health. Together, we can create a lasting impact, and I'm confident that this Kachcon 2026 will be a inspiring and empower future generations of this public health. I'm sure this 3 days event will be a very good academic feast for all the delegates who are attending this year. I thank you once again. All the best. Thank you.
Thank you, sir, for presenting the report. Recognition inspires excellence. May I now invite the chairperson of the Catch Awards Committee to announce the prestigious Catch Awards.
Good morning to all, dignitaries on the dais, off the dais, and friends. I think it's a very big honor for me to announce here, being the chairman of the Catch Award Committee. Catch Executive Committee gave us the mandate to identify the awardees, and Dr. Ravindra Reddy, myself, the chairman, Dr. Rangnath, secretary, himself was the secretary for the awards committee, Dr. Renuka, principal of Saptagiri Medical College, as another member, Dr. Ramesh Masti, Professor and HOD of KIMS Bangalore, was also member of the committee. Dr. Malte Shundi from Karwar Institute of Medical Sciences, also member of the committee. It was a big challenge because now Catch has grown so well and community health professionals have grown so well, from the erstwhile preventive and social medicine to the current community medicine and so many other areas of development and young budding and senior people. In presence of the founding pillars of Catch, Dr. M.K. Sudarshan and Shivam sir, I'm sure we have made our efforts, have done some justice, though it was a challenging, many contestants were there. So we followed a very strict way of selecting the awardees, awards, members for the award, and we followed various parameters for various awards depending on the awards. So the first one is the Community Health Professional Award. So we went through all the members, senior people, we got so much and contributed to the community health and the profession, and we shortlisted unanimously one person. Similarly, for the Oration Award, again, we have gone through various members and their strengths and other things and contribution, and we selected. And also Silver Jubilee Award for Community Health Practitioner. Again, this was a selection-based, this one, usually an NGO or a person who has contributed humanly for the service, but at the same time, we look at the region, around 4 or 5 districts in the region where the Catch conference is held. And then, of course, there are 2 awards, Young Scientist Award and the Best Dissertation. As Dr. Rangnath has mentioned, this year Catch has introduced the Best Dissertation Award for community medicine, dissertation in community medicine or public health. So that is a new one. So here we followed a strictly blinding pattern, and then whatever marks we got based on that we selected. Whenever there was a tie, we added one more criteria, that is contribution to the Catch activities and involvement in the Kachcon conferences was additional criteria where there was a tie. Then of course we had a challenge in selecting the very nice awards called Catch Community Champion Awards. So we looked at various criteria, one from the local, from the district where the Kachcon is being held, so the persons who are contributing to the community health activities there. Then coming to the institution and organizations from the field of medical colleges. Then we also looked at those from the government of Karnataka and government of India and central government and other agencies and NGOs where a lot of service has been done in the community, field of community health. So there's also we have committed. And then we had a last award, which is actually instituted by KIMS Bangalore, Kempegowda Institute of Medical Sciences, called Catch Sachin Menon Award. Basically, this was an award instituted by KIMS Bangalore, where in memory of a young budding doctor who was lost his life in the line of duty during pulse polio activity in an accident. So the KIMS Bangalore has instituted Sachin Menon Award. So that goes to automatically the best outgoing community medicine student of the college organizing the Kachcon conference. That is now, this is Sri Devaraja Medical College, Kolar. So now I will call one by one, and then I will request the persons to escort and introduce. So the Catch Community Health Professional Award. This was very important thing, prestigious award, and we had a very tough time to select, but at the same time, we had a very easy person to select also. So the Catch Best Community Health Professional Award goes to Dr. S. Prithvish. So you can see in the slide, Dr. Prithvish, it is really difficult. It's really difficult to introduce Dr. Prithvish in one slide, show his achievements. Small account, you can see there. He has done MBBS from Mysore Medical College and MD from Karnataka Medical College, Hubli, where Dr. Shivaram himself was the guide for Dr. Prithvish, and I am also from KMC Hubli. So that's, even RP Pai also I am sure from KMC Hubli. So he has also done DNB, also contributed to primary health care in Kolar district itself, food and hygiene, social accountability in medical colleges, safe motherhood, survival, and community-based rehabilitation for people with disabilities, a lot of activities in non-communicable diseases, and he has also 2 books published, more than 60 publications. Previously, in 2008, Catch BM Patil Varation Award also was received by Dr. Prithvish. He is also Fellow of Indian Society of Hospital Waste Management, Fellow of National Academy of Medical Sciences, and Devaraja Arts University is also Professor of Practice Award he has received. And there are so many other things which you can find out with him. Give him big hands. We know that he himself is a 3-4 generation teacher, but he is student of a doyen called Dr. Shivaram sir. So that was in the same conference, sir. Next award is the Catch Silver Jubilee, Sri BM Patil Varation Award. And this, of course, we had a lot of contenders for this. And we shortlisted one person who has done a lot of activities, who is also identified as top 3 years back, top 2% scientists in the world, actually. None other than Dr. Unni Krishnan, the Dean of Kasturba Medical College, Bangalore. I request Dr. Shashidhar to escort and introduce Dr. Unni Krishnan. Unni Krishnan, change the slide. Next slide.
Respected dignitaries and delegates, good morning to all. It gives me an immense pleasure and a great sense of privilege to introduce Dr. B. Unnikrishnan sir. So Dr. Unnikrishnan sir is currently serving as the Dean and Professor in the Department of Community Medicine at Kasturba Medical College, Mangalore, which is a constituent unit of the prestigious Manipal Academy of Higher Education. He is an accomplished academician, researcher, and administrator whose contributions have had a significant impact on the fields of public health and medical education, both nationally and internationally. He holds an MD degree and has been conferred the Distinguished Fellowship of the Royal College of Physicians, Edinburgh. Dr. Unnikrishnan sir serves as a member of the Expert Committee of the National Medical Commission, and he is the chair of the Independent Ethics Committee of the College of Association of Minimal Access Surgeons of India. In addition, he is a basic medical scientist member of the Institute Ethical Committee of the Central Health Education Bureau under the Directorate General of Health Services, Government of India, and an advisory committee member for the Center for E-Learning at the Public Health Foundation of India. Unnikrishnan sir is having an extraordinary scholarly work. He has authorized more than 364 scientific publications, has an impressive H-index of 60, holds 3 patents, and has secured over 20 copyrights. He has also mentored more than 10 PhD scholars. His major research interests include evidence synthesis, health policy, and global health. Dr. Unnikrishnan sir is also deeply involved in advancing medical education in India. He is actively collaborating with the National Board of Examinations in Medical Sciences in developing a series of faculty development programs. It aimed at strengthening medical education in India. In recognition of his remarkable contributions to medical education, he received a certificate of appreciation from NBEMS, which was conferred in May 2024. He has been awarded fellowships from the Sparkman Center of Global Health, University of Alabama at Birmingham School of Public Health, USA, Department for International Development, UK, South Asia Cochrane Center at CMC Vellore, India. So Unnikrishnan sir career exemplifies excellence in public health research, evidence-based medicine, ethics, health policy, and medical education. We are truly fortunate to have such a distinguished expert with us. So sir has received the Sir 3 B.M. Patil Oration Award. Thank you, sir.
After the inauguration, there will be Dr. Unnikrishnan will be delivering the B.M. Patil oration. Please attend all of that and listen to that. And now goes to the next award, Catch Silver Jubilee Award for a community health practitioner. This is given to NGO after doing a lot of research. The name of the NGO is Samarthanam Trust for the Disabled, which is located in HSR layout in Bangalore. I request Dr. Maltesh Undi to escort Desh Pandey, the Chief Operating Officer of Samarthanam Trust.
It's my privilege to introduce the Silver Jubilee Award for Community Health Practitioner, which is given for the NGO Samarthanam Trust. Samarthanam Trust works for the empowerment of persons with disabilities and the underserved through its diverse initiatives. Empowering persons with disabilities through inclusive education, skills, livelihood, and dignity, building an equal world. Established in 1997 by the visionary Dr. Mahantesh G. Kividasannavar, Samarthanam was founded on a simple yet powerful belief that every individual, irrespective of disability or socioeconomic background, deserves the opportunity to learn, earn, and live with dignity. Over nearly 3 decades, Samarthanam has grown into India's most respected non-profit organization, touching millions of lives through transformative initiatives in education, skill development, employment, healthcare, women empowerment, rural development, accessible technology, arts, culture, and sports for the persons with disability. It is also proud to hear that they are part of the World Blind Union and also received the special UN consultative status in 2015. So a huge round of applause to the NGO that received the award today.
In fact, when I went to Samarthanam Trust Chief Executive Officer to inform the selection for the award, they were seriously surprised when we have not applied. So something receiving without applying is the biggest recognition. That was Samarthanam Trust.
Thank you, sir. Thank you. Thanks for the opportunity. Thank you, sir.
Please go. So next award is Catch Prolific Community Health Literary Award, and that goes to Dr. Mohammad Muntazim. I request Dr. Manjunath to escort and introduce Dr. Muntazim.
Good morning, all the dignitaries on the dais and of the dais and all the delegates. It's my pleasure to introduce Dr. Mohammad Muntazim ji, who has done his UG, PG, and now is a staff in SSIMC in Davangere. He has published more than 40 plus community health articles in Kannada, regional newspapers, making public health accessible to the community. Covered a wide range of topics, including nutrition, immunization, communicable and non-communicable diseases, cancer prevention, and health and promotion. Promoted evidence-based health awareness through simple, culturally relevant writing in the regional language Kannada. And he has addressed important public issues, and also is an active Catch member, recognized for his sustained contribution to the community health literacy through the regional language Kannada. Congratulations to you, sir.
Next award is Catch Dissertation, Best Dissertation in Community Medicine or Public Health, and that goes, that goes to Dr. Savinita Prakash. I request Dr. Ramesh to escort and introduce Dr. Savinita Prakash.
Yeah, good morning. The prestigious Best Dissertation Thesis in Community Health, Catch 2026, awarded to Dr. Savinita Prakash for the thesis topic titled Development of a Comprehensive Antenatal Risk Assessment Tool and Assessing its Effectiveness in the Field Practice Area. She finished her MD Community Medicine from St. John's Medical College 2025. Currently, she is working as a consultant, Community Health Division, Baptist Hospital, Bangalore. She is an RGHS Gold Medal winner for the year 2025, and her main areas of interest is palliative care and qualitative research. Congratulations, Dr. Savinita Prakash.
The next award is the much awaited, the Emerging Community Health Professional called Catch Young Scientist Award in Community Health, and that goes to Dr. Prachet R. from Nimans. I request Dr. Girish to escort and introduce Dr. Prachet.
I'm very happy to introduce Dr. Prachet. He is receiving the Young Scientist Award in Community Health. So he has done his MBBS, MD, DNB, AMS, and also PG Diploma in HSM. So his key contributions and key areas of work is in the maternal mental health, health system research, and also NCDs. So he has worked as a principal investigator for 10 funded projects and also co-investigator for 15 projects. He has received grants from the ICMR, MOHFW, and several other agencies, and author of 65 publications in index journals and 8 intervention manuals, and also 4 book chapters. Conducted more than 70 academic programs as member of organizing team, including 15 as organizing secretary. So as 41 paper presentations in the conferences and delivered around 150 talks as resource person. He has received many awards, like 20 awards, notably being the Best Paper Poster Awards in 14 conferences, and IAPSM Young Leaders Oration Award, Presidential Appreciation Award, and also the member of National Academy of Medical Sciences and IJCM Ford Foundation. Congratulations, Dr. Prachet.
Thank you, Dr. Girish. So now goes the 5 awards in the group. What we have, the Catch Community Champion Awards. So here different areas of operation. We have selected 5 people. The first is Catch Community Champion Award to Dr. Gautam. He has done a lot of activities in accidents and others. I request Dr. Anantram to escort and introduce.
It's my privilege to introduce an extraordinary public health leader and policy champion whose tireless efforts over the past 2 decades have reshaped injury prevention and occupational health in India and across Southeast Asia, Dr. Gautam Melur Sukumar. He is a professor of epidemiology and academic faculty coordinator at the National Institute of Mental Health and Neurosciences, NIMHANS in Bangalore. He also serves as the head of the WHO Collaborating Center for Injury Prevention and Safety Promotion and is a distinguished member of the India's National Road Safety Board. After earning his MD in community medicine as gold medalist, he specialized further in global road safety leadership and injury prevention at Johns Hopkins University and Delft University, Netherlands. He has spearheaded more than 25 major research projects. He's partners with global bodies like WHO, UNICEF, and Johns Hopkins, instrumental in crafting national action plans for child and adolescent road safety. His studies have informed traffic enforcement and mass media road safety campaigns in Bangalore. The Lay Responder Care program developed by his team is currently being used to train police personnel across Karnataka as well as university students. He led the development of India's first national multi-sectoral action plan for child and adolescent road safety and led the development of WHO Southeast Asian Strategic Framework for Unintentional Injury Prevention. He has over 60 scientific publications and 30 technical manuals. He is not merely an academic, also saves lives every day on our roads, in our schools. So please put your hands together for Dr. Gautam Melur Sukumar.
Thank you. Yeah. Next, the Catch Community Champion Award next to the NGO sector goes to Dr. Sudhashri. So I request Dr. Seema to introduce Dr. Sudhashri.
Good morning, one and all. It's my privilege to introduce Dr. Sudhashri, who is my senior also. Dr. Sudhashri has completed her MD from KIMS Bangalore and PhD in Health Economics from London School and Hygiene and Tropical Medicine, International Masters in Health Economics, Papua Fabra University. She has got distinction for the same. PG Diploma in Medical Law and Ethics and Fellow Faculty in the Public Health UK from 2024. And she has many achievements like LED-led policy design for PMJ and then Global Health Leadership Award from Canada, Fellow Faculty of Public Health UK. Now, presently she is working as CEO of Swasti since April 2026, Senior Consultant for World Bank since 2018, Advisor for Health System Transformation Platform since 2018, Executive Director for Health, Policy and Hospital Engagement, National Health Authority, MOHFW, Government of India from 2021 to 2023, Director Medical for Suvarna Arogya, Suraksha Trust, Government of Karnataka, 2015 to 2018. Many more she has achieved. In short, I have briefed about Dr. Sudhashri. Thank you all.
Next, the Catch Community Champion Award from the Medical Colleges section goes to none other than Dr. Sunil, the organizing chairperson of Catch 2026 from Sri Devaraj Arsu Medical College, Kolar.
So, good morning, one and all. So, I'm happy to introduce Dr. Sunil BN, Professor and Head, Department of Community Medicine, SDUMC Kolar. Dr. Sunil worked as trainer of trainers for routine immunization training of medical officers. He worked as COVID nodal officer at RL Jalappa Hospital, Kolar. He worked as a resource person for FAP Autis e-logbook implementation, co-investigator for SANS, COG and NIMANS NHSCON project. He has worked in public health monitoring of various national programs. Thank you all.
The Catch Community Champion Award from the field, Community Health, selected Dr. Channakeshava from Malur, Community Health Center, Malur. He has done a lot of work during the COVID period and afterwards. I request Dr. Anvit to introduce Dr. Channakeshava.
I'm happy to introduce my friend Dr. Channakeshava, MBBS from Chinchingiri Medical College, MSc from the Siddhartha Medical College, Tumkur. Sir, being a ENT specialist during the COVID time, his work was excellent. Being this role model, he is the one who started with taking this throat swab and other things. And during this, any emergencies, either landslide or any other disasters in the state, so through this Government of Karnataka Health and Family Welfare Department, his sir was the first person to move. And through the bike is traveled from Kanyakumari to Kashmir for this creating awareness. And his age maybe 54, 55, he's double this, maybe he's more than 75 times he has donated his blood, and being the role model in this Kolar district is highly appreciated. He's more than 75 times he's donated blood. I'm happy to introduce my friend. Thank you.
And from the Ministry of Health and Family Welfare, Government of Karnataka, who has done a lot of service for TB for more than 20 years, the Catch Community Champion Award from the Government of Karnataka sector goes to Dr. Anil S., Deputy Director of Tuberculosis, in charge most of the time, in charge of Joint Director TB, currently is there as a general physician, and a lot of mentorship he has done. I request Dr. Shashi Kiran, classmate, and incidentally, Dr. Anil has done MBBS from Sri Devaraja Arsu Medical College. Classmate Dr. Shashi Kiran is going to introduce.
Good morning, all. It gives me great pleasure to introduce my friend for the last 4 decades, Dr. Anil. I recall my good memories in this college, where we traveled together from KGF to Kolar almost 4 years. First batch student here in '86. So Dr. Anil did his MBBS from here, and his MD General Medicine from MMC, Mysore, and has been in the government sector ever since. So his activities, his achievements are very, very long. I'll just cut it short, and in short, I'll introduce him to you. So he's been the Deputy Director of TB Control Program, Joint Director, Karnataka State's AIDS Prevention Society, establishment of Karnataka DR TB Program, Joint WHO Mentoring Mission member, and contribution to National Trainer for Airborne Infection Control NTP, and Distinguished Alumni Award, Best Deputy Director, Government of Karnataka, COVID Appreciation Award 2021, invited faculty at 60 plus CMEs, national conference and medical college across India. In short, I can't read the whole list, it's endless, but in short, I introduce Dr. Anil, a good student of this college, the first batch student. Congrats, Dr. Anil.
Dr. Anil has walked through revised National TB Control Program, and now National TB Control Program, starting from DOT strategy to Stop TB strategy, now the NTB strategy. All of them he is a real expert. The last award, Catch Sachin P. Menon Award, goes to Kumari Nisarga A.S. of Sri Devaraja Arsu Medical College, Kolar. So incidentally, she is the best outgoing student, therefore she is also busy in the examinations. You can ask someone? We request Madam Vice Principal to receive the award on behalf of your wonderful student. As I said, this was instituted by Kempegowda Institute of Medical Sciences in the name of P. Sachin, who really lost his life in the line of duty in the community health. Thank you very much. That ends the award ceremony. Now we'll request the MCs to take forward. Thank you.
Congratulations to all the distinguished awardees. Your dedication and contributions continue to strengthen community health and inspire generations of public health professionals. Now, I invite Dr. Prabhagar K., Principal, Sri Devraj Aras Medical College, to address the audience.
Good morning, everyone. Respected chief guest, distinguished dignitaries on the dais, eminent faculty members, delegates, postgraduate students, ladies and gentlemen. A very warm good morning to all of you. It is my privilege and honor to welcome you to the State Conference of Community Medicine, Kachcon. I extend my heartfelt greetings to all the delegates who have gathered here from different institutions across the state to share the knowledge, experiences, and innovations in public health. Community medicine is the bridge between the clinical medicine and society. It reminds us that the true success of the healthcare is not measured merely by the treatment of the disease, but by the prevention of illness, promotion of health, and improvement of the quality of life of every individual. The specialty plays a pivotal role in addressing today's healthcare challenges through epidemiology, health education, disease surveillance, health policy, and community participation. India has made remarkable progress in reducing the maternal and infant mortality, controlling the communicable diseases, and strengthening immunization and primary health care. At the same time, we face new challenges such as non-communicable diseases, mental health disorders, antimicrobial resistance, environmental pollution, climate change, and emerging infections. These demand multidisciplinary collaboration, evidence-based policy making, and innovative public health strategies. Medical colleges have a vital responsibility in producing socially accountable doctors. Community medicine departments are at the forefront of shaping future physicians who understand not only diseases, but also the social, economic, environmental, and behavioral determinants of health. Research conducted in our communities should translate into policies and inventions that benefit the society. I am very much confident this conference will provide an excellent platform for exchanging ideas, presenting quality research, discussing best practices, and fostering collaborations among the academicians, public health professionals, policy makers, and students. I encourage all students, especially our young postgraduate students, to actively participate in the scientific deliberations and make the most of this academic opportunity. As teachers in the medical college, we have responsibility that extends beyond imparting medical knowledge. We should strive to inculcate patriotism, integrity, compassion, and spirit of selfless service in our students, so that they become not only competent doctors, but also responsible citizens. We may not be great industrialists like Tata or Birlas, contributing to nation building through vast enterprises. Yet, like humble squirrels in the Ramayana, whose small but sincere efforts helped in the construction of Ramasetu, each one of us can make a meaningful contribution to our nation's progress. By sharing the knowledge generously, inspiring ethical practice, encouraging community service, and nurturing empathy for the underserved, we can shape generations of doctors who will strengthen the health and well-being of our society. Every sincere effort, however small it may seem, becomes a valuable contribution to the larger mission of nation building. I sincerely congratulate the organizing committee and the Department of Community Medicine for their meticulous planning and dedication in organizing this conference. Your hard work will undoubtedly make this event a memorable academic success. I wish the conference fruitful deliberations, meaningful interactions, and great success. May the knowledge shared here inspire innovative solutions for improving the health and well-being of our communities. With these words, it is my proud privilege to formally inaugurate the State Conference of Community Medicine. Thank you. Jai Hind.
Thank you, sir, for your inspiring words. May I now invite Dr. Muninarayana C., Registrar, SDUAHER, to address the audience.
Good afternoon to everyone. Dignitaries on the dais. Dr. Shivaram is a founder of the Kachcon and is a senior teacher, and all the other dignitaries on the dais, my teachers and delegates and friends. So it is a privilege moment for us to host the Karnataka Association of Community Health Conference in our institute. So I thank the Kachcon President and the Secretary for permitting us to conduct the conference in our medical college. I being the first student of this medical college, and as the Kachcon was approved for our institution, and we thought of having the theme for the conference is the Sustainable Development Goals. And as you all know that now, as Dr. Praveen highlighted in the morning session, that in all the rankings, it may be a NIRF ranking or the NAC, everywhere this is coming in a big way to all the educational institutions. So in that directions, we thought of hosting the conference on this main theme, and we have many speakers, experts in that field, so that we can gain the knowledge and implement whatever it is possible from our end. So in that directions, we have made the efforts. And last year, we have applied for the Times Impact Ranking. That is the global ranking. So in that, we could achieve some ranking points. Mainly in the good health, that is goal 3, we achieved 300 plus score. And global ranking, it was 1,500. And we have applied for the other few goals also. So there also we have scored about more than 1,000 plus ranks. So that is the first step in the this SDG goals initiative. And we have applied for the NIRF ranking also. That is the SDG ranking under the NIRF also we have applied it. And now we have given all the data to this one. And we may get some encouraging results in that also. So once again, I thank all the members of the CATCH for providing us the opportunity to host the conference. And so wherever there is some lacunae or there are some issues, kindly let us know, and we will try to rectify those things, and we'll have to have a better coordinated activity. So once again, thank you one and all.
Thank you, sir. May I now invite Dr. Divyalan Prasad, CEO, SDUAHER, to address the audience.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. At the very outset, seeking divine blessings from the great departed soul, Sri R.L. Jalapaji, the great visionary leader and founder of these great institutions, most respected Madam Honorable Vice Chancellor of the Academy, today's chief guests, Dr. Shivaram, Vice President of the Trust, Sri Rajendra, and Honorable Secretary, Sri Hanumant Raju sir, and all the other esteemed dignitaries on the dais, and other invited dignitaries, scientists, community medicine, learned faculty members, and academy faculty members, students, invited guests, press and media people. Very good afternoon to one and all. Really, it is a great matter of mine to share the dais along with these esteemed dignitaries and associate myself with all of you who are sitting in front of this dais on this inaugural ceremony of 36th Community Medicine State Level Conference being conducted in this esteemed organization today and tomorrow, focusing on the important global theme, Sustainable Development Goals. My dear all of you know, these Sustainable Development Goals adopted by United Nations in 2015, and these are the global goals aiming to achieve a healthier, equitable, sustainable world by 2030. These are the 17 goals are there. Out of these 17, goal number 3, Sustainable Development Goal 3, fine health and well-being is most important one, and it is a centric among all the 17 goals. Why? Because health forms the basic foundation upon which all the progressive dimension developments rest on. Just my dear colleagues, all of you know, community medicine plays a pivotal role in achieving all these sustainable development goals. And all of you know the factors like prevention of health disease, promotion of health care, immunization, nutrition, sanitation, safe drinking water, protection of environment, and community association are the basic pillars of primary healthcare system. Strong primary health care is essential for SDG 3, not only for that, and it is also essential for the goals with respect to poverty education, clean water, and decreased inequalities and climatic changes, climatic actions, etc. My dear scientists and community medicine professionals, all of you agree with me. There are drastic changes with respect to the climate and emerging investigations and antimicrobial resistance, non-communicable diseases, and environmental pollution demands multidisciplinary collaboration. My dear faculty members, you are the community medicine people, has to work closely with the government bodies, NGOs, private bodies, educational institutions to provide a resilient healthcare system in the society. Another important thing, my dear colleagues, medical colleges in the country have to give the center of excellence with respect to community engagement by introducing meaningful research, by strengthening the primary healthcare system, and to provide committed, well-trained healthcare professionals to the needy society. Apart from this, new technologies like artificial intelligence, telemedicine, and disease surveillance, digital medical records can progress the way towards the global health coverage while ensuring no one is left behind. So, my dear members who are here, this 2 days conference definitely will give a strong platform for exchange your ideas with respect to research, innovations, community strategies, and create a dent in creating the new innovative technologies to the needy society. I cordially welcome all the resource persons who came all over the state and have a comfortable stay with us today and tomorrow. Definitely your interaction, scientific deliberation will enrich our knowledge in creating the finest and fruitful collaboration with your institution. I wish this conference is going to be a grand success one, and I take this opportunity to extend my heartfelt thanks to the Community Medicine Department of this institution, who extend their kind invitation to me as a part of today's event. I wish you all the best, wish you a grand success. Thank you, one and all.
Thank you, sir, for those enriching words. Now I invite our respected Vice Chancellor, Dr. B. Venkama ma'am, to address the audience.
Good morning to everybody. Honorable Chief Guest today, Dr. Shivram C., who is the founder president of Karnataka Association of Community Health, and distinguished dignitaries, Dr. J. Rajendra, Vice President, Dr. Hanumantaraju, Secretary, and Dr. Girish N. Rao, President of the Association and Professor of Epidemiology at NIMHANS, Dr. Ranganath T.S., Secretary of the Association, Professor of Community Medicine, Bangalore Medical College, my all other colleagues on the dais, and the organizing people, Dr. Sunil, Dr. Dayanand, and Pradeep, and distinguished faculty, esteemed colleagues, and public health professionals, my dear postgraduate students, ladies and gentlemen. It's really a privilege and matter of great satisfaction to be the part of this association. I would like to congratulate the organizers of our Community Medicine Department for taking third time this 36th conference to organize in our campus with an important theme, that is Sustainable Developmental Goals, the way forward. Like already mentioned, that today we are not merely discussing those 17 global goals, we are discussing the future of the humanity. We are discussing whether every child born in a remote village of Karnataka will have the same opportunity to live as a healthy life as was born in Bangalore. We are discussing whether economic progress can coexist with environmental sustainability. And we are discussing with whether development can truly be called development if it leaves behind the poor, the marginalized, and the vulnerable. That's why the Sustainable Development Goals are not simply a United Nations agenda which was done in 2015. They are, I feel, is a moral commitment to humanity. Like already mentioned, from Millennium Goal, there is change of names in the Sustainable Developmental Goals. But Millennium Developmental Goals have also taught us valuable lessons. They help the world to reduce the poverty, improve the maternal and child survival, and expand the access to education. Yet they also relieved uncomfortable truth. Development cannot occur in silos. Health cannot improve without education. Education cannot flourish without nutrition. Economic growth cannot be sustained without protecting the environment. Gender equality cannot be achieved without social justice. Thus, emerge the Sustained Development Goals, an integral blueprint that recognizes the interconnectedness of human development. That's why SDGs remind us that everything is connected. Health dependent on agriculture, agriculture dependent on climate, climate dependent on responsible consumption. Responsible consumption again depends on education, education depends on equity, and equity ultimately depends on governance. Health is not the only goal among the 17, of course, being the good health and well-being, that is, health is common thread that binds all the 17 together. Basically, there are 3 challenges before us. What we need is a malnourished child cannot learn, an unemployed adult cannot afford health care. But there are 3 challenges before us. One is the epidemiological transition with the non-communicable disease accounting for the majority of the death. Second is the demographic transition, where aging population demands long-term and comprehensive health care. Third is the climate transition. Perhaps the greatest public health threat of the 21st century is the climate transition. That is heat waves, floods, droughts, changing vector ecology, declining food security, antimicrobial resistance, mental health consequences are redefining public health priorities. That's why the way forward, I think what we should look for this 2030 is for a sustainable development goal. We have to reimagine the primary health care. Primary health care should no longer be viewed merely as a first point of contact. It should start with preventive, promotive, rehabilitative, palliative, and digital health care. And we should invest in prevention because the future belongs to prevention. Every preventable disease represents the failure of public health. And the third is leveraging technology with equity, that is artificial intelligence, predictive analytics, genomic surveillance, telemedicine, wearable technology, drones, digital health records. The fourth point is the climate and resilient health systems. Climate change is no longer an environmental issue, it is a health emergency. Every district health plan should incorporate climate preparedness. The fifth part is the partnership for sustainable development. Governments alone cannot achieve the sustainable development. It has to be from the academia, industry, local self-governments. Every stakeholder must be a partner. Basically, to say that to 2030, that sustainable goals is the year is no longer a distant milestone. It is approaching rapidly. History will not ask whether we knew the sustainable development goals. History will ask whether we acted upon them, whether we reduced inequalities, whether we strengthened primary health care, whether we protected our environment, whether we ensured that no individual has denied opportunity to live a healthy and dignified life. As a public health professionals, everybody should, knowledge creates the responsibility, responsibility demands the action. Let this conference become more than an academic event. Let it become a platform for partnerships, and it should be a catalyst for innovation, a forum for evidence. Above all, a movement towards a healthier, more equitable, more sustainable community. I leave with you the timeless words of Mahatma Gandhi, who said, "The future depends on what we do it in the present." Let us therefore work together with science as our compass, compassion as our strength, and sustainability as our destination. Let us build not only a healthier Karnataka, but healthier India and healthier world. I once again thank the organizers for giving me this opportunity, and I would like to congratulate all the award winners for their commitment in this area, and I wish this conference a grand success. Thank you. I just wanted to mention that I think this conference had started very good beginning yesterday, and there was a very good 6 pre-conference workshops. I personally attended 2, that is, one is the leadership in public health. Another one is immediate care for the psychological events and emergencies for health professionals. It was conducted very well. I once again thank the scientific committee of the conference for organizing this wonderful, useful, sustainable program. Thank you.
Thank you, ma'am. It is now my honor to invite Dr. Girish N. Rao, sir, President of Karnataka Association of Community Health, to address the gathering.
ಗುರು ಹಿರಿಯರೇ ಹಾಗೂ ಆತ್ಮೀಯರೇ ಎಲ್ಲರಿಗೂ ಆದರದ ನಮಸ್ಕಾರ. At the outset, permit me to compliment all the awardees once again and thank you for consenting to be felicitated by Kach. We celebrate this academic and scientific feast at the 36th annual conference of the Karnataka Association of Community Health. Respected dignitaries, the Karnataka Association of Community Health was initiated in 1984. It then pioneered and since then supported, catalyzed, encouraged young in age and young in minds to channelize their passion, share their achievement in a very global manner, global plus local manner. We continue this journey, and I humbly salute and offer my respects and regards to all those who made it possible. One such person is sitting on the dais today, Professor C. Shivram, my mentor. I just remember Mahatma Gandhi's message. Mahatma Gandhi saying, "My life is my message." Sir, you have been a model and a look up to person for all of us who are sitting in this audience. Our sincere and humble pranam, sir. There are several such dignitaries and doyens in front of us today. Professor M.K. Sudarshan, who led the Karnataka COVID Task Force. Tomorrow we'll be having Dr. Suresh, who led the UNICEF, Dr. Rajanna, who is very famous for his writings, Dr. R.P. Pai, who reaches out to all the youngsters, UG, PGs, and GB sir, who is busy with his laptop. Sir, thank you for that average decisions. Dr. Unni Krishnan, Koradhyanamat. I think let's give a standing ovation to all these community health professionals of Karnataka who have been doing this yeoman service. Please join me in giving them a big hand. Dignitaries on the dais, community health professional, bridge the gap in treating at the hospitals and working for public health. We apply the art and science in organizing community and societal efforts for the larger well-being. Thus, the theme of the conference, Sustainable Development Goals Way Forward, is more than apt. Health cannot be seen in isolation. Health and development of any sorts go hand in hand. We cannot have development sans health, and development is a determinant for health. Today's inaugural event is a witness to this collaboration of a whole of a society approach. The Devarajaras Medical College and the Kolar District Administration have mutually engaged in serving the larger cause of well-being of the society, particularly to reach the unreached. I'm reminded of the outreach camps, the mental health services which the SDUMC has been partnering with the district administration. Kolar not just gave us gold to the country, but also set the street lights at a time when it was not heard globally. I will not be able to list several of the models which have come out from the district of Kolar, the Digital Information Nerve Center, the SANSCOG, Yuva Spandana, Karnataka Brain Health Initiative, NHScan, and many more. For us at NIMHANS, Kolar is the public health observatory where we initiate programs, understand what works, and learn how to make it work. Our MPH alumni have been doing yeoman services. These are people in the field in Kolar. The dynamic Jagdish, enthusiastic Chandan, charged up Charini, shotgun Vasant, Vector Sharif, silent Ramesh, and many more people who are already in the field in the government service in the district of Kolar. Yesterday, Dr. Charini was mentioning about a program which is running in Kolar, the RRR, that is reassess risk, reduce the time delay, and then respond swiftly. This is one of a unique program for mental health, maternal initiative in the district. And her foray to have an MOU between RLJH and the district administration so that any women who comes at an emergency is not attended to at any point of time. On this August occasion, as President Kach, I would like to propose a tripartite working strategy between district administration, Sri Devarajar's Academy of Higher Education and Research, and Karnataka Association of Community Health. 1, to develop case studies. 2, to build models of care. 3, innovate service delivery. We have a galaxy of experts led by Professor Vengamma, Vice Chancellor. We have got Dr. Prasad, we have got Dr. Prabhakar, we have got Dr. Munina Raina, and from the administration, district administration side, Dr. Srinivas, who is the DHO, Dr. Sharif, who is the district surgeon, and obviously the Kach family. Let's make this opportunity, this potential what is in front of us, a definite possibility. A personal note at the end, a note of gratitude and appreciation to Professor Vengamma. Madam, thank you for staying back to be with us at the inauguration. Thank you very much. Jai Hind, Jai Karnataka.
Thank you, sir. It is now time to welcome our esteemed chief guest, Dr. Shivram, sir, Senior Professor and Founder, President of Kachcon, whose distinguished career and invaluable contributions have significantly enriched the field of public health and healthcare. We have the privilege of inviting Dr. M. Dayananda, sir, Organizing Secretary, Kach Conference 2026, to introduce the chief guest.
Respected dignitaries on the dais and off the dais, and my dear friends. So it gives me a great privilege to introduce Dr. C. Shivram, who is my mentor and guru. So that is a proud privilege for me today to introduce him. So Dr. C. Shivram was born in the year 1940, and he has got MBBS degree in the year 1964 from Mysore Medical College, that is University of Mysore. And then he got his MD, P&SM and Community Medicine from King George Medical College, Lucknow, in the year 1970. And sir has worked in various medical colleges in Karnataka for 23 years. And also he has served as the Deputy Director of Medical Education. And also he has served as the Director of Research at Rajiv Gandhi University of Health Sciences, Bangalore. And also he has got various publications. He has got about amounting to about 45 to 50 publications he is having. And then he is also the life members of many organizations. And he was also the principal of MS Ramaya Medical College for 8 years, and principal of Vaidehi Institute of Medical College for the period of 2 years. And he is also the UNICEF coordinator. And these are his achievements. There are many more achievements are there, but for the constraints of the time, these are the achievements we are going to list on in his name. Thank you, sir.
Thank you, sir, for the inspiring introduction. We now request the dignitaries to come forward to felicitate the chief guest.
Thank you, dignitaries. With great honor and immense pleasure, may I now invite our distinguished chief guest, Dr. Shivaram sir, to kindly address the gathering.
My address is 2142 Shobha HRC Prestige, Jakkur, Bangalore. But since she has asked me to address, I've given it to you. Well, dignitaries on the dais and off the dais, and the delegates and my dear friends. I'm not able to understand how this old man was selected to be the guest of honor today. I was not very sure that I'll be attending the conference. I kept on postponing. And when even my wife was asking whether I'm going to attend this or not, I didn't tell her anything about this at all. Because of my health issues, I could not decide whether to come here or not. On the last day, I made up my mind to attend the conference on the assurance given to me by one of my very close friends, Mr. Priyadarshi, who is here, that they will not allow me to get out of Bangalore all by myself. They said he will accompany me. So he's sitting there. Well, my dear friends, much has been told about academics and SDG. Be rest assured, I'm not going to touch upon that, even a bit. Let me very briefly place before you how the genesis of this association. I have to take you back down the memory lane about 42 years ago, 1984. From the beginning of that year, late Dr. Armugam, Dr. Sudarshan, and myself, we started initiating to find out how best we could start an association. We used to meet after the college hours. The advantage was both BMC and Kempegowda Institute were adjoining, so it was easy for us to meet after the duty hours. I don't know how many times Dr. Sudarshan had to run up to the concerned authorities to move the file and to get the certification for us to start the association. And it was quite successful, I think by the end of the year. With a meager few friends, about 10 or 15 of us, we started the association with the main aim. In most of the annual conferences, the senior people take over everything. The juniors, they were never used to get the opportunity to show their talent. So it was mainly the initiation from Dr. Sudarshan that we should create a platform for the junior faculty, the interns, and the other trainees to show the talent, especially to learn the art of and the science of making presentation in conferences. So with that idea, we started this association in 1984. And another unique aspect was we threw open the membership not just only to the medical fraternity. We wanted to include the non-medical, especially anyone in the community interested doing community health activities. So that is why you see here that a lot of other members are also there. And the first conference was held, I think, June or July 1985 at Kempegowda Institute of Medical Sciences, Bangalore. If I remember, I think the total delegates was around some 50 or 60, but it was a well-attended thing. And the chief guest was none other than our former Prime Minister, Mr. H.D. Devagowda. Our association was so weak in finances because we had just made the beginning, and you may difficult to imagine for anybody. The conference ended with a very simple dinner at the Prakash Cafe in Chamarajpet. Well, that is, after that, this membership slowly began to rise with a slogan that catch one, each one. Somewhere in the middle, it became shaky, and for a couple of years, I think, it was a bit inactive. I think at that time, youngsters like Dr. Girish and his contemporary colleagues put the institution on the track. And this is what you see today. The association is alive, vibrant, and dynamic. All the credit goes to the younger generation, and I would like to say that they are going to take it forward. One thing in my mind, I don't know, is it the right forum to make? I think we have reached a point after 42 years or 40 years. All these things has become a ritual. Every year, conference, and the programs are also the same thing is going on. I feel it has reached a sort of a plateau. I think it's the right time. We should think of some change so that the Generation Z will be able to take it forward, at least make it visible all over the country. With these few words, I don't want to take much of your time. Let me congratulate all the award winners and the delegates. Wish you a very happy years ahead in your academic and professional career. Thank you. God bless you.
Thank you, sir, for sharing your insightful journey and your inspiring words. It is now my privilege to invite Sri Rajendra, sir, Vice President, Sri Devraj Aras Education Trust, to deliver the presidential address.
Good afternoon to one and all, dignitaries on the dais, Dr. Shivaram, guest of honor, founder, president, KACH, Dr. B. Vengamma, Honorable Vice Chancellor of our university, KG Hanumantaraju, Secretary of our trust, Chief Administrative Officer, DVLN Prasad, Dr. Muninarayana, Dr. Prabhakar, Principal, Girish N. Rao, President, KACH, Dr. Ranganath T.S., Secretary, KACH, Dr. Sunil, Organizing Chairperson, Krishnappa, Medical Superintendent, Dr. Dayanand, Organizing Co-Chairperson, Dr. Pradeep T.S., Organizing Secretary, and all the other dignitaries of the dais. This gives me an immense pleasure to address this August gathering at the 36th Karnataka Association of Community Health Conference, a conference that reflects our collective commitment to strengthening public health and advancing sustainable development. The Sustainable Development Goals represent a global promise to create a healthcare more equitable and sustainable future. Among these, SDG 3, good health and well-being, service as the foundation upon which many other goals depend. Achieving better health outcomes requires strong partnerships between academic institutions, healthcare providers, policymakers, and communities. At Sri Devaraja's Academy of Higher Education and Research, community service has always been central to our mission. We firmly believe that education should extend beyond classrooms and hospitals into the communities that need us the most. Our university has consistently invested in initiatives that improve access to healthcare for underserved populations. Through free rural health camps, comprehensive outreach services, free medicines for all eligible patients, free institutional deliveries is one which we are extremely proud of, and we have 3,590 completely free deliveries for the academic year 2025-26. We strive to reduce health disparities and improve the quality of life for vulnerable communities. Equally important is our emphasis on education, research, and innovation. Through our academic programs and research activities, we continue to develop evidence-based solutions that address the health needs of society while preparing future healthcare professionals to become compassionate leaders and responsible citizens. The theme of this conference, Sustainable Development Goals, the way forward, encourages us to think beyond conventional healthcare delivery. It calls upon us to build resilient health systems, strengthen primary healthcare, promote preventive medicine, protect our environment, and work together to achieve lasting improvements in population health. I congratulate the Karnataka Association of Community Health and the Development of Community Medicine for organizing this prestigious conference and bringing together experts from diverse fields to share knowledge and inspire meaningful action. I wish all participants enriching scientific sessions, fulfill collaborations, and continued success in your efforts to build healthcare communities. Thank you, and I wish Kachcon 2026 a very success. Thank you.
Thank you very much, sir, for your inspiring and visionary presidential address. Now, I request Dr. Pradeep T.S. to deliver the vote of thanks.
Under the divine blessings of Sri R.L. Jalapaji, I would like to render the vote of thanks. First and foremost, I express my heartfelt gratitude to our Honorable Chancellor, Sir, G.H. Nagaraja, Sir, in absentia. We would thank Dr. Shriram C. Sir for accepting our request to be the guest of honor. I sincerely thank I sincerely thank our Honorable Vice President Shri J. Rajendra sir to preside the conference and also for the encouragement and support. Our special thanks to respected Secretary Shri K.J. Hanumantaraju sir for the support extended towards the successful organization of this event. We sincerely thank our Honorable Vice Chancellor Dr. Vengamma ma'am for the visionary guidance and inspiring presence. We sincerely thank our Chief Administrative Officer Dr. D.V.L. Prasad sir for their timely advice. I also express the thanks to the silent force, our beloved Registrar Sir Muninayana C, for his extended support towards organizing this conference. We extend heartfelt gratitude to our respected Principal Sir, who always puts academics as the first priority. We extend our gratitude to our Medical Superintendent Dr. Krishnappa Sir. We express sincere thanks to CATCH President Dr. Giri Sir and CATCH Secretary Dr. Rangnath T.S. Sir for both online Zoom support and offline guidance. I would like to thank all distinguished speakers, resource persons, delegates, faculty members, organizing committee members, volunteers for your participation and active involvement. Before I forget, a word of appreciation should go for our young dynamic head, Dr. Sunil Sir, and young CATCH veteran, Dr. Dayanand Sir, with whom we started this dream of CATCH. Special thanks to media, librarian, our sponsors Jagdali Group, Marrow, Sparsh Hospitals, MERT, DAMS, JP. Before I conclude, I would like to thank our own KMC observer, Dr. Mahesh Sir. So with these words, I once again express my sincere pranams to everyone who has contributed to the success of this event. Thank you all. Have a pleasant day.
Thank you, sir. As we conclude the inaugural ceremony, may I request everyone to kindly rise for the national anthem.
गणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
This concludes the inaugural ceremony of Kachcon 2026. Please remain seated for further announcements, and we'll continue with the scientific sessions in few minutes. So we begin with the scientific session 2, and then we'll continue with the scientific session 1 by Megha Verma ma'am, following which we'll have B.M. Patil oration. The scientific session 2 on road safety for children, an SDG priority, SDG goal 3, 11. The chairpersons are Dr. Ramakrishna Gaud sir, Professor, St. John's National Academy of Health Sciences, and Dr. Gautam Sukumar sir, Professor, Department of Epidemiology, Center for Public Health, NIMHANS.
I'm already ready.
I request Ramakrishna Gaud sir, Professor, to come over the dais to chair the session.
Shall we start? Okay, dear delegates, I'm really sorry to interrupt your photo session, but there has been a slight change in the timetable because Dr. Sridhar has to catch up with a meeting at 3 o'clock. So without wasting much time, yeah. So Dr. Sridhar is a health specialist at UNICEF India, and without much introduction, I would request Dr. Sridhar to start the presentation.
One small bit from me about Dr. Sridhara. Dr. Sridhara also led the gap analysis work at the UNICEF when he was wearing that cap.
Kindly request Dr. Sridhar to initiate the proceedings, sir.
I request all the elders, seniors, friends, everybody in the hall to please be seated because Dr. Sridhara is going to start his presentation and we are running short of time. I seek everybody's attention and please I request all of you to take your seats so that Dr. Sridhara can attend the session.
I request all to take your seats. Delegates, kindly sit.
Dr. Sridhara, maybe you can start, sir, because you are in a hurry to go.
Good afternoon, everybody. I'm really happy to be here today for this conference and very happy that my session is chaired by Dr. Gautam and Dr. Gaud. And I have working relationship with both of them. With Dr. Gaud, I worked extensively for RMNCH implementation in Karnataka, and now with Dr. Gautam for road safety. And he's one of the champions for road safety, not only in India, in South Asia. And we cannot have a better chairperson than Dr. Gautam for this session. Having said that, a sincere apologies to Dr. Meghna. She was supposed to take this session. Sorry, I had to leave, so I'm taking your extra time. And thanks for accommodating for this. So in next 10-15 minutes, I'll try to wind up my presentation. And before starting my presentation, I just want to acknowledge our partners. If you can see the logo on this slide, Indian Institute of Public Health, Hyderabad, now IIPS University. And NIMHANS, Dr. Gautam is our key partner. And the most of the work what was there in my presentation comes from these premier institutes. And of course, the government of Telangana, the Department of Transport, is our government partner. Why I was specifically saying about these partners is, when UNICEF wanted to work on road safety 2 years back, these were the only partners available who were working on road safety. And after this presentation, few of you who are here, at least one of you get motivated to work on road safety for as a whole, and specifically road safety for children. I think the purpose of having this session as a part of SDG framework or moving
as a theme of this conference, I would feel it is a small success. I just want you all to know a few figures. When we talk about child and adolescent injuries around the world, so we are talking about injuries here, not specifically road safety. Almost 1,600 children die every day because of injuries. And in injuries, we have intentional injuries and unintentional injuries. 80% of those unintentional injuries comes from middle income and lower middle income countries. And if you look at the causes of unintentional injuries, that is where the first major cause is the road traffic accidents, drowning and falls. Intentional injury, of course, suicide is the major cause of mortality. The slide is not much visible, but what does it say? When we look at leading cause of death globally in children, and this data comes from Global Burden of the Disease, 2023 report, 2019 data. If you look between the age group of 5 to 19, unintentional injuries is now the global major cause of death. Now, if you unpack it and see, within unintentional injuries, if you take road safety, between the age 5 to 14 years, death due to road accidents is now the second major cause of death. And in the age group of 15 to 19, death due to road accidents is the major cause of death among children. And that is where UNICEF has started working after this 2023 report came. Otherwise, this is not the primary domain where UNICEF as an agency used to work for road safety for children. And if you look at the data for children globally, more than 600 children die every day due to road traffic accidents. And if you see the trend, by 2030, the number of vehicles are going to increase. It is estimated that by 2030, we'll have 2 billion vehicles on road. So there is no hopes that these numbers are going to reduce. It is further going to increase. And also, there is an estimate by year 2050, 68% of the world, almost 5 billion people will be living in urban areas. So road safety as a whole, and road safety for children specifically, is going to come as a major burden in the upcoming years. And if we look at the data of the different countries, after America, India is the second largest in terms of contributing to road accidents. India has 1% of the roads in the world network, contributes to 11% of those deaths in the world. And if you look at the 5th to 6th, I just want you to see, Japan is 5th and Germany is 7th in terms of number of road accidents. If you compare that with this slide, India was second in terms of road accidents, but in terms of road deaths due to accidents, India is first. America had 5 times more than accidents than India, but 2 times less deaths than India. If you see, Japan and Germany were 5th and 6th in terms of accidents, but they don't even figure in the top 20 when it comes to number of deaths. That means the immediate management after the crash and the post-crash care management is a challenge still in India, and DMANS is doing a lot of work to address these challenges. Worrisome is about the trend. See, there is a dip in 2020 during time of COVID, but after COVID, if you see, every year, the number of deaths are increasing. And if you see the latest data from the Ministry of Road Transport, 2023, and compare it to pre-COVID 2019, we have increase in number of road accidents compared to that. So if you convert that into absolute numbers and calculate it for per day, in India, we are losing almost 500 people every day and almost 20 deaths every hour. And what we committed in SDGs, and when I used to take this session elsewhere, many of them don't even know that road safety is part of the SDG indicators and it is part of the health indicator. In SDG 3, road traffic injuries, the target 3.6 committed that we will reduce the number of deaths to half than what it is currently by 2030. And SDG target 11.2 talks about safe transport and sustainable transport. And looking at the data, that is why, if you look at the topic of my session in the agenda, road accidents or road safety is a neglected SDG target. If you look at all the targets of SDGs, they are moving or they are slow or something, but this is reversed. And we are left with another 2-3 years for SDG 30, and we don't know what is beyond SDG. Still now the discussions are not happening because of the geopolitical tensions happening. While MDGs were happening 5 years in advance before MDG 2015, we had discussions on SDGs happening, but we are not having any discussions what is going to happen after SDG. And it is another 3 years is left. Look, from the SDG framework, the decade of action for road safety was planned that by 2021 to 2030, the world will commit for reducing this deaths to half, and Government of India was signatory, our Union Transport Minister was part of this when Global Decade Action Plan was launched, and he committed there, and subsequently when the second event happened, he did not turn up there. He told, I could not even sustain it, the deaths are increasing, and what face India will take if it goes to this summit. It happened in Kigali, if I'm not wrong. He did not go from India. They say, if only when I reduce the deaths from India, I will go to this UN Decade of Action Summit. And this Global Decade of Action for Road Safety, they identified 12 indicators for road safety, and they were divided into the first 2 indicators related to road safety management, another 2 indicators related to road safety and mobility, 1 indicator related to safer vehicles, around 6 indicators related to safe road users, and 1 indicator related to post-crash response. See, 6 indicators on safe road users. So the behavioral part as a cause of road accidents is the major concern for us. And it is not only about the SDG 3 and the 11.2 indicator for road safety. The road safety impacts almost 10 SDG indicators, right from poverty to climate change and security and safety. And if you look at the data, we spoke about the global and the national data. When it comes to the state level, among the top 10 states contributing to almost more than 60% of accidents in the country, Karnataka stands among 5th, Tamil Nadu and Uttar Pradesh being the highest, Madhya Pradesh being the highest in terms of accidents. And in terms of deaths, still Karnataka remains 5th, Uttar Pradesh leading the country in terms of number of accidents due to road safety. And if you take the cities which have population more than 10 million, our Bangalore figures in the top 2 after New Delhi. And the worrisome, as I told, for the country and for the state, you see the city of Bangalore data on the left side. It is increasing every year, and almost 3 times than what, almost more than what it was pre-COVID. And if you look at where the accidents are happening, the national highways in India contribute to 2% of the road network, but it contributes to 30% of accidents in the country. Similarly, the state highways contribute to 2.8% of the total road network, but 22% of the accidents. So state highways and national highways put together contribute to 50% of the accidents, and rest all road within the cities, in the rural areas, contribute to 50% of the accidents. And if you look at the cause of these accidents, the major cause is coming as overspeeding, but other significant causes are drunken driving, driving on the wrong side, distracted driving, mainly using the mobile. Though the percentages are less, but what the evidence says is that it's highly underreported. One of the joint commissioners of traffic police was saying, if we book somebody as accident and we book it as drunken driving, so he will neither get the life insurance nor they'll get the vehicle insurance. So that was the purpose that it has come down, but these are the major causes. And globally still, overspeeding remains as the major cause of road accidents. And if you look at the behavior, almost 30% where road accident happened, the drivers either did not have a valid license or they were on learner license. So if you take it on a road, if there are 10 vehicles, there are 3 vehicles where you don't know what is the status of driving license of a driver. So you are driving in that scenario in the city or elsewhere. And if you see out of the total accidents in 2-wheelers, 70% of the drivers were not wearing the helmets. And if you look at the 4-wheelers, 52% of the drivers were not wearing seatbelt. Again, a behavioral issue. And logically, if you see, accidents should happen more in the rainy season, in the foggy season, and the misty season. But if you see the data, 76% happen when there is clear summer where it is sunny, clear roads, everything. Again, a behavioral issue. This is more worrisome for UNICEF. If you look at the age group of the deaths, if you take less than 25 years, from 0 to 25 years, it is almost 26% of people who have died belong to this. But if you look at the very productive population up to 45 years, they contribute to more than 50% of people who died in accidents. Now you see the age group, and within this age group, if you disaggregate it to gender, 80 to 90% are men. Young men who are even today are the pillars of the family. If they die, what about those children whose father has died? Those children whose mother is alone now, a single mother. So our system, our social protection system only takes care of those who have died and some entitlements for this. But those who are left behind after they survive, how is our system addressing that? Globally, it is pedestrians who are losing their life more in road accidents. In India, the data says 44% are two-wheelers and 20% almost are pedestrians. So almost 65% these two road users are the one who are vulnerable for road accidents, then other type of transports and communication. Contrary to our understanding, we think that urban areas are the contributing to the more road accidents. And if you can see, Uttar Pradesh is now contributing to the major accidents and deaths. So, and if you look at the data, 60% of the accidents are contributed by rural areas. Only 40% comes from urban areas. And if you look at the time of, and this is a no-brainer, as the day continues from morning 6 to 9 o'clock to evening 6 to 9 o'clock, the number of accidents increase over the time, and after 9 o'clock, it continues to decline. So last slide, I will end here in the interest of time. The rest of the half, if time is available, I'll request Dr. Gautam to continue the slides, because most of the slides come from his work. Why we are worried about the children? Because I told, similar to the global data, our national data says road traffic injury is now the leading cause of death among children and adolescents in the age group between 5 to 19 years. And we have a huge number of adolescent population in India, so almost 565 million. And every day, we are losing 45 children in India due to road accidents. And the Global Decade of Action Plan we were telling, now if you see in the last decade, we have lost almost 2 lakh children due to road accidents. Dr. Gurraj, who is the founding member of, who retired as the ex-director of NIMANS, who started the WHO Collaborative Center for Road Safety in India at NIMANS, which is now headed by Dr. Gautam, he puts it very in an appealing way. He says that every day in India, 1 classroom is washed out because of road accidents. If you're talking about 45 children per day, so imagine there is a classroom and there are children, and every day we are losing 1 classroom. So with this, I stop. If there is any questions or clarification, I'll be happy to discuss. And thank you for this time. And once again, apologies to Dr. Meghna for delaying. Thank you. Thank you so much.
So any questions from the audience? Yeah.
What we see in, at least in Bangalore, most of the adolescents, they do this high-risk behavior of wheeling or very fast. And the police, they are not a bright eye to it. Even though in the press, media, we say they will take a strict action, but no action has been taken, and most of them are under the influence of drugs. So, do you have any data on that?
I think Dr. Gautam is better to answer this. Within India, sir, the data for road safety is the biggest challenge. Whatever the data currently we have is one report from the ministry and whatever Dr. Gautam generates from the demands. Otherwise, road...
Sir, if I can answer on your behalf.
Yeah.
Because this is the area I also work very closely. Sir, it is a policy fault. Because if you see, it is so shocking that our government is giving 50% discount to some discounts for all the pending road violation fines. So if you keep giving discounts on the fines, how would this act as a deterrent? So it's a major policy fault.
Yeah, thank you.
Okay. Sir,
And
to
also
answer
it is
your
an issue of democracy, sir.
You wanted the burden, no, sir?
Yeah.
So basically, we have studied around all 31 districts in the state of Karnataka, close to around 4 million observations. And our key finding is 30% of the youngsters are speeding beyond the posted speed limits. And the prevalence of alcohol-impaired driving. I do not know about drugs because it's difficult to conduct such studies. The prevalence of alcohol-impaired driving is roughly around 4.5%. So this is the current statistics. But the prevalence of rash driving is close to around 45 to 50%. So it is commonly prevalent. And the question, the enforcement is basically focusing on issuing challans, but not the immediate collection of money, which is the main which is the main deterrent. So there are so many political, administrative, and operational angles to it. It's not that they're not doing anything, but they've started something. So I'm sure over the days to come, it will certainly progress.
And also, sir, in my next slides, there is some data on this, what Gautam is saying. So up to 18 years, I think 2 to 15% of children have found with under the influence of alcohol and driving. And as Dr. Gautam says, now the guideline from the ministry, so if somebody is drinking and driving, the cutoff level is based for adults. There is no lower cutoff for the children. So 30 milligram per deciliter in the blood alcohol concentration is taken as the cutoff. And of course, it is a very high standard compared to what is there in Western countries. So India has a very high standard that it should be 30. Minimum is 30. In other countries, it is 60, 80. Some countries have even 100. It is allowed there. But there are strict standards for the adults. But children, from road safety point of view, it's too challenging. And less than 18, again, they cannot be punished. There are other different legal issues. If there's more than 18, all laws apply. And that is where road safety for children advocacy is one of our strongest area of advocacy for the government.
So Dr. Sridhara has some appointments in Bengaluru with the NHM directors and all that, so he's leaving us. But few of the insights which are left untouched by Dr. Sridhara will be dealt by Dr. our Dr. Gautam. He will take about 2 to 3 minutes to do that. But we'll see of Dr. Sridhara so that he won't be in a hurry and also will be at the denominator for risk of accidents.
Safe road travel back to Bangalore.
So we'll quickly facilitate Dr. Sridhara, and I request Dr. Gautam to give his insights later.
I request the chairpersons to come forward for felicitation of the speaker. Dr. Sridhar, sir.
I call upon Dr. Gautam Sukumar to give his insights, because he's the one who is soiling his feet and hands doing this work. So, Dr. Gautam, please take 3 minutes and give your key insights on this subject.
Thank you, sir. So I'll not be taking much time, but I would like to say one thing is that, in general, including this auditorium, is not designed keeping the child in mind. So our roads, our vehicles, our post-crash care systems is generally, by large, not designed keeping the child in mind. So because of that, there are various issues. Coming to the epidemiology, which Dr. Sridhar stopped, in children what we observe is there's something called as the trimodal distribution of death. Nearing 30% of the children die at the spot of crash, 20% die between the crash to the hospital, and 50% die in the hospital. Even the best trauma care systems can only salvage around 25 to 30% of that 50%, clearly indicating that as far as epidemiology of children are considered in road traffic injuries, prevention is very important. Even that's true for adults as well. But for child, if a child crashes, the probability of fatality is very, very high. So that is why the prevention is much important in children. So to address these issues, what we have done is, we have done a detailed analysis of how different is the epidemiology of RTIs in children vis-a-vis adults. And we have come up with India's first multisectoral national action plan for reducing road traffic injuries among children. And this action plan was released last year. And now the individual states are adopting this national plan with the principal concept that if you make the streets safe for child, it's going to be safe for everyone. So Telangana is one of the first states. We had the initial meeting on how to operationalize this national multi-sectoral action plan for child. And now it's going to be expanded to other states. A very important development in this area is that the long pending requirement of this country, the National Road Safety Board, which was not there, was basically formulated last week. And there are 12 national flagship programs under the National Road Safety Board, and Safe Schools and Safe Journeys for Children and Child and Adolescent Road Safety is also one of the important national flagship programs. So I'm sure that in coming years, even though the fatalities among children account for only 10% of the overall fatalities, in terms of DALIs, it is significantly higher. So the issue of road traffic injury prevention among children is a little more complex than adults, but I'm sure the national framework has got the necessary strategies, objectives, indicators, and the mode of operationalization to ensure that these fatalities as well as crashes is going to decrease. Even though we may not decrease it by 50% by 2030, we are hoping that we will achieve some amount of decrease in the fatalities as well as crashes. Thank you.
Excuse me, sir.
So, Dr. Gautam, before, two questions are allowed from the audience, but before it goes to the audience, Dr. Gautam, since almost all of us who are here are community medicine persons, and we all are involved in annual school health checkups. There are also some in the audience who are in a project mode into road traffic injuries. But for those of us who are involved with school health checkups, every year we go to schools, is there any one or two messages that you want us to carry to the schools the next time when we are in the school environments concerning this subject?
I would just say that 70% of the fatality is due to unsafe road use behaviors. So if you can inculcate, people say that people die due to potholes. That fatality is just less than 5%. So if you can teach safe road use behaviors to children, point number one. Point number two, we have developed a very objective way of assessing safety levels in roads around schools. If the schools can come forward and evaluate the safety levels in roads around schools, because evidence shows that majority of the fatalities happen within 1 kilometer from the school, especially among people aged above 8th standard or not, because they have unsupervised road use. They go together, cycle together. Even if you do these two things and start road safety education in the curriculum, I think there'll be a significant improvement. And I don't want to talk about licensing. I think at the school level, these three things can be done.
Thank you. Mahima, at the cost of making you angry, let us take just one question from the audience because I stalled him. Doctor, please, quickly.
Hello, sir. Regarding educating the students regarding road safety behavior, I am just curious as to, is there any data as to how many of these students have been injured because of their behavior of listening to music on the road? With the advent of wireless earbuds and over-the-ear headphones, noise cancellation headphones, I'm sure they can't hear any honking behind them or any sound, vehicle sound for that matter. Any data on that, sir?
Continuing the same question, in your mentioning in the previous for a question, you answered that drug estimation is a bit difficult, TDS among children, alcohol is want to be, but majority of the reason happens to be the rash driving. That was a statement by yourself, right? So for drugs, we have got investigations, alcohol so is there. But rash driving, what was the basis for quantifying or considering that? Rash driving on the part of the victim or whatever, what's the reason? What is the basis? According to my understanding, it will be based upon the hearsay evidence or the witnesses, whatever they have told. How much of that is acceptable? These are my doubts when you mentioned that rash driving happens to be. And going by my colleague's, friend's question, behavior. Have we assumed that age group children, their behavior and characters, we generalize and say that that may be the reason? Is that what? No.
There is a specific section that defines what is rash driving. For example, children who are doing wheelies, children who are going in excessive speed as well as trying to do difficult maneuvers, changing lanes. So there is a particular section on which the police catch the child as rash driving. So that is by definition of law, that is defined as rash driving. So operationally, when you are doing roadside observational studies, we focus more on speeding than rash driving. Rash driving is a legal definition which police put the case.
Fairly well said, sir, but how many of the accidents are being observed with the policemen to document and say that it was rash driving or the difficulty in navigating, they had a fall? Because in our country, in our system, there is
so
no
just to cut you short, sir, police do not observe and say it's accident due to rash driving. The reason for the crash, actually we don't use the word accident itself, we use the word crash. The reason for the crash is determined from a forensic analysis of the crash site. So there are scientific ways in which, by looking at the crash site, vehicle, pattern of injury to vehicle, the skid marks, the injuries on the body, the scientists can clearly say the reason for the particular crash, from which side, front, back, side, speed. That's a different science by itself.
Types of injuries, what we
Dr.
have read in
Prasanna,
forensic medicine, right?
Gautam is with us. He's staying back with us. So we
tonight
can
we will
still
have a
catch
night
him.
discussion, I think.
Okay. So thank you all very much for your patience. Dr. Sridhara in his absence and Dr. Gautam, thanks a ton for filling in the gaps and giving your valuable insights. And thanks Mahima and team for tolerating us and taking few extra minutes. Thanks a lot. We sign off from here. Thank you all very much.
Thank you, sir. I request Dr. Sunil, sir, to come over the dais to felicitate the chairpersons of this session.
Thank you, dignitaries. Now, continuing the first scientific session under Understanding the SDG Framework, I invite Dr. Srinivasa, BM Scientist, D, ICMR, to introduce the next speaker, Dr. Meghna Verma, ma'am.
Thanks.
Thank you, sir.
Very good afternoon to everyone. I think I should really congratulate the team to get this speaker. We have all seen the SDGs, multiple goals and other things. One of the important things which all, I know many of you commute from Bengaluru, and one of the important challenges is urban resilience. And today we have Dr. Meghna Verma ma'am. It's proud and privilege for me to introduce a person with such a versatile career. She has a wonderful publications, and her presentations are across the country and across the globe. She has always, also been felicitated from Niti Aayog and from Government of India for Brand Bengaluru. I welcome you, ma'am, and for the time's sake, I'm cutting short, but her profile is noteworthy that one of the important domain of urban resilience is her domain of work. Welcome you, ma'am.
Thank you so much. I'm grateful to the organizing team for having me here. Thank you. I hope I'll do justice with the time. I'm really grateful to all the people who are still sitting there and ready to hear the presentation, despite that this is a lunchtime for all of us. So thank you so much for that. I hope this will be a kind of a slightly value addition. I am not a doctor by the true meaning. My doctor is because of the doctorate. So I bring a different perspective altogether to this particular conference. And that's what the conference briefed me up when I said that I'm not a doctor. I hope you're not making a mistake here. They said, no, you work in sustainable development goals and we want to have that perspective. So I'll try to bring it there. Thank you, Chair, for giving me the opportunity to present. My title is Beyond Healthcare, Building Sustainable Communities for Health and Quality of Life. So I'll be emphasizing more on the word beyond and the quality of life, because you're all healthcare experts, you all know the problems in the healthcare. So while addressing those, what else we can look upon? So that is my point here. So when we look at it, I thought of getting some engagement done, like why you're wondering I am here. Thank you, Chair, that you gave certain perspective and they can expect a little bit from my presentation. So anyone who could resonate with any of the emojis, I would love to hear. However, now everybody is hungry, so probably the fifth emoji suits to all of us. Why at this time and why this presentation? So I'll move next instead of engaging with you. So first question is, why SDGs? Why we need to focus on that? It is because we always believed into Vasudhaiva Kutumbakam, and there are 5 elements. Now human activities have destroyed all the 5 elements. That's the result of climate change. We cannot ignore it, and let us see how we have resulted in destroying it. So, Prithvi, Agni, Jal, Vayu, and Akash. So Akash become a space. You look at the space debris nowadays. Everybody is getting fascinated, and privatization has also happened. So we have not just left the earth being polluted. We all know, I will not emphasize on that, but we have polluted our skies also. And we are paying price for that. The AQI index in Delhi is a well-known element here. Water, we all know what has happened to water. I wanted to have this more of a conversational, but now I'll only answer it because I just want to ask one question with the audience here. Which is a developed nation? Germany, Austria, or India? Germany, right? Thank you for answer. Which is the richer nation? India or the Germany, per capita income, and otherwise also? Then why we are buying water bottles, but they are having free water in the tap? These are the questions we need to ask. Why a country like India is buying water bottle while the developed nations, which are richer than us, gets free water in their tap? Where are we going wrong? That we have to ask ourselves. When we talk about fire, there are wildfires happening. It's not only because of the natural phenomena. The livestocks are there, and we need grazing spaces. So human consumption has gone to the extent of destroying forest, not just in India, globally, including Australia. Please search, you will have shocking informations. So wind, it's Vayu, and we know how we have polluted. Each winters, and the AQI index goes up. So these are the 5W1H we typically talk in terms of management, and we'll get an answers to all these questions here. We all know Sustainable Development Goals. They're classified basically into 5 categories: people, planet, prosperity, peace, and partnership. These are some of my work which I have been engaging over the years. And SDG 3, 5, and 10. I've done a government project for gender inclusive transport policy and submitted the policy recommendations. That time, DALT officials were a part of my mixed method study, and few of the things were implemented also. Then Sustainable Cities and Societies, we all know probably the Brand Bangalore campaign, they had 7 verticals. The Agile Mobility vertical came to us. I analyzed the data, and we did it along with IISc. And that's a contribution here already. Then, you was talking about this lifestyle for the environment, the Niti Aayog thing. So these are the Kumbh Mela, crowd dynamics. This is something very interesting. Because when we talk about crowded space, India is the largest crowded festivals. All the Kumbh Melas top the chart of human gatherings, the largest on the earth. And the kind of the epidemic which can spread over there is much higher. So what are we doing there? And who are studying them? How are we studying? So in 2016, this project was funded by Ministry of IT and NWO, where we had multidisciplinary, country project. And some of the studies were also done in terms of health. So post the session, if we are interested, I can definitely give you the details. Responsible consumption and production is my core area because I come from the background of marketing and analytics. So we do a lot of research in this area as well. Now, coming back to the word quality of life. Anyone, any guesses? How many of you have actually heard the word quality of life? Can I get that so that I can spend time accordingly? Quality of life is a scientific word. 2 of you, okay. So I'll give you an example first to understand the quality of life meaning rather than the definition here. So let us say Bangalore has rich people, right, from corporates to IT to the government. But a person, a corporate tycoon, maybe Kiran Majumdar, Shaw, similar people, they are on the road. And they have best of the car facilities, they have best of the money, but they're stuck up in the traffic. Now, if they're stuck up in the traffic for every day for 1 hour to 2 hours, where is the loss? Loss in terms of productive time. Also, the hidden loss of their health, because sitting in AC and emissions is not good. So they may have money in their hand, but quality of life is questionable. So quality of life must not be mistaken as per capita income. What is that we are trying to achieve with our sustainable cities and smart cities? We are trying to improve the quality of life of citizens, or we want to improve only the infrastructural spaces. So that is what a simple understanding of a quality of life. However, quality of life is defined in terms of well-beings. It is physical well-being, social well-being, mental well-being, environmental well-being, and functional well-being. Our quality of life is good or bad? In urban spaces, right? You don't waste your time on roads, you don't have pollutions. Slow is luxury these days. Do you really have a time to sit in the garden and just leisurely take a coffee without your mobile phones? We get luxury at the Bangalore Airport Terminal 2, but on the main roads at Mathikere or other places, where is the green? So quality of life is poor for all of us. And why it is poor? And what are the consequences here? It is because of poor health. What it results to? It results to poor health, limits our mobility, energy, and comfort. Social well-being, we become an individual person, right? How many of you are able to travel to your families and other people for celebrations there? So where is the social well-being coming up into picture? Then stress level has increased. Work pressure, satisfaction level has gone down, and the life overall satisfaction is going down. When we talk about environment, unsafe surroundings negatively impact health and safety. We also looked into inability to perform daily activities, which limits our independence. Old age people are almost house arrest in Indian scenarios, and especially in urban areas. Naini, you don't go, please don't go, we will buy this for you. Why? Because there is no pedestrian infrastructure. Now here, Supreme Court might have given us a fundamental right to walk, but is the walking safe? I have seen myself, many old people are unofficially house arrest. So we are losing our independence also. Inadequate community well-being is a result of poor quality of life. Probably we are much used to it. So Sridharji was presenting in the previous one. I work also in the same area. So he said that a classroom size of the children are dying every day. And in other words, when you look at the adult people dying, it's like a jumbo jet crashing with no survivors every single day. That's the number of road accidents in our country. But it takes headlines only when a jumbo jet actually crash. So we are not paying attention as what is required. And these are the headlines in the newspapers. Diabetic capital of the world, I looked into one of the medical papers, which proves that we are the diabetic capital, why it is so, right? Then we all must have experienced at the airports, the number of wheelchair users are higher as compared to anywhere in the world. Why? People may argue that it is because of navigation issues, old elderly are traveling. Why are we making our elderly so weak? Right? And we have mocked ourselves in front of the entire world. This is a global phenomenon now. It's a newspaper article. So where are we going wrong? It's all about individual choices, and it's about infrastructure deficiencies. Both are there. If airport is easily accessible, probably Indian elderly people will not be using a wheelchair because they can walk through. So there are lots of things. And where is this happening? What happened to our walking and cycling? Because there is no infrastructure in the urban spaces, where should I walk? So we have lost the main ability of a human being, which is 2 legs and to walk. We have to go back to our basics. So beyond the healthcare, as I said, I'm not going to emphasize much on the healthcare. You all know that, and you are all expert there. So beyond is the abbreviation, and I'm going to expand that here. Built and natural environment, right? So here, health and sustainable spaces. I'm talking about spaces here. In equity and inclusion, fair and just societies. Your everyday choice and behavior, healthy lifestyle decisions, opportunities for accessibility everywhere for all people. Network and social connections, which is a strong community relationships that need to be built up, and democratic and data-informed governance. Data-driven decision-making, the bottom line is the quality of life, the foundations of health and quality of life, which is often ignored, because the previous speaker also talked about behavioral changes. We need to bring behavioral changes in us, in governance, in education system, across that. And that's the very reason, being a management institute ourselves, we started Center for Sustainability in 2022 itself. And we have blended sustainability in our courses, in our lifestyles. We are trying to make it as a zero-waste campus. So beyond healthcare means recognizing that health is created not only in hospitals and clinics, but also in the communities where people live, travel, work, interact, and make everyday choices. Now, this is probably could have been a good takeaway for the healthcare practitioners here, how to move from traditional healthcare to beyond healthcare spaces, right? So here, I'll just read out few. Focus on treating diseases, and here you are looking at the well-being of people. So can we have a slight shift even in our academics here? Center is on individual patients, and there it is like the entire community is getting healthier. How can I do this? And then operates within hospital and clinic, and here you go to all public spaces, make public spaces healthy and interactive. Relies on medical indicators, and there the indicators are happiness, quality of life. It's subjective well-being. And then driven by healthcare professions, there it requires multiple section collaborations. And these are not philosophical things that I'm talking about. We have done the projects in the later slides. You will get to know about it, that we have actually implemented it. Then driven by, so concentrate on short-term treatments, and here it is long-term community well-being. Like the VC was also mentioning, our destination is sustainability, happiness, right? How do we achieve that? So it's a collaborative work. Unsustainable communities, as I said, related to SDGs, there are 5 Ps. And the 5 Ps is terribly going wrong. So despite we defined the SDG goals, 17 goals, but are we able to achieve it? And how much are we able to achieve it? Are we really intended to achieve it? So neglecting people health everywhere, right? We have ignored public spaces. You can see in your own neighborhood how many social spaces you have. Think for a while after this session that if you want to go to a particular day, let us say on a Sunday with your family, where would you go? Your answer will come malls. Malls are not social spaces for mental well-being. Then undermining the prosperity in terms of livelihood, economic resilience, and responsible consumptions. For when we have a bad or unsustainable communities, these are the characteristics. And I hope you agree with that these are the characteristics of our communities as of now. We can debate if you have different point of view. Weakening partnerships. This is happening actually. We see in our neighborhood. We might be partnering at our workplaces. How many of us really know our neighbors? So partnership, like, why we are going so far for the partnership for the international collaborations? What about my social well-being when I'm looking at my neighborhood? So these are all issues that we cannot ignore. Disregarding planet, we all know how we have ruined our own planet, and finding a space, it results in improved health, well-being, and quality of life. So sustainable community, if we look by the definition, is a settlement of the group of people that meet its social presence, environmental and health needs while protecting the resources, opportunities, and living conditions required for the future generations. And that's where the importance goes. So when we looked into it, the community well-being, when we talk about it, besides the treatment, if we can also focus on this, that would be really helpful. India never talks about this index. You will have your own answers why. Because it's almost difficult to achieve. And what is this index? It's a livability index. It's a livability index, and these are the top 5 cities in the world, which are the most livable cities on the earth. Have you ever heard about India competing for livability cities? We talk about cleanest city, small goal. We'd never heard about this index, and this is a global index. And the global index, why? So I have been, except Melbourne, I have been to all these cities, and I have experienced it. And our focus is still not there. Why we are not talking those highest parameters of life and livability and wellness when it exists? Our country does not even talk about it. Is it that unachievable? Why are we hiding it? Why are we not into the competition? We becomes the most polluted city, but not livable cities. And the parameters are very interesting. It's stability, cultural integration, infrastructure, environmental thing, and health. So if it can be Google searched, much more there. So what I did was, I took those parameters of livability cities to livable communities. So it is like bottom to down approach. So it has safe, and if our communities provide us safety and stability, it reduces stress and violence. If we have better environment and cultural health, it improves our well-being, right? So like when you go to Austria, Mozart becomes a phenomena, a cultural event, right? A singer there, a musician there. But we are somehow losing into our own cultural identity. We are not preserving our local artisans. Why? And that is one point of a biggest sell in those countries. Healthcare access leads to preventive and curative care. Infrastructure development provides connectivity and accessibility to everybody. Quality education creates resilient communities because education is the bottom line. If we are educated, not just because of the degree, but if I am aware about that quality of life is much more important than per capita income, my approach towards the life and earning will change. We are quite confused between life and livelihood. Please ask your own questions. Am I only working for livelihood? Where is my life? And that comes an answer with the doctors who treat patients. So healthy people needs healthy communities, and healthy communities must be intentionally designed. It doesn't come by its own because we have destroyed the nature. So I propose a framework here because we are scientifically approached people. So care, so co-create. Can we develop the communities so the areas and the medical doctors where they work, can you also bring people and towards a more happier life? So it is not one person's responsibilities, everybody's one's. Align it with the SDG goals. That is what the first speaker in the morning session talked about it. How can you align as an institute there? Redesign. Redesign streets and services to prioritize human needs, not vehicular needs, not infrastructural needs. We need humans to be more at the center point. Road accidents can be easily reduced. There are a lot that can be done. And evaluate. How do we evaluate? By numbers, that I have done these many kilometers of road infrastructure or those many houses have been built? No. It is all about my satisfaction towards life, my quality of life, and I have already given the parameters of life. There are many scientists who have been working and giving the metrics to measure it. I'll show you a couple of. Now, having understood the theory of the first session of first scientific part and my session basics, I'll give you some live examples by local people and by the scientist. So this is, how many of you have been to this place? Anybody who has experienced this place? So this is quite famous all over India. And here, every single thing is zero. If you see it here, it's a zero waste space. And this is a person not highly qualified. But if you see the database the person maintains, the local juice shop owner. He maintains everyday database of waste. Now imagine, there was an argument in the first session, how we will do it? I have to do research, this. It's so simple. One of the students after every event can see how much waste is generated. The next event will have lesser waste. Next event will have lesser waste. After 3 years, probably it will be a zero waste campus. People are doing, it's just that we are not listening to them. This is very, very interesting. We talk about malaria database. I heard in your inaugural. Malaria, we all know why it is there.
2 a.m.
Why we have to take certain vaccines before we travel to Europe. Right. So why are we not answering the fundamental questions?
The narrowest lanes,
there is no
crowded
malaria.
bazaars, old city
Right. So this will not take
streets,
away the
everything was
job of
cleaned till
doctors.
sunrise.
We will be
Collector
probably just like how
Nayak
AI is
was personally
redefining
monitoring the operation
role
on a
of
scooter at midnight.
professionals.
Alongside him,
These roles
Municipal
will
Commissioner
redefine our own
Sarah walked through the
positions.
markets, encouraging workers
So
and
here
distributing sweets.
we talk
While
about
most city
partnership.
officials inspect from
It's a
AC
partnership
offices,
example
Jaipur's officers
of
were
the
on
SGD
Activas at
when the
2 a.m.
government
But
has a
why?
good intention
Because the
bureaucracy.
city has one goal, to
People
make
in
Jaipur
charge
one of
of
India's
cleaning the
cleanest
city,
cities. And this
professionals,
wasn't
those
their
who
first
are supposed to
move.
do,
Under
plus
Safai
people.
Seva Marathon,
We decide
Jaipur
things
cleaned
happens.
6,000 tons
So let us
of
not
waste
target
in a
too high
single
of the
day.
partnership.
Under
We have
Rang De
partnership in
Gulabi,
our hand which
500
we
plus
can
walls were
definitely
beautified. Now
leverage
comes
upon.
Operation
One of the best
Clean
example.
Sweep. The
For the
administration
time
has one
purpose,
message
I'll
for
go to the
citizens.
next one.
We are cleaning the city. You help keep.
Anyone who knows this? No? Okay, small video.
This village has a top-up card for water, fully digital classes for
Bangalore has
students,
recently
and is
issued an
100%
advisory to
plastic
save
free.
water.
Sounds like a smart city,
But
right? Welcome to
we can see around
Adachivadi,
us
a
how
village
much water
near
is
Pune.
wasted.
Here,
During the
cleanliness isn't a
lunchtime,
campaign,
during
it's
the
a
tea
habit.
coffee time,
Every week,
we
villagers
leave the half
collectively
water
clean the
bottles.
village. Waste
Can
is
we do
strictly
something like that?
segregated into wet,
It's
dry,
called
cloth,
community.
and plastic.
We build
Dustbins are
community.
pinned on maps, so
Each
even
one of us
outsiders
build
know where
community.
waste goes.
Then we crib about
46
population.
CCTV
It has
cameras
nothing to
don't
do
just
with
watch
population.
streets,
It's
they
all
ensure
everything to do with
accountability. And when systems work, results
An
show.
excellent example
Roads here are
of a
smoother
small
than those
village
in many
which
metro
teaches
cities.
us a
The
lot.
drainage system is built to last decades. There's a park better than most urban parks. Over 90 solar panels power the village, and the school is fully digital, with every student using laptops and tablets. Even after the bell rings, retired teachers step in, teaching children for fixed 3 hours every day. The village is 100% plastic free by choice. But this wasn't always
that's very
Adachivadi's
important.
reality. The village once faced severe water scarcity. Water was wasted, there wasn't enough even for irrigation. Today, careful water use has changed farming completely. Pig is now the main crop,
I
and
want to
nearly
highlight
70%
here
of farm work
the
is done
RO
by
water
women.
technology.
So what
Each
did
one of our houses
Adachivadi
has.
do
I
differently?
made a choice
They
of not
built
to
a
have an
system.
RO water
Contractors
because
were
there is
removed
a
to stop
parallel
leakage.
wastage of water.
Villagers pooled their own money with CSR
RO water
funds.
was not
Rules were
supposed
followed
to be at
strictly.
houses,
Work
it was
quality
meant
was
for
monitored by
industrial
the
purpose.
community itself.
But there
Every
is no check
decision
and
was
balance in
collective.
India.
Every
We are the
rupee was
probably the
accounted
only
for.
country
Adachivadi
which has
proves how
RO machines.
collective ownership can
Why?
reshape
We need to
India's
ask
future. Do
ourselves
you
and we have
think
to
our
ask
cities should
our
adopt this too?
governments.
Comment below.
So
2,500 sanitation workers.
this is a bio village. I'll skip this video because it talks about solar panel and various other initiatives in organic farming and all that. But I have a question here to ask. Why am I showing these things? How it is connected to your conference, which is doctors. The profession is medical profession. So why it is so? Any thoughts there? That's a research topic for all of us. As a researcher, when we have such kind of spaces developed by the communities, can we measure what is the impact of such beautiful initiatives on the health of the people and the community there? And when we record it, and when we develop the parameters, it should be replicable for the entire country in the similar spaces. So that is the reason I said, because when we talk about all the accreditations, I am also one of the faculty, we all struggle like how to have the industry impact, societal impact. These are real case studies. We can actually create, I hope you all have heard, because you are doctor professionals, you anyway have live patients, but there is something called a living lab. Have you heard about that? So GIS has made it popular in India, living labs. So what we do is, I'll give you an example in the next slide of mine.
क्या आपको पता है इंडिया का पहला बायो विलेज त्रिपुरा में है? जी हाँ.
Imagine Tripura has it. This is one I'll surely want all of you to see.
Food isn't cooked in any house of Gujarat's Chandarki village. Instead, the entire village's food is prepared in one place, where everyone gathers to sit and eat together. If you're wondering why, the reason lies in it being the village's antidote to loneliness. With most of its youngsters immigrating to cities in India and abroad, Chandarki was left with a large number of senior citizens. So a group of villagers started a community kitchen to help the elders get some much needed rest. This started the tradition of village cooking in a shared kitchen and eating meals together in a solar-powered AC hall. This has now become a place.
So coming to the research point of view, what research can we take out with this? It's a quality of life, well-being, healthcare professionals. Can we do multidisciplinary research in such spaces? Of course, yes. It's the word which we use is care economy, right? It's a big one. And what are we doing? See, we are taking pride for a few decades. We are the youngest population, large population, productive population. What will happen after a few years? The same population is going to be elderly, and we sitting at the academic institutions and the research institution need to predict the future, give the policy recommendations, how it is going to be too. So that is what is a job, and a very high responsible job that we owns. Now, there's just few things here. As we have been talking about, SDD3 cannot be looked in silos. This is from my experience that I have written it here. So how can we blend it? So health with transport, food choices, clean neighborhoods, clean air, water, and soil, consumption patterns, which is responsible consumption, waste management, natural ecosystems, industry waste. We are in Kolar mines, right? We all know what is happening. I literally kept this, keeping in mind this. And I wrote there mining activities, which is geographical spaces and how it is impacting. The biggest threat, we may get fascinated by AI. I have a basic question to ask. Can healthcare professional give advices to the patient that you can live without water, but you cannot live without AI. Or can an individual human being does this? Yeah, we cannot do this, right? So why are we allowing data centers which are consuming all the drinking water here? We have done few studies. That's government study for the adult, where we have talked about quality of life with women's segment, and we recommended the policies. There was another study in Bangalore, again collaborated with government, Church Street First, where it was a living lab. The street was converted into a completely pedestrian street to have the quality of life there. There is another city of Metro Yellow Line. If it gets operational, how it will impact the health. So these are the studies we and our team has been doing. And I would also like to emphasize on this because we are researchers, and I thought that I should put up a slide here. And I stand here for multidisciplinary research, why it is important. And for the takeaway for the researchers, the young professionals here, the doctors here, these are the journals which publish all the kind of studies. Only Sustainable Transport and Livability is Taylor and Francis. The rest are Elsevier journals. And they are highly cited, highly respected, and they are having good articles for multidisciplinary research. And that's where probably I was invited and standing here. So shift beyond healthcare, treat illness, asking how do we treat illness, or move towards design healthy communities intentionally, asking how we design communities that help people remain healthy. So quality of life is not only about how people live, but how to be able to live a happy, healthy life, which is with respect to physically, mentally, and socially independent life. So with that, thank you so much for your time and patient hearing. I hope I added the value to your time because all of you must be waiting for your lunch. So truly appreciate, and thank you, Chair, for giving me the opportunity.
Ma'am, at the outset, I really want to appreciate the Pradeep and team for choosing you as a speaker on this topic. And it was a wonderful topic. If you see, we represent community health. And one of our definition is what you had put, social, mental well-being. To add on to what you have told, the wonderful is all the community health is working for enabling environment. And really, it's very nice to see the positive impacts which you have brought with your own works. Two things, as a researcher, the present investment is more on blue zones, as you already told, and it's wonderful work which you have done. Thank you for the wonderful talk, and I open up the audience if they have any questions.
Everybody is hungry.
Yeah.
And yes, please. Thank you so much. Yes.
Long back, we lost a track. This forum lost a track in health administration, and we gave up our responsibility of pushing through the policies at the policymaker level to IAS people, right? Today, it's a reflection, again, after 30 or 40 years later, we are actually, you are showing us a path where we are missing again in losing out on our, what the 5 elements, how we should train,
Yes.
teach, and expect the patients to live harmoniously with the 5 elements.
That's right.
That's a good thing.
Thank you.
That. Next is, with your exposure with multi-sectoral things, have we lost the war, or do you have hopes still?
Oh God, very difficult questions, because each time when I work with government, many a times I lose the hope. But then if I lose it, then how we will take it forward? Somebody has to take the burnt of it. And the path of honesty or sustainability or this are the difficult paths. Some of us have to walk. So I just remember and remind myself always, I go back to Gita when I get totally lost, why I'm wasting time when nothing is happening. So I go back to Gita and it reminds me, there were 100 Kauravas, but there were 5 Pandavas. Do we want to leave Hastinapur to Kauravas, or Pandavas should fight? That's a choice the sustainability advocates have to make. One day we will win, and hopefully we'll make our cities, the Mother Earth, one more time livable, not dreaming just to go to Mars.
Ma'am, it's a wonderful thing. I would like to add on to what Madam told, sir. Sir, if you travel, I think Madam told Shafai Zala, and I was there last week in Tripura for regional review meeting.
Yeah.
There's a wonderful sanctuary, animal sanctuary there. Sir, the work is happening across the country. If you see Nagaland, there's a global village called Kohima Karu,
Yes,
which is
beautiful.
working wonderfully. And if you go to Gangtok, Gangtok town itself has implemented most of these things.
Exactly. And you know, much before the Clean India campaign, Sikkim was the cleanest. I visited in 2006 and it was beautiful city. So it's a choices they have made. So we all have to make our own individual choices. And as you said for the first point, that you could give us the way forward, I kept in mind the theme of the conference, SDGs and way forward. So I thought that it should have some meaning in it for the future discussion and the future course of action. Yeah, but we have time together. Still together, we can work with multidisciplinary approach in research and scientific manner to prove it right.
Thank you, sir. Thank you, ma'am. Sir, we have one more question.
Yeah. Two things I wanted to just reflect. Number one, see, you asked one question in the beginning, first part of your presentation, that are we going to achieve it when it comes to the 17 indicators? See, I was in touch with a few people from UN also yesterday, and a review which was done in 2026 early says that the time is too short, and the achievements so far have been only 16.5% of all the, if we track the entire thing, only 16.5%. At the same time, it is something, perfection is working towards perfection.
Yes.
We should not get worked up on that.
We should not. We
But
should maintain
at the
quality
same
each
time,
point.
but at the same time, there is an encouraging thing. Encouraging thing is Finland
Yes.
stands first.
Yes.
Denmark stands next.
Yeah.
And those things, it is, and France comes within the first 10. France come. There
France has
so
gone down in ranking, sir, for many parameters. Yes.
yeah, but still, we should not go behind that. That's one thing. Second, I wanted to ask your reflections on, we sometimes speak about the happiness index in Bhutan.
Yes.
Some of the areas which you told about the studies, and these are innovative. Good that and you are asking us whether health profession can take it. See, health always has to be viewed as part of development. Unless we look at as part of development, it doesn't become, encroach upon the areas which you are mentioning. What are your comments on happiness index? What is spoken in Bhutan and the studies which you have done?
Yes. So happiness index, I'll just take 30 seconds to finish this answer. To the point, sir, rest we will discuss it afterwards. So happiness index, you know the fun part of this? In 2016, when I was preparing for this Indo-Dutch research project for Kumbh Mela Crowd Dynamics, I looked into the literature review. And I found Harvard is giving the happiness indexes, the parameters. And I was asking a question to myself that Indian culture, which is so sustainable, have always been looking for people happiness, why there are no research papers? And I still did not find the complete scalability of measuring the happiness, though Bhutan is our immediate neighbor. So, sir, I think that's the whole point that I wanted to emphasize on multidisciplinary research. I'll be very happy to reach out to all of you if we can discuss later and take the work forward. Let us develop that, sir.
Thank you, ma'am, for that insightful session. Now I invite Dr. Pritish sir, Dr. Prasanna Kamath sir, and Dr. Srinivas sir to felicitate Dr. Meghna Verma, ma'am.
It is an honor to have you here, sir. You was the first awardee. So, thank you.
Thank you, dignitaries. Now I invite Dr. Ranganath sir to felicitate all the chairpersons of this session.
Thank you, dignitaries. Before we start the third session, scientific session, I call upon Dr. Siddharth Shekhar Mishra, MBBS, MD, AIMS, New Delhi, DNB, SPM. Former senior resident, PGI MER Chandigarh, currently medical reviewer, Google Docs, faculty of Delhi Academy of Medical Science, who is also a sponsor for this Catch Conference 2026.
Okay. Post-lunch session, and I can see the senior faculties over here. So probably the audience would not be right for me as a junior person to be speaking on the stage as of now. But this session is mainly meant for the people who have joined this branch as a resident. So I'm just here to take your 10 minutes to make you understand that, guys, this branch is different as compared to what a clinician looks into. And that is the reason I would first and foremost request the seniors, please no offense sir, I'm just trying to tell my juniors what they should do to reach your place. So this is just my views over here. Being from AIMS, from PGI, I got a chance to get trained from the best people, and also in the last 15 years to be trained from the best minds of our country and abroad. Couple of my seniors are also here who are listening to me, so that gives me a bit of jitters as well. I could hear in the session prior to this, ma'am made a fantastic presentation on SDG and the trauma which we get. Now, generally as a student, we used to think, when will I be able to make such kind of research? When will I get a chance and how can I make it? So before that, we need to understand the challenges of our branch first. See, please understand, as a postgraduate, whoever is sitting in this class or whoever would be listening online, our branch is different. We are classically the engineers of medical field as well. So for us, a stetho and a laptop both are equally important. And this is the first thing we need to understand. With AI coming up and we using AI rampantly, it is not going to answer a community medicine person's quest. I'll give you a very simple example to it. The moment we get an article, being a reviewer for PLOS ONE and BMJ, the moment I get an article, I independently put it into the AI software where I check for AI. BMJ sends me a report stating that this article has this much of AI, but still I check it. That is the first point where we will reject the article. The same goes for a funded project. The moment you write a project as a resident or a young assistant professor using a AI, we actually check it for that. And next is plagiarism. Earlier, when I was a student, we checked plagiarism. Now we check AI as well. So AI is not a friend of a community medicine person. It is rather the biggest enemy. So as a resident sitting over here, please stop using AI if you want to learn this branch. Next, we have to go to the field. I could hear from ma'am that she mentioned she has been to places which are the bordering state of our country and various places over the world. Trust me, you ask me, I will tell you, if you want to do good, go and serve in Bihar and UP for a year as a young resident after your residency. We call it as Makkah and Medina of public health. No AI works over there, but we learn a lot. Similarly, probably will be Kolar. We all have seen the movie, but this movie is one part. What about the occupational hazard? You want to learn it, go to the field, just look into few people working there, you will know. So this branch is different. Plus, we use a lot of maths. Trust me, as doctors, we have entered this branch because we hated maths. But our subject uses a lot of maths. So stats is important for us. We do not know. Last, the global volatility which is there. Earlier, for a resident, the easier way was to enter into an international agency. Now, with the global volatility, it is very difficult actually to get into these organizations because these organization is not exactly functioning smoothly the way it should. And that is what, for a resident, if you ask me, these are the 4 paths which we say. But before that, as a resident, I have just chalked out that for every year of PG, what exactly you are supposed to do. So as a first year who enters, we always say, start with the Park textbook. There cannot be a better textbook than Park which gives you everything. You put up in the second month probably your topic and your thesis. You read books. Please understand, we have separate books for every chapter of Park. If you love epidemiology, start with Leon Goddess. Yes, sir is here. Yes. So we also bonded over a course when we learned it probably 10 years after passing a PG. So that is how a PG also learns. So this is something which you should do. Second year, you just upgrade it. So once you are done with Leon Goddess once, read it again. You would realize there are more things to do. And probably in the final year, you end up publishing your first manuscript. One of the students outside whom I met, the student told me, sir, is there even there a value to publish as a PG? The answer is, there is a value to publish even if you are a first year MBBS. Because that tells me you know how to write. You know how to actually put up a referencing. Please understand, we use a very peculiar referencing. That is one big deal which a PG should learn. So all the postgraduates over here, this is important. You go above this, that's okay, but at least do this. Additional, put up some 6 monthly targets, be updated. We have so many conferences. The national body of IAPSM, IAPHA, they are putting up so many courses. We just need to see it and learn. This is an excellent conference, you get a chance. See, as a student, at our time we used to wait once a year, one conference once a year, that's what was allowed. Now you get it more. Join WhatsApp groups, Telegram groups. These days there are so many groups. Even the Ministry of Health runs a Telegram group to give us updates. What is your path ahead? To keep it very simple, as a postgraduate in community medicine, probably we have the most structured path called as a senior residency. There are various options to it. We become a faculty at a government medical college, private medical college, or the Central Institute. We can look into higher studies. DM courses have been made available now at the INICT colleges. PhD is definitely available. Masters in Public Health is there. We can join directly into NGOs like the PHFI or the Government of India's IHMR over here, ICMR. We have our World Health Organization, JAPIGO, so many options are there. But please understand, none of them is a hospital. So my friend who is a respiratory medicine guy or a gynac would join Apollo Hospital. I would join ICMR. So this is where as a PG we should understand. Some paths are unexplored. You can definitely go on to basically become an entrepreneur. Please understand, PSM is one branch which gives you a lot of chance for entrepreneurship. We have excellent young people now who are doing. One of the best example, you can go and Google today, Dr. Achisman Mahapatra sir, he has made up a council called as Grid Council. Yes, you can just have a look. He is just like us. 7 years down the line, he was just thinking about it. He started and now he has put up a absolutely a new thing which none of us had thought. But now we have many who are coming up. Now, just to give a reference to this is my batch from AIMS 2012 to 2015. If you look 10 years down the line, couple of them are faculty at AIMS Gorakhpur and at AIMS Bhubaneswar. One is a faculty at AIMS Delhi itself in hospital administration. So you can see one of our students actually digressed into a hospital administration stream from community medicine. One is a faculty at Maulana Azad, one at SGPGI. So if you see, we have 2, 3, 4, 5. Out of 8, 5 are faculty members already, associate professors at their respective colleges. One of them has built a setup of his own. He has started a startup. He did a PhD and now has started a startup. One is a scientist E at ICMR and one is me. So if you see, we 8 represent a batch 10 years back, just like you as students who are sitting probably at the back, sleeping around. Trust me, 10 years later, your name would be on this board. 10 years later to me, I would like to see myself in Sir's place or even at least 1% of where they have reached. Please understand, guys, our branch is very good, but it requires a different tango in your life. You cannot just sit back and relax because our branch is changing very rapidly. With digital health coming up, please understand, when I was a student, I had never seen NQAS happening. Then I went to a training of NQAS. Today we are doing digital NQAS. I had never thought. I had seen an ASHA worker weighing a child. I am a part of a project where we are using an app to weigh a child. And the size of the sample is 1 lakh. So 1 lakh kids across the country, I'm running a model to do it. I do not have any idea how it works 5 years back. But today, just by doing, I have come here. And the same works for these people. So the only request I have to all of you is please have an urge to learn. Everyone in this branch, there is nothing to compete. We have the whole world to win over. Please have an urge to learn. Just the last minute to conclude. We are running resident courses for so many branches. And for the first time, we are starting with a PSM resident course. This is only for the residents, only one in our country. We do not have a second one also. It started with 0 videos and now it is around 300 hours. If you are happy, you can just have a look. It's up to you, but the most important thing is to have an urge to learn. That is what I would like to tell all of you over here. Any queries, please feel free to reach out to any one of us who are sitting in this room, in your college, across India. But please know, public health in India is changing rapidly. We are people who can make a difference. The 2 things, what actually made me think in the last probably 2 months about why our youngsters have to become more dynamic. First, on the 1st of July, Doctors' Day, I could see every newspaper coming up with a huge list of doctors wishing them. I could not find a single public health person's photo there. This has to change. That will only change if as residents we step up. Second, please understand what my professor told me. Our value might even come after our death. And the best example he used to cite was the iodine project which happened in Shimla, in Kangra, in Himachal. After the death of the PI, you can go and Google it, we came to know that iodine is important. So our branch needs patience. It is not clinical medicine. So please do not do it. Just to end, whatever I am today, it's thanks to my teachers. So be thankful to your teachers. Learn from them. And also learn from your peers and your juniors. Here, we are here to learn. I do not know everything. My teacher does not know anything because public health is the whole planet. Neurology might only talk about this. Public health talks about the planet. So the world is here for you to grasp. Please do it, guys. We are relying on you. I don't want to die, whatever at age I die, stating that I could not see a youngster who attended this session actually replace all of us. We need to step up. And if you want motivation, just go to YouTube and see people like Abhay Bangsar in Search Gadchiroli. Monumental to change my view of public health as a student. If you do not know about him, go to YouTube. He's a clinician turned a public health specialist. See that. You will actually realize we can make more impact as a public health specialist. That is all from my side. Thank you. Thank you, senior faculty members, for listening me out. And I'm sorry if I went wrong, because I'm just on a mission to tell the youngsters that, boss, we need to step up. We need to come out from where the mindset is that if I don't have a stetho, I'm not a doctor. We are more making an impact than anyone else. Thank you, sir. Thank you, ma'am.
Thank you, sir. I now invite Dr. Ravindra Reddy, sir, Vice President of Karnataka Association of Community Health, to introduce the speaker for B.M. Patil's oration. Sir, over to you.
Good afternoon. I think long-awaited oration from Dr. Unni Krishnan, who received Catch B.M. Patil Oration Award in the morning, in the inauguration session. Due to delays in certain things, we have postponed now. He is already busy. He has to take the flight back, actually. I think we have introduced in the morning Dr. Unni Krishnan. I was fortunate when he was doing MD Community Medicine at KMC Manipal. I was the assistant professor at KMC Manipal. So today he has gone really heaps and bounds, if I see. And he's my sir now, I can say happily now. That kind of thing we have seen. And probably you would have heard 3 years back, he was quoted in the newspaper I came through. He was quoted as the top 2% scientist in the world. Am I correct? Yes, he was one of the person. So immediately if you see, just a glimpse of that. Morning already we have shown, in addition to MD Community Medicine and so many other things, he also has done fellowship of the Royal College of Physicians from Edinburgh. He has got more than 364 publications, H-index of 63 patents and 20 copyrights. And he has given more than 10 PhD scholars. And when he went, he took as HOD of Community Medicine at KMC Mangalore, there was no MD course. He started, in fact, MD course also. And then now he is the Dean of KMC Mangalore. And he's also in various committees at state and also at national level in some of the international, including NMC also is a member of committees, including the ethics committee. Since the time is not there, there is so much to introduce. I request Dr. Unni Krishnan to give us the oration.
Thank you, Dr. Ravindra Reddy, sir, my teacher. When I joined Manipal, sir was there to receive me as a young postgraduate student way back in '96. Thank you, sir. Thank you all the teachers here. Sudarshan, sir, I can see, and other teachers who are present here, and all the empty chairs in the auditorium, and all those who are there in between these empty chairs. Warm greetings from Kasturba Medical College, Mangalore, a constant unit of Manipal Academy of Higher Education, an institution of eminence deemed to be university, currently rated as the 3rd best university in the country. I am bringing the greetings from MAHE, Manipal Academy of Higher Education. Thank you. The Catch, Karnataka Association of Community Health, for giving me an opportunity. It's a lifetime opportunity for delivering this very prestigious Shri B.M. Patil Memorial Oration in Community Health. I was reluctant. I accepted this oration. Then something happened in my family. Then I told I cannot come. But I then thought that my father expired 6 days back, and that too he expired in Manipal. Then I thought that my father wouldn't be unhappy if I don't commit what I have promised. That is the main reason that I am here. And this oration is in the memory of I devoting it to my father, in memory of my father, late Shri K.G. Bhaskaran Nair. My topic for today, I was listening to the previous speaker, young guy, young chap, MD, community medicine, fantastic. Half the work is done, what he spoke. Half the presentation, I can just flip it and I can go ahead with my rest of the presentation. I am not here representing National Medical Commission, even though I am a member of the National Medical Commission. These are my personal views. I am a member of the National Board of Examination in Medical Science, otherwise known as DNB. That all these are my views, nothing to do with NMC or National Board. But I was just thinking that isn't the right time that we should think about community medicine? We should rethink about community medicine. Do we need to teach the same way how we have learned community medicine, or do we need to change the teaching in community medicine and to add things which are relevant for today? So then I thought that the paradigm shift in teaching and training community medicine postgraduates. Initially, I thought of postgraduate, but I thought of starting with undergraduate. What happens is that as an undergraduate, we teach community medicine from the day one. And we start with the topic, which undergraduates don't like it. And then they have the repulsion towards community medicine till the end, when they finish the community medicine in final MBBS part 1. So I was just thinking that why a paradigm shift is necessary. What is the traditional versus modern community medicine training, vision for future community medicine postgraduate, proposed curriculum model, institutional requirement for transformation, expected outcome of the paradigm shift. So I have prepared my presentation in this direction, why a change is required. We need to make future-ready competencies. There should be a paradigm shift in curriculum. We need to have some innovative teaching strategy, and there are expanding career options, not only in the academic pathway, but there are a lot of other pathways, not only academic, not only NGOs, but there are different pathways. I was listening to Madam, I was fortunate enough to listen to Madam when she had visited Mangalore for the IAPSM conference about health economics and all. So these are the pathways what I think that we need to teach the students, health policy, health economics, and all those things. And what are the strategic way forward? So based on this, I'll be delivering my talk. The first is transforming healthcare education. Healthcare education is evolving to meet the demands of complex technology-driven and team-based care environment. I am of the opinion AI should be implemented in teaching. AI is a very, very important tool, not for copying, but lot of things AI will do that will help us. AI is very important. We cannot do away with AI. Future will differentiate us with the doctor, community medicine person who knows AI and the community medicine person who doesn't know AI. That will be differentiation factor, and AI is going to be there, and better AI is going to come. Curriculum innovation and flexibility. What we teach today is okay, or we need to change the curriculum. I am seeing the curriculum, no changes have been made. When I joined community medicine in 96, now it is 2026, I don't see any change in the curriculum. I don't see textbooks are same. Curriculum is same. Park might add few chapters based on every year is Park. Now the popularity of Park is so much that every year they are releasing a new edition of Park, and Park is making money out of that. But do we have to restrict ourselves, and do we need to teach something extra? Do we need to teach them health economics? Do we need to teach them health policy? Do we need to teach them international health? Do we need to teach them translational health? So these are all the things we need to. And we need to be a part of the curriculum development. What needs to be there in the curriculum? Or still are we okay with what is the difference between rapid sand filter and slow sand filter? I have never seen a sand filter in my life. They have taken me to the sand filter, but I didn't go. I was somewhere else. When a mosquito comes, I don't know whether it is Aedes aegypti or I don't know because I'm not fine. Whether something happens, malaria happens here. Who is bothered about which mosquito has bitten you? So, do we need latrine? Do we make latrine? No, but we need to understand the concept. Do we need to teach our students or not? We have to rethink. I am not telling that whatever is old is gone. No, we need to incorporate newer things also in our curriculum. Preparing for future challenges. They see pandemics, when pandemic happened, sir was very well active in that. Except sir, I saw only very few community medicine people across the country. All cardiologists were talking about pandemic. All other, except community medicine people, all others were talking about pandemic. Karnataka government, I salute Karnataka government, at least they identified a community medicine specialist to head the task force for controlling the pandemic. Across our country, all the talk was done by cardiologist or cardiothoracic surgeon. Nobody from public health background. Technological, why change? Emerging 21st century healthcare challenges. We need to invest in technology. Definitely, I am telling you, we need to invest. If we want to train our postgraduate to be future ready, every institution should invest in technology. Technology is the mantra for the future. Like digital tools like AI, telemedicine, electronic records require healthcare graduates to be adaptable and tech savvy. Demographic and health trends, like for example, aging population, chronic disease demand, holistic patient-centered care approach from healthcare workers, global health crisis impact, pandemic. In pandemic, we have closed our district borders. We have closed our state borders. We live in Mangalore and Kasaragod is in Kerala. We have constructed a wall between Kasaragod and Mangalore. Like somebody will come from Kasaragod and infect people with COVID, and somebody from Mangalore will go to Kasaragod and infect people with COVID. So we were not prepared. We were not prepared to handle such mega-scale pandemics. But we have learned a lot of lesson from COVID. Lot of lesson. First important lesson, what did we learn? There is no need to have meeting physically. We can have virtual meeting. After that, my university has, I don't have to go to Manipal for any meeting. I have to sit in my chamber and conduct the meeting. Otherwise, I have to travel 70 kilometers and come back, just attending a 5-minute meeting. I can attend the meeting with Praveen Kulkarni in ICMR and I can sit in my chamber only. It has taught us. I can conduct an interview virtually. Before COVID pandemic, there was nothing like virtual. Every institute invested money on creating infrastructure. Every institute invested. So these are the things what we have learned. Our education is teacher-centric. Okay, teacher will teach something, learner will not listen. Why can't we transform it from teacher-centric to learner-centric? Now it is happening. After the CBME, it has becoming, but the problem is, curriculum will change. Everything changes, but we don't change. If NMC says that you need to have a small group teaching, but our teaching is always for 150 students or 250 students, we will not do 25 students teaching. Small group teaching never happens. And students also doesn't want to attend to small group teaching because we are making them to do work. The moment we ask them to do work, they will disappear from the class. In the large class, they are very happy. They can sleep in the class. They can play with their mobile. Everything. Their attendance in the large classroom is the highest. When I calculate the small group teaching, attendance is 10%, 12, I think it is same for all the medical colleges. They don't want to attend because we have taught to be passive learner, never active learner. If you ask a question in our school, teacher will get angry. Teacher will give a comment that you know more than me, you are questioning me. So why can't we think in that direction by converting the teacher-centric model to learner-centric model? engagement strategy. There are a lot of medical education people who are there, a lot of strategies are there for engagement. We need to work as a facilitator or mentor for facilitate their learning. There might be many books. The books which was shown, Park is there, Leon Goddess is there, XY, many to I also have not read. Okay, many books even I am seeing it for the first time. I have not read all those books. Park also fine. New Park I have not read only. Competitive CBME, competency-based medical. Now it is coming to the health professions education. We need to shift our entire education to outcome-based. Here we teach them thinking that they have learned, but we never never find out whether they are skilled or not, whether they are able to perform the work or not. We never look at it. Our job was to take a class, teach them, and go back. We never look. But when we start measuring the ability, postgraduate we can do it. Hardly how many PGs? 5 PGs, 10 PGs, not more than that per year. We can give them a task and we can teach them and we can assess them. Comprehensive competencies, continuous feedback, and faculty also should attend faculty development program, because we were taught how to teach 20 years back, but teaching strategy have changed over the period of time. The medical education unit should be actively involved in training and retraining the faculties how to take the class differently. Otherwise, we will be the same, how we were taught, the same way we will teach. But I am seeing over a period of time, maybe after the COVID pandemic, the love for community medicine has increased. I am telling you, one good thing pandemic has done is the love for PGs are joining community medicine, because they know the importance of the community medicine personal. Before that, when I say that I have done MD community medicine, half the people, lay person, doesn't know what is community medicine. What do you do? I have heard of general medicine, but what do you do in community medicine? Well, what general medicine do with one patient, I do the same within community. So we need to have a paradigm shift for that. Why paradigm shift? As I already told, evolving healthcare challenges, as I told, demographic shift, technological changes, and rising demands for equity and quality. Expanded curriculum focus should include health economics, global health, health policy, implementation science, and translational research. We have, I'll tell you that research, what my earlier speaker was telling, we experimented one thing. 20 years back, we made very sure that we will incorporate research into medical education curriculum. We did it. We made mandatory that every undergraduate student coming out of Kasturba Medical College, Mangalore, should have a research project with them. And we used to assess them when they used to come for their Viva, final year Viva. Then later, when our model became successful and we made it mandatory that this research project should be published. And if you get a publication copy, and they all do it, and they are very happy by doing that, and they have learned a skill. Okay, how to face ethics committee, how to write a protocol, how to change it, how to amend it, how to present it, how to do the data collection. All these skills we are teaching them. They have learned it when they become a postgraduate in any specialty, but the undergraduate teaching has taught them how to do a research. And later what we did, we converted that thesis research into publication. In 6th semester, we made it compulsory that the research project, what they have done in 4th semester, should be, it might be published or it might not be published, but research paper format should be ready and should be uploaded to a journal. And 2 years back, now NMC has made it mandatory for electives. What we did, we made an elective on evidence synthesis, that is systematic review and meta-analysis. Now students are taking up that elective, and undergraduate students are doing systematic review and meta-analysis for evidence synthesis. At least they are understanding the process. Entire process they are able to understand and they are doing it. At least they are reaching to a stage where they are registering their protocol into Prospero. At least that they are doing. Whether they do it or not, I don't know. But at least they are registering their protocol into Prospero, thinking that this is a publication, and they are very happy with that. Why a paradigm shift? Healthcare challenges today, as I already told, aging population, communicable, non-communicable disease burden, rising cost, and growing health inequities. We can always complain that government GDP is hardly 1.9%, ideally should have been 2.5% or more than that. We can complain with that. But how can we bring the cost? Cost can be brought by if we put a lot of emphasis on preventive health, we can bring down the cost of healthcare. Importance of preparedness, like many events like COVID-19 pandemic reveal the need for resilient and evidence-based health system. We didn't have any evidence when the COVID came. We never had, oxygen we have to give, remdesivir. We didn't have any evidence in that pandemic. We were experimenting by a lot of things failed, and because it's not that, because we have never faced a pandemic like COVID-19. We have never faced it. Now we are prepared. Now, Government of India is investing money on many districts to develop critical care unit for taking care of pandemic. So things are happening. New competencies required. New competencies like digital health, big data analysis, AI demand skills in data interpretation, and ethical governance. We do play a lot with big data, especially with global burden of disease we play. How we play? Global Burden of Disease is a very good publication. They come out with publications in Lancet and all those things. What we do, we have already taken a permission from Global Burden of Disease that please give us a permission to take the big data from their the big data so that we can reanalyze and do a subgroup analysis for South Asia, so that we can do a subgroup analysis for India, so that we can do a subgroup analysis, because that matters a lot. Because when it comes for the world, India becomes a very small part. But when we do a subgroup analysis among South Asia, we will come to know about many things which we can inform the policymaker. Then we can tell the policymaker where we should spend more money. Curriculum reorientation is required. Updated training equips postgraduate to address health challenges, policy. In the district level, during the COVID, how many of the community medicine department were involved, even giving the evidence to the deputy commissioner or collector? I don't think many of the institutes were involved, community medicine department. Where is the evidence? I am part of Cochrane collaboration. I do Cochrane systematic reviews. If I give a Cochrane one systematic review of Cochrane is 150 pages. Where is the time for a policy maker to go through 150 pages? What I do is that make a policy brief of half the page and give it to the policy maker. Otherwise, what happens? If you don't tell them properly, things can go wrong. I'll give you an example. WHO gave us a consultancy to find out evidence whether fortification of rice with iron will reduce anemia or not. Okay. So we did a Cochrane review for WHO, whether fortification of the rice, because if you look at the data of NFHS or DLHS, the real problem is anemia. We are not able to bring down the anemia level, but we are able to bring down the malnutrition, other thing. But anemia is a big problem even today. Even the affluent class, we see that anemia is a big problem. So they wanted to tell them whether fortification of rice with iron is beneficial for preventing or reducing the anemia or not. We did a systematic review. In the last paragraph, we wrote, there is some evidence that if you fortify rice, it might benefit, but it is a low-grade evidence. We wrote it very clearly, low-grade evidence. But what government did, they implemented it. And telling that we have advised them that we can implement it. But in the policy brief, we have mentioned that it is a low-grade evidence, because when you do a secondary analysis, unless your primary data is robust, you cannot put garbage inside and expect gold to come out. If you put garbage, which comes out will be garbage only. If the primary studies are poor quality, what comes out also will be poor quality evidence. And you cannot implement poor quality evidence into the population or the community setting. And then government started questioning us. Not government, newspaper. Sir, your study says that giving iron, because then what happened, especially in Karnataka, midday meal, they started supplying fortified iron, rice fortified with iron. And the newspaper reporters, they asked us. I told, this is the thing what we have told, that evidence is low grade, not a high grade evidence. Then ICMR told us, why can't you do a study on fortification of iron with rice? I did with iron with rice, Holla did with wheat, milk, oil, 5 consultancies they gave us. Apart from rice, I don't think anything else benefited. Very less benefit was there. Traditional method, as I told, we were only focusing on thesis. You do thesis. Arey Baba, once you do thesis, then do what? Your room will be full of thesis only. I always tell my postgraduate, if you don't disseminate your research finding, it is equivalent to you have not done the research. If you do a research and put it in the shelf, it will lie in the shelf only. What you have to do, you make a 20-page thesis. Fine, I don't have a problem. Publish it. At least you are disseminating what you have done. If you don't disseminate it for me, it means you have not done it. Because you have wasted your time, money, material, everything without disseminating. Dissemination is a very important thing. Earlier, you do, if I have to do, as a postgraduate, if I have to do thesis, I will go to Davangere, I will go to KIMS, find out what thesis already has been done, take out the topic, give it to my guide, sir, I will do it. Guide will say, okay, this you can do, I will go back to Davangere, KIMS and Bangalore Medical College, take the data from there, I will do something and deposit it. We have to think beyond that. We have to think, what is the utility? Are we able to translate that? Are we able to make out certain policies out of that? We have to rethink on the topics also. Nowadays, what I tell my faculty, every department faculty I tell, before a postgraduate comes to department, please have some research question in your mind and give the research question to postgraduate, some 4 or 5, and ask him to choose which one he or she wants to. Otherwise, we are wasting time. 6 months, we'll ask PG, find out a topic and come back. He will go and get 10 topics. No, all 10 are useless. You go back. He goes back and comes, already 6 months is over. You have to submit your thesis 6 months before the examination. So what will he do? If you have a question, give it to the postgraduate and do it and help them to do it, so that definitely that research would be used for publication, and if it is a policy related, might be used for policy. Modern, as I told you, should be systems oriented, because we have a very less resources, very minimal resources, but we have to utilize the minimal resources to the fullest extent. We don't have much money for health. We have less money. Where do we need to use that money is very, very important. Impact on public health. Enable graduates to design sustainable interventions and influence health reforms effectively. Vision for future community medicine, integrated health knowledge. Clinical knowledge is very important. Integrate with health system, economics, and policy insight. Multifaceted health problem analysis. Analyze health. Health is not a single domain. Analyze health with epidemiological, economic, social, and political perspective. Ethical practice and lifelong learning. Integrating healthcare financing into the curriculum. Very, very important. We don't know budgeting. Healthcare financing. You have to integrate the postgraduate education, healthcare financing, for equitable and functional health system. Integrate benefit, what they help learn, understand how to generate the fund, how to pool the fund, and how to utilize it for health services. And applied learning and policy impact is very, very important. Health economics. I was so happy that Madam has done a course on health economics. Why can't we integrate health economics as a part of MD community medicine curriculum? We have to do it. Health economics is a very, very important component. If you look at it in our country, hardly very few trained health economics persons are there. After MD community medicine, I advise my postgraduate, go to UK, go to US, or go to India and do some course in health economics and come back. You will be a very important person in the country. you might get a good job in the country if you are knowing health economics. Health economics is very, very important. We were theoretically learning cost effectiveness, cost benefit, and cost utility, but we never implemented it. Health technology assessment, that is really important thing we need to integrate into our community medicine curriculum. Informed priority setting, because we have a lack of resources, you need to find out where resources need to be placed. Evaluating public health intervention, like there are a lot of interventions are there, whether it is useful or not, we need to evaluate, we need to teach our postgraduate how to evaluate it, evaluation of vaccine, screening program, and new technology. Economic concepts in health, opportunity cost, marginal analysis, and equity to guide transparent and accountable policy making. Global health perspective, because health is not limited to local level or state level or national level, global health. Any crisis globally can have an impact on our country. Global health perspective, we should teach our undergraduate, now our postgraduate, about the global health perspective. Education covers international health, regulation, global disease burden, and comparative health system. Health policy, we need to teach them health policy. We need to teach them understanding of the policy process, how policies are made, how can we transmit this policy to the stakeholder. Relevant stakeholder require relevant policy brief. If our stakeholder is a doctor, you can go for little in depth. If he's an IAS officer, you have to make it small. Minister, 2 lines, not more than that, because they don't have time for all those things. Then skills for community medicine, we need to train them how to write a policy brief, stakeholder, for whom are we writing the policy brief. You need to identify the stakeholder and legislative, so that stakeholder will give it to the politician. Bridging evidence and decisions, health policy research helps specialists ensure policies are effective, feasible, and contextually appropriate for better outcomes. Implementation science is very important, bridging the no-do gap. Challenges of implementation, we can see, okay, these interventions are good, but does it work in the real world situation? It might not work. Maybe there might be cultural factor, there can be social factor. I was reading an article that Government of India has made a decision that obesity is a major problem in our country, and to measure obesity, all the healthcare workers have been told waist-hip ratio need to be measured. Then I saw an article written by Dr. Srinath Reddy that how to measure waist-hip, whether culturally it is acceptable or not, whether people will allow, ladies will allow us to measure it. No, they will not allow. But what are the alternative things to measure it? He has written a very beautiful article on how to assess obesity. So we need to find out what works in the community or what doesn't work in the community with respect to the cultural norm, social norm, and other norms. Role of implementation size, how they will take up the evidence-based, whatever we are giving, skills and impact, develop skills to design strategies, monitor outcome, and adapt intervention locally to improve systems. Translational research is another important. Bridges discovery with practical application to improve health outcomes in community. Training and skill, we need to train them with regards to the translational research and impact on health system, how translational research will have an impact on health system. Competency-based framework, alignment with real-world situation, integration of competencies, learner-centric, as I already told, flexible training, support for accountability and priority. What is our priority? If I talk about priority, in my district, what is the priority? State level, what is the priority? National level, what is the priority? Nowadays, ICMR, they give us a checklist of priorities. If you apply for the priority, if any study, we need to get funding from ICMR. If we find out what are the priorities about the Government of India and we apply for that, and chances of getting funds have become much easier because they have already identified the priorities. Innovative teaching strategies, I already told. Active learning, I have already told. Experiential learning, field attachment, that we need to encourage our postgraduate to go to the field, work in the field, give them attachment with the program officers in the community to find out what is happening and how it can be improved. Competency development focus, as I told you, from passive knowledge transfer to active competency building. That is the thing. Nowadays, we need to become not a teacher or guru, we need to be a facilitator and a mentor. Digital health and artificial intelligence are not going to go. It is very important that our undergraduates and postgraduates are competent with AI and digital health. Digital health tools, AI training concept, and curriculum integration is very, very important. Our curriculum should integrate with digitalization, digital health, AI, and what is the utility of that. Reimagining research training, traditional thesis focus. Traditionally, you come, talk about thesis, survey, finish. Survey jana sukhintaba, finished. You do a health survey and your community medicine things are over. Policy research, what type of research are we doing? Whether it is policy-driven research, we need to look into it. Health systems and economic evaluation and evidence-informed decision-making. We need to help the stakeholders in taking the decision which is evidence-informed. Leaders, we are born, community medicine guys are born leaders. We need to instill some communication skills, leadership classes we need to take them. We can call external people to talk to them about leadership and all, because we are going to be the leader, maybe leader at the district level, leader at the state level, national, international leader also. Mentorship and role exposure and impact leadership on impact on health systems. If you look at our DHO, on all the districts in Karnataka, I don't think any community medicine, very few community medicine people have become DHO. Otherwise, you look at it, a surgeon is becoming DHO, ENT guy is becoming DHO without even a knowledge about community medicine or public health. When we are teaching differently, assessment also should be different. We cannot teach differently and assess the way we were assessed. Assessment also should be changed. Evolving assessment method, programmatic as a workplace assessment, real-world performance focus. Our real-world assessment strategies are designed to reflect real-world professional performance and drive meaningful learning. This is the proposed curriculum model, integration of discipline, balanced curriculum weightage. I am not telling old is waste. Balance it with old thing, let it be there, what need to be taught and what did not be taught should be removed, and what should be taught now onwards should be added there. And holistic competency development should be focused. Career pathway, already he has informed us, like us, we can become an SR. Our time we were very happy. I was talking to Ravindra sir, he told me I was given lecturer post and other college offered me assistant, I went to assistant professor rather than lecturer. So our things are, you become dean and you retire. Okay, career, academic. The easiest way of entering into our community profession is academic. Okay. It may not be AIMS and that central institute, but at least a private medical college, you will get an appointment. Government, public, district level roles, DHOs and state and national role, central government agencies, you might get an appointment. EIS, many people have done epidemic intelligence surveillance, EIS program. They are doing quite well. Okay, this is also a career opportunity, but they need to learn something more than what a MD community medicine guys learn. Some extra course. Research, innovation, MD community medicine guys can get into research, organization, innovation, and even in the pharmaceutical industry, they have a huge role in pharma industry as a medical advisor, content writer, and all those things. International, you know that you can join international and global health organization. Healthcare management, hospital administration. As a Manipal hospital, we prefer MD community medicine for administrative roles because they understand better. Okay. They understand the government policies, they understand Ayushman Bharat, they understand it better. We prefer, not at the top level, but at the middle level, so that the person is good enough so that he can reach the top level. But healthcare, he need not do. He can do MHA later, but he need not do any. So it means that we need to teach them healthcare administration, hospital administration within the curriculum. Health policy economics, teach them, they are good. They can enter the field directly. Conclusions and key takeaways. Versatile career pathways. Community medicine is not restricted to academic role like us. It has a different, this thing, people are now going. I don't think many of our postgraduates themselves don't join community medicine academic. They go out to international, they go to hospital, they go to pharma, they go to different roles they play. Focus on preventive. This is the challenge. Rather than calling us, I don't know why it was known as community medicine, I think it should be known as preventive medicine. The understanding also would be much better, because preventive medicine has a better role, I am telling you, terminology of preventive medicine. If we are strong, nobody will go to the hospital. The preventive medicine is strong enough. Continuous skill development, continuously, because AI is there today. We learned AI. After 5 years, something else will come. We need to relearn, and we need to rethink, and we need to unlearn certain things which we have learned. Thank you very much for giving me this opportunity to spend some time with you guys. Thank you.
Thank you, sir, for your inspiring words. Now, I invite Dr. Ranganath, sir, and Dr. Sunil, sir, to felicitate Dr. Unnikrishnan, sir. Moving on to the next scientific session 3, we have spotlight presentations followed with panel discussions on reimagining healthcare systems for universal health coverage, trust, value, and people-centered care. A session by Swasti team, the Health Catalyst, with the Comprehensive Primary Healthcare Alliance and CPHC Design Lab, chaired by Dr. M.K. Sudarshan, moderated by Dr. Sudha Chandrasekhar ma'am, with Nachiket Moore sir, Dr. Suresh Shastri sir, Dr. I. Sushil Kumar sir, and Dr. S. Dhananjay Naidu. I invite ma'am and her team to start over the session, and also I invite Aditi Shekhawat to host the session.
Good afternoon, distinguished guests, respected faculty and colleagues, and some of the few postgraduate students we have with us here. Hopefully you're all here voluntarily with us. Let me acknowledge the obvious. This is the post-lunch session, and historically, you know, this is where we lose audience. So I really thank you for being with us even after the lunch. So by principle, we've designed this to keep your attention with us because we are in the business here to talk about continuity of care, and we can't go ahead and speak about it if you can't have your attention. So a very warm welcome to reimagining healthcare systems for UHC, trust, value, and people-centered care. We have become fluent in talking about universal health coverage in the language of money, schemes, packages, empanelment, claims. The language matters. It has protected millions of families from catastrophic expenditure. But financing a hospital bed is not the same as keeping a person well. A system can be financially protective and still be clinically episodic. You can be fully covered and still be entirely alone. So this session asks a harder question. What would it take to build a system that people actually trust, return to, and stay with over years and not just periodically visit? 3 shifts that we're going to frame in next 1 hour. 1, trust, which is moving from more episodic visit to continuous relationships. People, which is treating communities as partners in care and not recipients of it. 3rd, alignment. So financing that rewards keeping population well and not treating them once they're unwell. So for the next 1 hour, I'm in effect the referral system, so I'm going to be calling people, calling our speakers and rest of the panelists over. And since I'm told that one of the most dangerous lines at conferences is just one slide, just one next slide, so I will be very strict with the timing that we follow here. And for the flow, I will first invite our chair, our moderator, and our panel to the stage. Then we have 3 5-minute spotlights from people building this in the field that opens into a full 30-minute panel discussion moderated by Dr. Sudha Chandrasekhar. Then we take your questions, and we close with the release of CPHC Design Lab's India Landscape and Strategy Report. It is my privilege to invite our chair, our moderator and our panelists to join us on stage now. It is a particular privilege to introduce our chair, because in this hall he needs no introduction at all, which of course has never stopped anyone from giving one anyway. So Dr. M.K. Sudarshan is Founder Secretary of Karnataka Association of Community Health, the association whose 36th conference we're sitting in today. He's ex-director and retired dean and principal of Kempegowda Institute of Medical Sciences, where he led the Department of Community Medicine across 4 decades of teaching, research, and practice. He's founder, president, and mentor of the Association of Preventive and Control of Rabies in India, the president of Rabies in Asia Foundation, work that took a disease this country that quietly accepted as inevitable and turned it into a problem with a policy, a protocol, and a program. So a great many people in this room are here because of an association you've helped build. So thank you so much for joining us. Our moderator, Professor Dr. Sudha Chandrasekhar, CEO of Swasti, the Health Catalyst, 24 years across government, the World Bank, National Health Authority, and Karnataka's own health system. First rank in her master's from Rajiv Gandhi University of Health Sciences, advanced training at Pompeu Fabra, Barcelona, and London School of Hygiene and Tropical Medicine, and in 2024, elected Fellow of the Faculty Public Health at Royal College of Physicians, London. She has seen universal health coverage from policy table, from field, and from evidence. Dr. Sudha, welcome. Panelist, Dr. Suresh G. Shastri, Joint Director for ABDM and Digital Health with the Department of Health and Family Welfare, Karnataka. Director Medical at SAST, More than 76 publications and co-founder of paper on Karnataka's online referral framework under Ayushman Bharat Arogya Karnataka. If you've ever wondered whether a referral system can be designed rather than merely hoped for, Dr. Shastri has the data. Welcome, sir. Nachiket Moore, he's an economist by training and a health system designer by vocation, visiting scientist at the Banyan Academy of Leadership in Mental Health, and visiting professor at the Indian School of Business. Few people in this country have thought as rigorously about the architecture of a national health system, and fewer still are as willing to question its most comfortable assumptions. Nachiket, welcome. Dr. I. Sushil Kumar, Project Manager for Ayushman Bharat Digital Mission at the Department of Health and Family Welfare, Government of Karnataka, trained in community medicine at Bangalore Medical College with field experience running from COVID vaccination across BBMP to statewide digital rollouts today. He's the person who finds out whether our digital architecture actually works, not in slide deck, but at a health center. Welcome, Dr. Sushil. And Dr. S. Dhananjaya Naidu, Lead for Partnerships and Innovation at Access Health International, 17 years spanning health insurance operations, Deputy Director at SAST here in Karnataka, and Lead Consultant at the National Health Authority, where he's a core contributor to the health benefit packages under PMJAY. He sat on both sides of the claim. Welcome, Dr. Dhananjaya. Panel, thank you. Please make yourselves comfortable. We have 30 minutes of moderation happening right next to the spotlight presentations. Our first spotlight is on CPHC Design Lab itself, and on what we learned when we stopped asking what is missing in Indian primary care and asked why the pieces are already what they have to do to fit together. Dr. Balkrishna Korgaonkar, BK, is an Associate Director at GDI South Asia, a physician with an MBA from IIM Ahmedabad. He has worked across India, South Africa, Ghana, Uganda, and Kenya on tuberculosis, HIV, maternal health, non-communicable diseases, and primary care in both public and private systems. Before this, he led value-based healthcare at Roche Pharma. He's a co-author of the report we release at the end of the session. BK, welcome.
Thanks, Aditi. I'm going to talk about the CPHC Design Lab, which is an organization that came together with Swasti, GDI, and Indian School of Business. And we started this organization with the intent of designing CPHC models that really work for different contexts of India. It is also supported by CPHC Alliance and Leapfrog to Value. Our core hypothesis here at the Design Lab is something that, for a room full of people with background in community medicine, it's preaching to the choir, right? Basically, our core idea here is that today we spend very little on prevention. If we can increase what we spend on prevention and set up a system properly, then our expenditure on treatment, complications, and the DALIs would go down. So our overall cost will come down, but at the same time, we'll end up spending slightly more on prevention. So that's the core hypothesis with which the Design Lab has been looked at. To begin with, we decided to do a landscape of what progress has been made on comprehensive primary healthcare. This process was done through a deep listening process over 6 months. And as a result of that, the landscape and strategy report has been published. It will be released today. We looked at different areas of CPHC, the 8 areas that have been listed there. We had discussions with 22 different experts from government side, from payer side, provider side, tech and AI side, philanthropy, and other public health experts. And finally, out of this discussion, we really focused on 5 themes that emerged from these discussions. Trust being the first theme, continuity, tech and AI, outcome accountability, and financing as the 5 themes that emerged from this discussion. So what would the lab be doing? The lab would be actually testing a unique combination of accountable care, outcome accountability, financing models that are risk-adjusted capitation kind of models, and accompanied by an AI co-pilot for the doctors and healthcare workers. And brought together in this way, it can be a unique combination that can really help us deliver sustainable primary healthcare. So we request all of you to join us as partners, the governments, payers, providers, and managed care organizations. We invite all of you to join us as partners. Thank you.
Thank you, BK. Our second spotlight moves from design to machinery. Strategy documents are easy. Steering a live state program with evidence rather than instinct is considerably harder. That is the work of a virtual project management unit. To share the Andhra Pradesh experience, I invite Shankar AG, who's Director Swasthi Programs, 25 years across health delivery, workplace well-being, and institution building in India and internationally. Shankar, over to you.
Thank you, Aditi. Good afternoon, everyone. I don't know whether I can justify sharing everything what we do in Andhra Pradesh in 5 minutes, but I will try my level best to summarize. Swasthi is a global public health organization having over 20 years of experience on working towards public health aspects. One of the initiatives that we have been collaboratively working with the Andhra Pradesh government is about virtual project management unit using the AI power in order to reduce the expenditure, better programming, better efficiency, better program outcomes, adding a little thin layer to the existing system which delivers better value care. But at the same time, look at the demand and also see how we can bridge the gap with right expertise and also job cards. That's the model that we have been working for. And in this slide, you can see the traditional project management unit, what the traditionally operate within the government system, but at the same time, how AI-enabled or virtual project management unit can deliver a great amount of value and outcomes. I will not get into the details because of the time limit. In this, the overall architecture, we look at 4 stacks. You see the program stacks, which looks at the better planning, better execution, better optimization, at the same time accountability. And the second stack is about technology, bringing in technology, various technology tools that amplifies or augment the current work that government already been doing. I will give some of the examples in the coming slides. One of the aspects that we have been discussing about financing, which is very critical aspect in terms of, yes, the problem has been identified, there is a resource, there is a budget, how can we optimize it better? But at the same time, interoperability of the financing and other tools also important. The partnership stack, which is one of the core aspects in order to identify experts in the domain, either individual organizations, in which whenever problem identified, the thematic experts are available to meet the the demand, meet the the needs. I think that's the core. So I will not get into the details of below. If one job card has been identified, when I say job card, the problem, how the transit from the one level to another level, but at the same time achieving the citizens' well-being, that's the core, right? But at the same time, entire ecosystem, the architect you see, it enables better decision, better outcomes, and sustainability as well. So our idea is not to create parallel structure, but at the same time ensure the design is embedded within the government architecture, so that there is a ownership, there is a accountability, but at the same time they will sustain the learnings and outcomes, so that without organization like Swasti can also continue to deliver outcomes and results over the period. So that's the governance framework already been established right from the beginning. These are the few results I would like to share over the period. Just in 1 year, we were able to achieve the 40 job cards, and 18 medtech solutions have been identified and deployed on ground within 1 year span across the 14 districts where they're delivering the better results. But at the same time, 90% of the report accuracy in terms of disease prediction modeling as well, and over 150 specialists are already onboarded from local to regional as well as international, so that there are no dearth of experts needed at the right time to deliver what is need to be delivered. So I'll just quickly run through. This is one of the examples where how we supported in terms of evidence-based decision-making on various thematic aspects you can see here. And this is the MedTech challenge, one of the can say India's largest MedTech challenge that we helped the government of Andhra Pradesh to organize. There were 297 applicants, but at the same time 18 solutions were identified and deployed on ground for implementation. I will not get into the too much details on this, and this is one of the example where advanced analytics using RCH, where the government, the different team is using in order to better programming. And this is the precision health, another platform towards climate health. Just a few examples. Thank you so much. Sorry for rushing, but at the same time I have to adhere to the time which has been allocated. We are looking forward to collaborate with the other states who really wants to make change and optimize the resources as well as the investment that already government making for better outcomes. Thank you.
Thank you, Shankar. Our third spotlight brings us closest to home, Karnataka's own care coordination model and what changes when digital rails are not simply to process a claim, but to follow a patient. Presenting the ABDM-enabled coordination experience, Dr. Dhananjay S. Naidu. Over to you.
I would like to thank for the opportunity given by Kachcon to present this. And after a long time, I heard you, Bala. It was an excellent, concept which you have started working. Hope that we get an opportunity to collaborate again and work with you. And before starting of my presentation, I would like to thank and acknowledge our Joint Director, Shastri Sir, SAST whole team, and the Government of Karnataka for giving an opportunity for us to work on this. We are going to discuss more about the UHC and its components in the upcoming panel, which I would not like to enforce more. But what we have tried to put up in our whole concept is the pain points of the patient journey in the health-seeking behavior is what we have tried to map here, map in our whole initiative. So referral, ABRK scheme starts from a point where the patient gets referral from a public facility. So we have tried to map from there. So one is the referral, and then once the referral is done, where the patient wants to prioritize the hospital where they want to go, and then the admission and the treatment process, how it is going to happen, and the happy discharge ending, and then the recovery and continuity is what we want to map in the whole this patient journey. So the main intention of overall this initiative is to make an reactive system to an proactive system for the patient support initiatives. So that is what has been planned in the overall initiative. So we want to convert the patient calls for an grievance and answering from an government end, and then the single level of interaction and closing the loop there itself is the present scenario, which we would like to convert it, that into an patient identified at a critical stage of care itself, and have a proactive interaction with them, and then support them with an right entitlements and navigation, which is going to help them in happy ending of their the journey, patient journey. So these are the 4 important parameters which we have looked out. One is the proactive navigation, as I said, contact them before, as early as possible, and try to help them as much as possible is the concept. And then create a longitudinal care history of the patient in a digitalized way, so that the whole journey of the patient can be mapped and it can be tracked digitally. And digital integration for a skill. Once you do this, there are a lot of unintegrated systems within the platform of an payer, which we want to integrate together to have a comprehensive way of approach to finish the patient journey. And then the last mile is community engagement. So within this, only digital platforms may not help the patient journey completely. So there is a need of proactive awareness creation and community engagement also, which is also part of our pilot. So these are the 4 important touch points which we have put up in the project. One, at the time of admission, in order to support them, help them, what entitlements they have in the scheme and how they can utilize it better, and what they have to get and what they won't get. All that need to be briefed to them, and at the time of discharge, what can be done in order to decrease the out-of-pocket expenditure from the patient, and what information can be given to the beneficiary in order to cut down that. That is what is the second point. And the third point is early recovery stage. After the discharge of the patient, we should not leave him alone. We should continue the coordination with them so that the continuity of the treatment is ensured, and there is an ensureness of the completeness of treatment by the patient. That is what we have envisioned here, along with the 4th stage, which is the continuity of care, which we continually follow up the patient in order to create a longitudinal health record up to 3 months. So we have taken in the pilot 2 priority groups. One is the urban poor, and the second one focused area is the tribals in the HT Kote Taluk of Mysore. So understanding the barriers at a community level and building their health literacy, promoting the entitlements, and give the access to the helpline, and then develop a community health navigators who are going to help us in the patient journey at a ground level, and then connect the people to the navigation support systems. So this is what we have envisioned in our project. We are enthusiastic to start to have more collaborations to make it a great success. Thank you for the opportunity. Thank you.
Thank you to all 3 of our spotlight speakers, and thank you for respecting the clock, which is, in my experience, is the highest form of professional courtesy. We've heard 3 views from the ground. Now we have an hour to, half an hour to discuss what they add up to. So Dr. Sudha, the floor is yours.
Thank you, Aditi, and thanks to all the spotlight presenters to get the applied aspects of public health on display, so that how we actually work on the field with the theoretical knowledge that we learn. So I have a very distinguished panel and people who have been engaged at the government level, at the national level, at the funder level. So it's a variety of lenses and perspectives that I'm sure the audience would really appreciate. So to start with, Dr. Shastri, I think many people don't know that Karnataka was the first state to launch UHC, the Universal Health Coverage, and even before the Ayushman Bharat PMJAY. So even at that stage, you had thought of the separate cell at the directorate. So the current challenge is how do we link the health insurance part of the Arogya Karnataka and PMJY to the Arogya Karnataka cell, which deals with the primary health care. Because the focus is always, you know, as long as the primary health care anchoring is there, I think the health outcomes would be much, much better. So I would request you to explain on the linkages and the opportunities and the challenges to engage primary health care and the continuum of care for the patients and people of Karnataka.
Thank you, Dr. Sudha. Good afternoon, everybody. So, as she rightly pointed out, in 2018, we had a visionary bureaucrat who understood that by implementing PMJ or Arogya Karnataka in a vertical stack, it will be very difficult to reach all the government points. So, very strategically to work as a fulcrum between the state health agency and the department, we established ABARK cell, Ayushman Bharat Arogya Karnataka cell. Basically, it is headed by the regular government fellow. It works as the link whenever something happens at SAS level, whenever all good things as well as bad things. It is communicated to the cell, and cell in turn communicates to the field. So in that way, this is a very unique model which is not there in other states. In all other states, the SHA, the state health agencies, they work vertically from the department. And wherever the common bureaucracy is there, things move. Otherwise, it will be very difficult to move the things in government setup. And we are also, she asked about primary care. If you look at the PMJAY or if you look at ABRK, it's a specialist scheme. Basically, all the codes are there for specialists. In our department, we had a thought in 2019, there are codes which MBBS person can handle. We need not have MD, MS, MCH fellows. There are like common fever, dog bite, diarrhea, excision of lipoma or any small issue. That can be handled at the primary health care level or primary health center level. You need not go to the district level hospital. So out of 1654 codes which Karnataka has, they bifurcated around 40 codes which can be managed by MBBS doctor as a daycare procedure. So that's how all the primary health centers in Karnataka got empaneled under PMJ or ABARK. We are the first state, I think only state, where every primary health center is involved in ABARK scheme. No other state. If Tamil Nadu has, they have kept codes for hospitals, but that goes from taluk hospitals and above, and very limited scope for primary health centers. This is a forethought again from the top management, because ours is an incentive-based model wherein a hospital gets money for every procedure done. There is a reimbursement procedure. So that money, out of that 70% goes to the Arogya Raksha Samiti, which can be used for development of the hospital, and 30% as an incentive for the team, the treating team. This is making the Atmanirbhar Bharat, what we call the self-reliant hospital system. We need not depend, otherwise all the primary health centers run on input-based system wherein they chart out how many drugs are required, what is the budget required for salary and all those things. This ABARK is making them very strong. They can take care of themselves with this money. Anyway, salary is paid by government. But all of the small things, you need not wait for the state to release the funds. In that way, the system is improving. And they are also owning the program at the primary health centers. Coming to the trust factor, there are some issues with, if we are purchasing primary, this is primary health care, there are challenges. The biggest challenge is HR. There will be vacancies everywhere. There are vacancies of medical officers, there are vacancies of other field level staff. But whatever is available, we are trying to strengthen the system, because government is never perfect. So there will be challenges in government. So I hope this is what you wanted to know.
I will get back to you on the additional questions after we do one round with the other panelists. I think I'll go over to Nachiket who has been spearheading a lot of primary healthcare reforms at the national level, at the country level, in even supporting other countries. Mainly when we look at primary healthcare, it is more an episodic care. How do we move from episodic or an sickness-based care to a longitudinal wellness? And I think your recent work with the Lancet Commission also threw in a lot of areas where we can really improve the primary healthcare. So just your thoughts on what could be the reforms for enhancing primary healthcare.
Yeah, I mean, it's a big question. It can take up a whole day of discussion.
Yeah.
But the core, if you ask me, what are the missing pieces that we need to try to fix a little bit to go from where we are to where we need to go? I think the challenge for us has been that our models of primary care have remained somewhat ossified for the last 25 years. And what the community health worker does, in particular the ASHA, earlier the A&M used to do a little bit more. With the ASHA, we moved a little bit back relative to the A&M. In my work, I call that the first level of community health work, which is the health messenger. If I look at, for example, Ethiopia, which learned from us, already the community health worker is a full-time government employee, is much better trained, is much better capacitated. Sir mentioned MBBS doctors can do. The reality is you don't even need an MBBS doctor, at least to identify the issue. Yes, for prescription, you will need one, but through telemedicine, one can actually solve that problem. The challenge right now is that we don't have that capacity, nor do we have a plan. For what do we do about this health worker as we go forward? Because what we discover, and Kerala is a very good example of why a good, well-designed primary care system fails. Right? Why do they have such a high diabetes burden? I'm told they are now showing amputation rates every half an hour an amputation. And districts like Pathanamthitta have become now, every home there will be an amputee. Right? Why is that? Because the presumption was, when we designed it, again using Western ideas, we build the clinic, patient will come, we'll give a prescription, patient will act on the prescription. There is no evidence that the patient does that. What you need is a health worker, if I take the example of, say, Iran, who has 100 households, 200 households for comprehensive coverage. They are responsible for those people. And they make sure that these people stay well. Right? So it's a big jump in terms of the responsibility that the health worker has, the ability to do things that they have, the tools that they are able to use. It will be for us an enormous movement away from our ASHA approach, where she's given limited responsibility, given limited money, given limited tools, and not held accountable for almost anything, to a situation where is a complete switch. I have not seen health systems that have successfully implemented good primary care without this transition. If I look at the Turkish example, the Brazilian family health team, the Thai example, Costa Rican example, a much smaller country, all of them, this has been an important movement in the primary care journey.
Thank you. I think definitely as other countries are learning from us, we also have a lot to learn from other countries and make sure that we strengthen our systems. Sushil, I think ABDM is a big buzzword, right? I think anyone and everyone would be talking about ABDM, how it will be a game changer in terms of healthcare and health reforms. So what do you think is the current potential of ABDM, and how is it being operationalized within Karnataka? And where are the challenges, why we are not able to move it? I think it's been like nearly 3-4 years since ABDM has been launched. So what are the challenges for us to move into a more digital and a well EHR connected systems?
Thank you for giving me this opportunity to be here, and I would like to thank our Joint Director ABDM, Dr. Suresh Shastri, as well. He has dual roles here to play, but he was kind enough to ask me to speak on the digital health aspects. And Dr. Sudha, you rightly said that ABDM may be a buzzword, but it is the lesser known cousin. It is the lesser known cousin of the Ayushman Bharat pillars when we talk about the national health authorities two prime missions or programs, if we call it. One is the ABPMJY and the other one is the Ayushman Bharat Digital Mission. Now from the national level, Ayushman Bharat Digital Mission is trying to create some standard health stacks, like creating a common identifier for a patient, a common identifier for a hospital, a common identifier for a doctor or nurse or any other healthcare practitioner. Now, this is basically the backbone of what we call as digital public infrastructure. Like we have infrastructure for running our cars and other vehicles, we also need some infrastructure to run our softwares and digital health systems. So that is from where ABDM comes into play. Now, at the initial stages, of course, our mandate was to go on and saturate these registries, create this healthcare facility registry, healthcare professionals registry, and the Ayushman Bharat Health account for all of these stakeholders to be able to create a single source of truth for all these players. Because anytime we talk about any service, majorly there are these three players which come into picture. So now, after that point, we hit a plateau. After creating these registries, what do we do next? Because to see the real value of this connected, health stack, we would need some tool which can be realized at ground, right? So, in the Department of Health and Family Welfare, there was a digital health society that was established, and we moved from implementing only the registry parts to more focused projects. Right, so one of the major projects that we are looking at is how do we digitize the hospitals in a more comprehensive manner. We have had historically solutions which are running in hospitals to some extent, but our idea was to create a more well-connected system to ensure continuum of care, what is the key theme of UHC these days. And also our idea was to resolve the issues of equity with regards to information. Equity, the inequities with regards to information is also a sort of inequity, according to me. And when a person is not able to know which is the closest hospital which does a lap cholecystectomy, it is inequity in information, and it does create barriers to access to healthcare. And how we have started in digitizing these hospitals is basically, it is all about a lot of procurement and all that, so it is a more technical aspect. But what we are saying is we will have hospital management systems from the district hospital till the community health centers, because their workflows are more or less similar. Whenever we try to get in a new software tool, we should very clearly keep in our mind whether they are in sync with our workflows in a day-to-day scenario. So in a district hospital, taluk hospital and CHC, they are more or less similar. We have some specialties, we have some clinical workflow, we have some national program workflows, which are all handled fairly by these off-the-shelf software solutions. Now, where we faced a challenge is the primary care, because primary care, primary health centers and sub-centers are not very well-defined hospitals. They do a lot of programmatic work. They deliver, schemes and programs which are more curated. And there is also a link to the community through the ASHA workers and the primary healthcare officers or the ANMs. So how do we resolve this problem was a bigger question. We tried our pilots with few of the solutions, because pilots are the only way you can learn whether it works or doesn't work. They are like micro experiments you run. And we finally realized that we need a much lighter solution for it. Our doctors at the PHC may not be able to use a full-fledged hospital management system, digitizing each and every aspect of the workflow. So we are now going ahead with a much more lighter solution, which will be connected to a community-based platform as well, which the ASHAs and the ANMs will be using. Now we are at, I would say, somewhere at the middle of implementing these projects. And we have a long way to go, because once we start getting into the final phase of the project, we would look at change management also, because getting the adoption from people in a public healthcare system is also a big challenge. And I think with slow baby steps, we will be able to reach somewhere. And with ABDM in the background, all the analytics, And the uniformity of data, the capability to run AI algorithms, everything comes when we have good data. We have data now, but whether it is good, whether it is high quality, is a very questionable thing. But we are trying to create something which is more validated, a sample of data at least, which we can use for larger programmatic planning, good service to the clients who visit hospitals in the public health facilities. And with this vision, we are moving ahead. So these are the two large spaces that we are currently working on. And of course, all other digital tools come and fit inside, provided they follow the same structure of ABDM and other things. So this is how it is.
Thank you. I think taking a cue from what you said was in terms of adoption of ABDM. I would request Dhananjay, who has worked across multiple states, in looking at how does different states look at ABDM adoptions and the 5 C's of ABDM, ensuring the contact, the coordination, the continuum of care, the comprehensiveness of the solution. So maybe you could throw some light on how different states are looking at, and also a little bit on the microsite project, what is the kind of outcomes or what is the kind of learnings from those 100 microsite project for ABDM adoption that is being tried out with a specific focus on the private sector.
Okay, thank you, Dr. Sudha. Normally, when we speak about UHC, we speak about financing, or we speak about the health benefit packages, or we speak about the implementation methodologies which have been followed across the country. But if we actually prioritize only this, never we can build a strong health system, is what my opinion is. So these 5 C's, what Dr. Sudha mentioned: contact, comprehensiveness, coordination, context, and continuity of care. So these all 5 need to be an integrated model. Then only we are able to make a patient journey a happy journey in his whole health-seeking care. So if we have to achieve this, what is the major problem? We take an example of PMJAY itself, which is an social insurance model which is getting worked across the country. Most of the states, I can say now all the states, have adopted PMJAY. And more than 40,000 providers are working on a single platform of PMJAY to provide the care to the people. But what's the problem? Problem is very clear. It is not an integrated model. It's only presently only an inpatient care giving pathway which has been created. And that too is not on a single digital platform. As Sushil was saying, PMJAY is the most adoptable first use case of this interoperable digital architecture. If we are able to achieve that under the social insurance schemes, especially PMJAY, ABARK and all, then definitely we can build a very strong health system. Many states have already have reached different stages, I can say, in this path. I will take example of Karnataka because we are here itself. If we see the contact as in first C, how a patient can get contacted into a digital interventions. There are different ways. We can create a digital ID to the beneficiary, which is ABA presently. Or it may be creating a beneficiary database, how we have created under ABRK, in a digital way. You can see that there is no manual intervention either in ABRK or in PMJAY presently in identification of the beneficiary. He will go to the different level of hospitals, like he may go to the primary PHC, or he may go to CHC, or he may go to block level hospital, or he may go to a private facility to take the treatment. In case if he is identified with a single identifier without creating a new ID every time of his admission, definitely a longitudinal, his health history can be recorded under that particular ID, which is a basic principle of overall ABDM adoption. So presently it may not be on the ABHA, but the complete inpatient care has been has created a longitudinal health record under ABRK. We can proudly say that. So in a similar way, even under the PMJAY also, a longitudinal health history of a patient who has taken the inpatient treatment has definitely been created under the PMJAY system. But the issue which has been left out is the interoperability of these systems, which has to come only with an ABDM enablement. So that's where the challenge is, and I would like to pause here and continue.
I think the second round of questions, I would like to have the audience here. If you have any questions, clarifications, because these are all people experienced in implementing actually on the ground. So based on your work or your reading of the UHC, do you have any questions that you would like to pose to the panelist? Yeah, can someone pass the mic, please?
Hello. Yeah, thank you for good discussion, good points, and I got to know like Karnataka is a pioneer in many of implementation. Regarding ABDM only, like how is the private acceptance and how it's been like the process? Because okay, we talk about it will be good longitudinal, and how is the patient's acceptance? And because even in I work in Atal Bihari Vajpayee, we are getting whoever patient comes now, we get the there or not, we get the ID created, and it's all going on. How is like that longitudinal process accept, especially in the private sector, many different sectors, how it's going on?
Okay. Dhananjay has permitted me to take this question, so I'll take this.
Sushil,
sir.
With permission of Chair, I am Dr. Ranganath working for Bangalore Medical College. So my query is regarding the ABDM. So the patient comes to this hospital, either maybe MCH hospital or general hospital. When the patient comes, the physician or in the registration counter, we ask for the Aadhaar card. And most of the time, our Aadhaar card will be attached to his father or husband or somebody's phone number, obviously. And when we register that, they will ask for the OTP. That will go to the somewhere. If you take this, she has come for the delivery, more so, that most of the time the OTP will go to his husband's because number will be given. This is the commonest problem what we face, and something like this. And we heard that many times the app is under upgradation or something like this. So that's why this is another big challenge we are facing in the government sector. Any solution? Thank you.
My question is to Dr. Shastri. Then you delivered a note on ABRK, this thing, 40 procedures have been under primary health care, this thing. So, as being I was a DHO, that time I used to experience many hurdles faced with this one through the TP at that time. So, whichever medical officer claims more, you used to face music then. So such kind of scenario is still existing, or it is fairly being cleared now because it is with us now. So that's why this thing. The second this thing is, so up to what level, for example, 2,000 and odd primary health centers are there, exact number I have forgotten, 2,500 or something this thing. How many are actually in the platform claiming these 40 these things? So this is my, thank you.
Yeah. The question will be related to same on what Dr. Rangnath, he spoke at the hospital level. I'm speaking at the level of primary health care level and the village level. Why we are so much of got into a psychic mode of getting into digitization at the level of village level or the individual level or the service seeker level. I face a problem of registering my child in Anganwadi center because of one number change or phone number related, Aadhaar link related. not only that one, now you go on for that face recognition of a child. And I see more than 25 to 30% of my children below 6 years are not getting their due, though we have a world-class ICDS program. The same mistakes we have been doing last 30 years or so. Why this obsession sort of thing? And the other question will be for policy advisor, economist. So what is that we are concentrating more on Medicare with all our digital system advanced, and why we are neglecting the healthcare aspects? And what is the constraints of an advisor to policymaker? Why he fails? Is it lacking the data on healthcare indicators or Medicare indicators? The depth, is there any gap in that where we need to pitch in and support you people to come up with a good, strong policy guidance for the makers? Thank you, sir.
My question is that...
No, I got the two themes around which the questions have been framed. So one is with regards to the adoption of ABDM largely across government and private sectors, if I understand it rightly, and what are the drivers for it? How do we see that it may succeed or it may not succeed, or what is the story to it? The second part is regarding the Aadhaar and the workarounds to it in case of registries. So in case of ABDM, sir, when we talk about creating of ABHA, like I told you, initially our mandate was also creating IDs, registries and all of that, but then we realized that you need tools. You need tools which will make people realize the value of ABDM. So that is when we started considering hospital management system as a strong tool to digitize it in an end-to-end fashion. Only then, when care is digitized, only then people will realize the value of care. And only then it passes from one place to another. Now with regards to private adoption, of course, there are much bigger challenges we are looking at. Private healthcare is a very different entity. In fact, the way it is financed now, it is quite scary to see how do we crack it. But I think ABDM has a small answer to it, but through this National Health Claims Exchange. National Health Claims Exchange is basically a pipeline for all the health insurance claims to flow from a provider to payer and back. So this is going to standardize the claims in a manner that it goes quickly, in a very, very refined manner to any of the third-party administrators, be it a private or a government entity, and also make sure that the turnaround times is kept at minimum, because now you have digital data flowing in. It is not some scanned records or paper records which are going in. So from that point of view, even IRDAI for that matter has mandated all the insurers to get on board NHCX. All providers are also on board NHCX. By providers, I mean the softwares which work at a hospital level. Now it is about the mandate that pushes this through. Right? So whether the mandate will come today or tomorrow, but at some point of time it will come for sure, because ultimately that is what is going to push digitization, and it is again through the insurance assurance scheme perspective when we talk about larger adoption. And regarding the Aadhaar to be used as a common registry across places, one thing is Aadhaar now has multiple modes of authentication. If a particular Aadhaar does not have a linked phone number, you can always use a biometric device to authenticate the person, where you need not enter the phone number at all. Over and above that, if you are a government entity, you have the facility to authenticate it through something called as demographic details, where you enter the name, gender, and the address of the patient exactly as Aadhaar, and it gets validated. And we also have Face Auth now, which is workable only for adults. I'm not sure if it is implemented in children. As far as ABDM is concerned, we do not insist to be implemented in children. In fact, biometrics also are fairly inconsistent in children, so we only ask for the parents' authentication. We have a specific workflow for it called Bal Aadhaar, where we leverage on the parents' Aadhaar and create the child's Aadhaar. So that way, we try to keep the registration red tape to the least. And why we are digitizing is basically for ease of doing business, I guess, and ease of living, because all services across the country are getting digitized, and healthcare is one which is left behind. So I think everyone is just keen to digitize it, is one answer I can give. But there is a much learned panel. They could suggest better, things why it is going that way. Thank you.
My question
The
is
question on primary health centers, the uptake, we are finishing in 2 minutes. Over the years it has improved, sir. The problem, as of the last quarter report, around 140 primary health centers are inactive. Other than that, every primary health center is active. They are means at least they are generating 1 to 5 cases per month. Because their OPD is around 20-30, but still they struggle to upload. They have realized that importance of uploading cases and generating funds, because as you know, the things have they worsened over the last few years. So the fund crunch, and that is one source of running the system. Whoever is motivated and passionate, he actually uploads the cases and generates funds for the hospitals. Yeah, but the thing is, now the thinking itself is now changing gradually. We are, if you look at the program for last 40-50 years, we have been only marketing programs and diseases. We have never marketed health. So now we started marketing health in Karnataka. Okay, and first time in 2018, the word wellness came. All these days we were only talking about illness. Now there is something called wellness. So we have to think about wellness. That is the future rather than illness. Thank you.
Thank you. I think last words from Nachiket, and then we go to Aditi. You have last words, and then
I think sir has already given a good response as to where the shift is happening already in Karnataka. And it's a matter really at the end of the day, if there is a willingness to take accountability for good health. It's not as if we don't know what good health means and how, or if we don't know, we can turn to experts like you. But I'm encouraged to hear that in Karnataka, for example, that conversation has started. And sometimes I think the public health field is its own worst enemy. We present these ideas as separate ideas, separate things to be done. The connection back with good health, connection back with reduced illness, because as you correctly point out, all the schemes, everything is for illness. But unless there is a connection seen between these two, sometimes it becomes hard for the government to justify budgetary allocations, etc. But I think there is progress in this direction. And you saw some of the wonderful work Swasti has been doing in, and many of them have a character of good health, not just, I was just being shown outside, the whole heat program that Swasti has done with Andhra government. These are all wonderful examples of moving away from, what you called kind of medical to health.
I request Professor Sudarshan sir to give a quick summary before we go to the launch of the report.
Yeah, thank you very much. And this is a very distinguished assembly of experienced and experts, which I could make out, which all of us could by now understand. They have shared their expertise, which has come from their understanding and their experience. And definitely, I think now we are behind schedule, and they are going to launch the report. Am I correct? Yeah. So one thing for the postgraduates here I would like to say is, see, do not always think that knowing the specialty will take you to different places. No. It is your personality that also equally matters. I would rather put denominator, the personality, the specialty as the numerator. I'm very clear, I'm telling from experience. Unless you are okay, your knowledge, your experience and expertise is not good enough and will not be okay to those who are on the other side. So That is for the postgraduates, and here, of course, it was to sum up this highly technical and a little tricky, a little complicated, very fine-tuned activity. I will not go into the details. I have one thing I would like to compliment from what I know. For 3 years, 3 months, I was in the government. COVID pandemic literally paralyzed for nearly 2.5 years. There were few program officers who were brilliant, who could make things happen. I am not here to please Dr. Shastri. Shastri was one such person. He was holding a very key position. That is, he was with the minister, media management. See, pandemic, media management. Whether media managed him or he managed media, I would now clearly say he managed the media. So these are, and I have seen him how he did it. So these are things which we need to learn. And when you are being posted to the municipal corporation or the GBA now or whatever it is, health department, or in the Directorate of Health Services, please work very hard and sincerely. Go before the officer comes, leave after the officer leaves, and understand how it is working. That is the best way of learning. With this, I stop here, and it is over to Dr. Sudha Chandrasekhar, and through her to the organizers. Thank you very much.
So over to Aditi, and I request all the panelists to come over at the center for the launch of the report. Photo.
I would also like to call the authors of the report, Dr. Balakrishna and Shankar, and I'll also be joining.
Thank you, ma'am, and the whole panel team for this wonderful panel discussion. Now I invite Dr. Sudha Chandrasekhar, ma'am, and M.K. Sudarshan, sir, to felicitate all the speakers. I invite Dr. Sudha ma'am to felicitate Dr. S. Dhananjay Naidu, sir. Dr. Suresh Sastry, sir. Dr. M.K. Sudarshan, sir. Dr. Balkrishna Kaudgaonkar, sir.
Dr. Sushil Kumar, sir. Nachiket More, sir. Dr. Sudha Chandrasekhar, ma'am. Dr. Balkrishna Kargovan, sir.
Thank you. Pleasure is fine. Yeah, thank you. Sure.
Thank you, panelists, moderator, and chairman, sir. So we go to the next scientific session 4. We request Shankar AG, sir, to receive the momentum. Thank you once again, panelists. So we begin with the scientific session 4 and on adolescent well-being and sustainable food systems in Sustainable Development Goal era, goal number 2, 3, 4, and 5. A panel discussion. To guide us through, we have moderator Dr. Archana Siddhaya ma'am, Assistant Professor, Indian Institute of Science, Bangalore. I request her to come on the dais. Archana Siddhaya ma'am. And we have speakers, Dr. Charini, Dr. Melvin, Dr. Narendra Rao sir, Dr. Senthil Amadan sir. I invite all the speakers and the moderator to come over the dais.
Hello. Good afternoon, everyone. So before starting, I would like to express my gratitude for the organizers for giving us this opportunity, and I also thank all the speakers for graciously accepting the invitation to be part of this panel. So why this topic of adolescent health? So globally, we all know that they constitute So adolescents make up to 16% of the world's population, and for the first time, young people constitute the largest proportion of population in the human history. And yet, as we approach the deadline for the SDGs, adolescent health has been the most under-prioritized in the global health agenda. And we all know that adolescence phase is a very critical window of opportunity. And when we utilize it, it will unlock a great potential that can lead to healthy and productive lives as adults. But the progress in adolescent health has lagged, and because of which we are still struggling with numerous public health issues, such as triple burden of malnutrition, which has consequences in their adult life, and also increasing mental health issues, and the newer addition, which is the technology addiction and its consequences. So this panel has been constituted against the backdrop of some of the most pressing adolescent conversations and issues happening right now across the globe. For example, the HPV vaccination drive, which was implemented by the governments both in the central as well as in the state, and the debate around the banning of social media for teen. And this debate is far from over, as a recent study from Australia shows that most of the teenage people, they were able to circumvent the social media ban, and 85% of them were able to use various social media platforms. And this is exactly the kind of real-world complexity we are going to discuss in this panel. And I'm happy that we have practitioners, we have experts from the health system and also from the policy to discuss in this panel. So before that, I would like to introduce the panelists. So first, we have Dr. Charini, who is the Reproductive and Child Health Officer, who is working in the Kolar district. And she has done MBBS and MPH from NIMHANS. And she has been working with the health system for more than 18 years. And she worked as a COVID nodal officer during the pandemic, because of which she was awarded the Best Program Officer for the state in the year 2022. So I welcome Dr. Charini. Next, we have Dr. Melvin, who holds MD in Community Medicine, and he served as a consultant to the World Health Organization, where he worked in one of India's most challenging health landscapes, when he was posted to the state of Bihar, and he contributed to the public health programs working on the field. Currently, he is working with the United Nations Development Program in Karnataka as part of the Health System Strengthening Division, where he's working at the intersection of policy, implementation, and grassroots impacts for the UN program. So I welcome Dr. Melvin. So next up, we have Dr. Naren Prahlad Rao, who I don't think requires any introduction here, as he is the alumnus of this medical college. He's currently working as the medical director and senior consultant psychiatrist at Mano Shanti Center for Emotional Well-Being in Bangalore. And in the past, he has been affiliated with the Department of Psychiatry in NIMHANS. Currently, he is adjunct faculty at the National Institute of Advanced Studies in Bangalore, and he's a consultant for the Tanu AI Center for Excellence at the Indian Institute of Science. In his distinguished career, Dr. Naren has been a recipient of various national and international awards and fellowships, and he has more than 90 publications. So thank you, Dr. Naren, and welcome to the panel discussion. So lastly, we have Dr. Senthil Amudan, who is the professor and head of the Department of Epidemiology at NIMHANS. And in his more than 18 years of academic experience, he has published more than 70 papers. And some of the important contributions are in the field of technology addiction among students. He has worked as a consultant with the MOHFW, WHO, and UNICEF, and he was the convener of the Child Health Subcommittee of the Karnataka Vision Group, constituted by the government of Karnataka. And he has received numerous awards, including the prestigious BMJ Awards for South Asia in the area of healthcare innovation. So thank you and welcome. So before going into the panel discussion, so I will briefly explain how the session will run. So we'll start with the individual presentations, wherein each panelist will get 10 minutes of time to present. And this will be followed by a round of discussion before we open the panel to the audience question and answers. So first, I would like to welcome Dr. Charini ma'am to give her presentation.
Good afternoon, everyone. First of all, I would like to thank Department of Epidemiology, NIMHANS, who have given this opportunity for me to present about our service delivery with respect to adolescent health services. And I would like to acknowledge DD Maternal Health, DD Child Health, DD E-Health, and our department, that is Health and Family Welfare. With the permission of our madam, so I would like to present about the AFHCs, that is our adolescent health and the services which is offered through RKSK, especially in Kolar. We have been performing this since 2014. Before it was presented to the adolescents as Sneha clinics and ARSH. So under ARSH program, we used to conduct Sneha clinics. That is, every Friday we used to attend to the adolescent health issues through Sneha clinics. And from 2014, to address few of the counseling part, especially STI and RTI was major concern at that time. But now, moving forward, like with the problems, that is especially technology addiction, the mental health disorders, stress, and especially substance abuse. So these are the challenges which we are focusing through our RKSK program. So here we are addressing to all this. Not only this, we are also giving the non-judgmental services, and with the new innovation of Samagra Samalochana Kendras at every Taluk General Hospitals and at District Hospital, we are even addressing to their medical problems. That is a one-stop solution for various medical illness, which can include even counseling to curative. So this is the concept of Samagra Samalochana Kendras, and these are effectively implemented at the Taluk level. So in this Kendras, all the counselors belonging to different departments or different programs have been integrated, and they are providing the counseling services, they are mobilizing the children, they are mobilizing the adolescents, and even they are giving the counseling services for various problems which the adolescents are facing presently. So with this, I would like to tell few of the determinants which are acting upon the adolescent health. So why adolescent health is the concern is because it is catering to 1/5 of the population of every geography, and their problems are so dynamic that we are unable to address few of the problems till date. So for which we will be modulating, like every program is implementing new solutions for the adolescents. It is like a life cycle approach that we are addressing to these adolescents. Starting from 0 to 19, that is from the child, it is being covered till 19 under this program. That is RBSK plus RKSK together, we are addressing to the child health problems. So few determinants which are acting upon the adolescent health. So especially family, school, peer group, the community, the media, and health outcomes. So here the majority of the adolescents in newer trends, we are finding that they are facing lot of peer pressure, for which they are falling into lot of substance abuse disorders. And there is school absenteeism also, which is being recorded during our RKSK or RBSK visits. So which is also been one of the school absenteeism again is being reported as one of the important factor which should be addressed immediately. Otherwise, the child or the adolescent which is being missed from the school is found elsewhere, whether it is traffic or whether it is like under teenage pregnancy or child marriage or a child labor. So it is the need of concern that it's taken up by RKSK very seriously at Kolar district, and to present to you as a pride that we effectively managed to control 6 child marriages from our team, and we have been even identified 1,500 hotspots for IV drug users, which has been listed and given to the enforcement officers like police department. And this is taken as a special task from different departments, and again we are planning here to bring out the child to the rehabilitation centers and to the mainstream indirectly. Again, the influencing factors again for the adolescents being education is one of the important factor, and again social factors like poverty and other like literacy of the parents also matters, and gender norms especially. So if it is a child if it is a female child, again she is more prone for being under teenage pregnancy or for child marriage. This is the matter of concern. The prevalence of teenage pregnancy being 0.23 at the state and 0.27 at the district. For us, the challenge is again the migratory population. So whenever we plan a program for whether it is an awareness program or whether it is a counseling session, for us the challenge being the migration. Among these teenage pregnancies, for us the 40 to 45% are migratory. Whether they'll not be having any age proof or whatever, the literacy rates are low. Again, addressing to this population is a very challenge, and this should be taken very, it should be addressed in a different manner that we address as a general population. So this is the evolution of our adolescent health program. As I mentioned earlier, the ARSH in 2005, RKSK in 2014. The peer educator program is again now sprouted again. We have identified peer educators at every schools, at every villages by our ASHAs. So whether she is married or unmarried, whether she is school going or non-school going, so every peer is identified by ASHA. Again, these peers will be trained at the PHCs through our trainers, our TOTs who are being trained at the taluka, in turn at the district, and finally, we are being identifying the different problems at the village level and addressing to the problems effectively at the district. Again, digital health integration is one of the important things. 2020 it was evolved. So here we are providing the telecounseling services. Again, digitization is one of the important things that adolescent health, which is being addicted to digitization. So one of the their side effect, we are utilizing that for our own benefit of the program. Here we are being, in our district, DINC is one of the digital platform where we are catering to adolescent health services, and Telemanas is again 14416 from NIMHANS is being utilized for the counseling services. Again, youth-owned ecosystems, that is way forward 2030. Here, adolescent is a very impulsive age where they have their own problems, their own solutions, and they have been obsessed with the digitization where they have their own solutions through WhatsApp groups, through for example, physical tracker on their own this thing. So independently, they come up with their own solutions. So this is a way forward. So our AFHCs, especially adolescent friend health clinics, every PHCs, every sub-center, every taluk hospital, every general hospital is catering to the adolescent health service through AFHCs. And Karnataka is one of the leading state with increased number of AFHCs and catering to the services of adolescents in in the lead. So till date, we have in Kolar, we have 8 functional AFHCs at taluks and counseling units of 7, and nearly we have organized 120 to 150 counseling services every month through our RKSK counselors and through our RBSK teams. So number of beneficiaries in last year being 6,454 and the referrals being 60. So this is the challenge, as I mentioned earlier: fear of judgment, stigma, confidentiality concerns, provider attitude, cost and accessibility. So more than this, I feel their mentality, especially towards health-seeking behavior. So this is very important, and peer pressure, especially, for which peer education program is being in place. And the accessibility here is a challenge. Every adolescent with problem will not be coming or reaching the facility. So that's why there is a program which is addressing these kind of problems, is that our AFHCs. So in our AFHCs, the community-oriented, whatever the problems is generated from the community or from the peer will be again escalated to the team, that is our peer TOTs. So TOTs will be escalating it to the taluk, where our RKSK counselors will be guiding them, and this will be addressed at the village level and at the community level. So a linkage is created between the community and the facility, so through which we are providing the services, especially the STI, RTI, nutrition, and counseling services. That is, confidentiality is also maintained, the confidential counseling services. So these are also provided at AFHCs. Along with that, even we are giving the focus on gender equality, especially with respect to the girl child. Safe girl child is one of the concepts that we are even giving the stress. And we are even giving the health promotional counseling services, especially with respect to menstrual hygiene. So this is one of the key area, especially which we can relate it to stigma at the level of village level. And effectively, with the help of Government of Karnataka and the Suchi program, we have been able to provide the sanitary napkins. Again, not only the provision, we are also giving the health education regarding how to use the napkin and what is the minimum time that a girl should be using a single napkin, and regarding the disposal, regarding hand washing, the nutrition, the physical activity during menstrual period, and other stigma which is being prevailed in the village will be communicated to the higher ups, and it will be addressed at the advocacy meetings through our counselors. And we are even building, so these are all the services that we are providing under AFHCs. So that is nutrition, sexual reproductive health related services, mental health services, substance abuse, injury violence, non-communicable diseases. Again, the lifestyle modification is being addressed. So all these are facility oriented. So when it comes to community based, we have the platforms like Village Health Nutrition Days, Village Health Sanitation and Community platforms, where every single child is addressed in this platform with the coordination of Department of Women and Child and Public Instruction. So here we will be addressing to the child in specific and the problem or the stigma which is prevailing in the village. So through these platforms and with the community participation, especially ASHA and Anganwadi workers who are involved in these platforms are also involved in these programs. So for us, the challenge for us in the district is, again, delayed early marriage. So this is the agenda for us for the program specific. Since, as I mentioned, the teenage pregnancy is one of the challenge for us. And again, health promotion with respect to menstrual health and hygiene and prevention of STI and RTI, promote gender equality, provide confidential counseling. So peer education and community awareness is one of the important things that we are focusing. And a way forward, again, digitization is again one of the concern. So as our sir told, ABA ID generations at every clinic is also being monitored. So we ensure that with the help of Digital Now Center and eSanjeevani platforms, counseling services are sustained. And also, it is like a boon that we have this program, and through this program, we are effectively, we have already achieved 82% in HPV vaccination. Wherever we were finding difficulty in vaccination, the concerned team used to create the awareness regarding HPV vaccination. Especially infertility was one of the thing that which was one of the area where it was going synonymous with HPV vaccination, which was really, specifically focused and addressed at the community. And we had overcome this in many areas, but still we are with this stigma still. But still we have achieved 82% with the teams who are actively involved at the community level. So this is what the ecosystem which is built in our health system, that is family, school, community, digital platforms, and the health facility. So it is adolescent-oriented and centralized system which is built and which is running. So every group is coming up with a problem new, and new problems is being identified, and new solutions are being given at the facility level. Okay. Thank you.
Thank you, Dr. Charini. May I now request Dr. Melvin to deliver his talk.
Good evening all. So today I'll be just presenting on Shielding Our Future, a case study of adolescent human papillomavirus vaccination program from Kalburgi district. So I'm just taking a part of HPV vaccination which we are doing in Karnataka state at present. Kalburgi as an example. Okay, so it helps in our SDG number 3, health and well-being. So I'll be more talking about the challenges we faced after the interventions and how could we succeeded in the program. So briefly I'll be telling about introduction, about the vaccine and present scenario, global and Indian scenario, and what is the WHO take on HPV vaccination as on today. Then digital platform that is UVIN introduced now to record the vaccination. Following that, Kalburgi district, the challenges, the intervention part, and what are the implementation part which made successful vaccination in the Kalburgi district. So introduction, just you all know cervical cancer. So lower part of the uterus with a persistent infection of a HPV, it's a high risk HPV strain which is persistently infecting that part leads to cervical cancer. So usually we have many serotypes of HPV vaccine. Among that strains 16 and 18 are more high risk, which can lead to cancer. Okay, so as of now, global scenario, so we can see it's the fourth most common cancer in the global. Okay, so first will be breast, lung, and colorectal cancer. Following that, cervical cancer in the global scenario. Estimated 662 new cases every year. Like in 2022, they estimated this many cases, and deaths due to cervical cancer is 3,48,000. So if you see incidence, that is 14.1 per 1 lakh women years, and mortality is 7.1 per 1 lakh women years. So mostly seen cases are in developing countries. So unless if you have you don't have any prevention control measures in the country or the nation, we're going to estimate it like 8 lakh new cases by 2030. So this is what the thing. Coming to Indian scenario, in India it's the second most leading cancer, cervical cancer. If you see the incidence, it is around 11.6 per 1 lakh women years, and mortality 5.1 per 1 lakh women years. So estimated cases are 79,000 in 2022, and if you see the deaths due to this is 34,000 deaths. Okay. So what is the elimination strategy? So vision is to eliminate HPV related cervical cancer. So, and to bring the threshold like 4 cases per 1 lakh women years. This is what, so that it is no longer a public health problem. It has kept a strategy like 90, 70 and 90 target. So 90% of all girls who are 15 years old should receive vaccine. 90% of girls should receive vaccine, like 15-year age group girls should receive vaccine, and 70% of women who are in their 35 years age should should have a screening for cervical cancer, and again at 45 years. So 70% of women in 35 years and 70% of women at 45 years should go for a screening for cervical cancer, and 90% of the identified cervical cases, like it may be precancerous or cancer in situ, so all those should be treated. 90% should be treated. This is the target set for 2030. So as of now, WHO position paper tells till 9 to 14 years of age group, we can give either 1 or 2 doses of human papillomavirus vaccine. 15 to 20 years, again 1 or 2 doses is sufficient for the girls. And more than 20 years, 2 doses recommended at 6 months apart, at the interval of 6 months. So recently alternative single dose schedule, which they tested, that single dose of HPV vaccine is more like equally efficient, okay, equal efficacy of second 2 dose or 3 dose vaccine. So that's why it's very easy for the countries to launch their countries like single dose HPV, which has more equal efficacy compared to second and third dose. So it has a programmatic advantage, affordable, cost effectiveness is there, efficient, and improved coverage. So this is possible through single dose. So based on this, Government of India launched HPV vaccine. This is a Gardasil 4 quadrivalent vaccine. It has 6, 11, and 16 and 18 serotypes of HPV. Launched in 28 February 2026 this year as a campaign for 3 months and extended again for next 3 months. So, and the eligible beneficiary are girl children who are 14 years old. The girl who has celebrated her 14-year birthday and not yet celebrated 15-year birthday. This is the cohort where we are going to vaccinate for HPV vaccine. So there is this UVIN. So you all know that UVIN was introduced in India, and in Karnataka, July 2023, we launched UVIN. So it is digital recording of vaccination, all routine immunization. Any vaccine will record to UVIN, where with the phone number and photo ID, it's a line list based, and the citizen interface is there, where citizen can book their appointment and get the vaccination, and tracking us through UVIN. So same thing is used for HPV recording also. So once we vaccinate, we have a e-certificate. So we can know that where the child is vaccinated. In this certificate, you can see all vaccines, also HPV vaccine included in the last row. Because going ahead, post-campaign, HPV will be introduced in routine immunization for all 14 years age girl children. So going to Kalburgi, so Kalburgi has a population of 29 lakh, and as Government of India told, 1% of the total population is our eligible beneficiary for HPV vaccine. It comes to 29,000 beneficiary, and we have received a vaccine and allocated 21,000. So proportionally we allocated vaccine 21,000 to the Kalburgi district. Kalburgi is a very challenging district. So once we launched the JE campaign also, the coverage was not so good. Repeated intervention, repeated follow-up, review meeting, the coverage improved. So same challenges we also faced post HPV campaign. So first is there's a myth among the community that it will lead to infertility. So many girl children were refusing to take HPV vaccine. The parents were against to take HPV vaccine. It's a big challenge. And post-COVID vaccination, there is some reluctant to take vaccine. These are the challenges initially. No, coverage was very poor. And as Government of India told, it's a health facility based. We can't go to school and vaccinate all children because Government of India told vaccination should happen in the health facility where medical officer is available and you will monitor for any AAFI. Okay, and we have few vacancies that also lead as a challenge for us to cover entire district. And once adolescent age group, majority will be school. So private schools were little reluctant initially for the vaccination. And the time of launch was in February, March, April. So you can see many children were going for exam, post-exam vacation. So very difficult to cover those cohort during this campaign. These are the challenges. And interventions, so again, when repeated reviews and initial months, initial March month, the coverage was not poor. District was bottom at 23rd, 27th position. And repeated intervention, the district administration herself took a lead, and district task force meeting was held, interdepartmental coordination. So all departments were called. So basically we want health department, women and child department, and Panchayat Raj. All departments were called for this meeting, and they were given a task for covering HPV vaccination. And the post-meeting, it was not stopped. Every day reviewing was there. How many children were covered? Which are the facilities did good? So daily evening reviews were happening. And few far to reach area mobility support was arranged by Panchayat Raj. The fund, they took a vehicle and children were brought from nearby school or the home to the nearby health facility. So mobility support was made. So, and again another challenge was parent-teachers meeting. So with, because vaccination is given to 14-year-old girl, consent should be given by guardian. So we have a consent form. So parents-teacher meeting was conducted, awareness was given regarding the vaccine to the parents, and the consent form were shown, and children should take consent form to home and get the sign from the parent. Or another way of giving consent is through OTP. Through OTP, they have to give consent. So for this PTM, parent-teacher meeting was important. It was conducted, and it helped in mobilizing the beneficiary. Coming next, and this one, few private schools were having a challenge. So the particular BU of the block education officers and HMs, medical officer went there. There's a letter from the district officer and DDPI letter to the all schools so that to conduct a vaccination and the awareness regarding the vaccination. Through this letter, they could be able to go one on each school and talk to the HMs there and convince them for the vaccination. And high motivation video clips. So from the district collector and other health officers and other department like high officials used to have one small video bite on vaccination, and children themselves after taking vaccine should share one video. They have to put as a WhatsApp status and share in the groups. So it also helped in vaccination. Through UN digital tracking, daily reviewing, real-time review was happening. Okay, so achievement, following all these efforts, the district stands at top one today with the vaccine given. So we have given them 21,000 vaccine. They utilized almost 97% of the vaccines utilized. It ranked first, as on yesterday data, the Gulbarga ranks first in the state in vaccine utilization. And how could we achieve this is the strong leadership from district collector, herself reviewing, starting the initiation and reviewing every day. and IEC awareness through parents teachers meeting, and through digital media, through WhatsApp, Facebook, the video, small video bites were circulated, and very good coordination among the health department and supply of vaccine, timely supply vaccine. So all these things made achieve good coverage in Kalaburgi district, leading to the top performer of the state. So with all these things we achieved good, and I conclude my talk by this. Thank you.
Thank you, Dr. Melvin. So can we have Dr. Naren, please? One request, Dr. Naren, since we are running out of time, if you can stick to 6-7 minutes, would be helpful. 7 minutes? Yeah. Thank you.
At the outset, I thank Dr. Archana and for the Kachcon for the invitation, and happy to be here at the alma mater and speaking to the public health specialist. So what I will do in the next 7 minutes time is to give you an overview about the behavioral addiction and how the regular strategies that were successful in controlling the chemical addiction may not be successful in controlling the behavioral addiction. So this is more from a clinician perspective, because I'm not a public health specialist. So I come from the clinical background where we treat patients on a day in, day out. So let's, for the working framework for this session, we consider the behavioral addiction is a compulsive engagement in a rewarding, non-substance activity. So it is usually the screen nowadays, but it could also be other behavioral addictions. So we will consider mainly the screen, the technology use, mainly in terms of the internet, be it gambling, be it excessive use or a mobile use or mobile or video gaming. So that is what I will be focusing in today's presentation. So how is it different compared to the use? Because I'm sure there is nobody in this room who hasn't opened your mobile phone in the last 15 minutes. Every one of you would have touched, some of you might have switched it on, but rest of you also have touched the mobile phone at some point of time in the last session. So how the high engagement is different from an addictive use, because most of our work actually now depends on the use of technology, be it a laptop, be it a mobile phone, or be it a tablet. So the healthy or a high engagement use is usually goal-directed, whereas an addictive use is primarily a coping mechanism for distress. So it is not a goal-directed use, but it is mainly repeatedly you are using it either to get a reward or you are either to escape from a distress. So the control element is the most key aspect. So for example, you may be able to stop it whenever you are having a high engagement use, but whenever there is an addiction, it is very difficult to stop. Even if somebody attempts to stop, they relapse. So there is a good cycle which we see very similar to a chemical addiction in behavioral addiction. And the consequence, there is no meaningful impact on the sleep, school, or the relationships in a high engagement use, whereas in an addictive use, those things gets affected. And time on its own is a poor marker, because many times we see parents who come and bring their children telling that he has been using the laptop for a long period of time. And the child says that all my teaching assignments are in the laptop, or all our lectures are now happening on a tele basis. So the children in the last 5 years, especially those who were in their adolescence during the COVID time, have told that all our parents lied, because earlier they never allowed us to use the laptops, but during COVID they made us to sit in front of the laptop from morning to evening. So time alone is not a good indicator, but it is the control and the consequence of the use of the mobile or the screen. So why legislation alone falls short? So this is where it is very important that strategies that were very successful in controlling the chemical addiction, be it increasing the first use age, or be it decreasing or restricting the access to that, cannot be implemented in the behavioral addiction because technology is infrastructural. So there is no field which is away from the internet right now. So everybody has to use your mobile phones if you want to keep in touch. If you have to have a mobile phone if you want to actually do a banking. So it is present in every other domain of the life. So you can't restrict the access. And also access cannot be fully controlled because there is a good overlap. It's the same operating system which hosts your reward mechanism oriented social media. Also it is the same thing which holds your educational initiative oriented app also. The third thing is very, very important, that restrictions are circumvented. The current generation is extraordinarily smart. They are born with the digital media. So they know how to use the digital media, because I am aware of many colleges who have put a restriction on an IP, but they all use a VPN to circumvent the restriction. So it is very, very difficult to put a physical restriction in a mobile phone use, because the restrictions can be circumvented in a digital medium. The last one is that prohibition can backfire, because if you restrict the access, they go to the dark net. And then in the dark net, the children are more vulnerable and can have more problem behavior rather than in the open internet. So the adolescent brain is wired for novelty, because the reward systems are actually like adults, but the control mechanisms are like children. That is where the adolescents come. So that is why there is no maturation in terms of the control mechanisms, but the reward systems are highly functional. So the children, the adolescents in that age are having a high amount of novelty. And there is a good amount of reward pathway dysregulation, which I'll skip this because this is what I want to focus, that there is a reward deficiency syndrome. Not every other children or an adolescent who uses mobile phone gets addicted to it, because there are a subgroup of individuals, be it based on the genetic predisposition or an adverse childhood upbringing, there is a reward deficiency syndrome, who don't get rewards on a smaller amount, who actually need a big amount of rewards actually to get the high. You would have seen many individuals who actually get bored very easily, but become happy only occasionally when the reward is extraordinarily big. So this is the reward deficiency syndrome, who gets addicted to either a chemical or to a behavior like a screen. And this population, if one is taken out, they go and get addicted to the other one. So restriction alone is not going to work in this population, because they do have a biological vulnerability to get addicted to one or the other. That is where the educative component comes into the picture, because restriction only can produce only short-term reduction, whereas educative approach can bring a durable self-regulation skills. So what are all the steps which we have to do in an educative approach? So the first thing is the digital literacy training. So critical awareness about variable rewards, infinite scroll, and autoplay, which are built into the social media application. So we need to educate the individuals that if you are not paying for the app, you are actually the product. The app is making money by using your time in the app, because they are encashing your usage in the app. So it is important that these apps are devised in a way to get you addicted. So that is very, very important to train the individuals. Then the second one is self-monitoring skills. As simple as how many times you have opened a mobile phone. If you put an app which tells you, you will be astonished to see that in a day we use at least 150 touches to the mobile phone. So every time you switch off and you switch on, you switch off, switch on. So self-monitoring is the first step after the digital literacy training. And the third one is the collaborative media planning. That is, the family and adolescent have to have joint boundaries. Simply taking away the mobile phone or taking away the laptop is not going to help, because they are going to circumvent that restriction. So it is important that the parents and the adolescent both are on the same page when it is coming into what is the goal setting, and identify the underlying need, assess what use is regulating. So is it because of the boredom? Is it because I meet individuals so I am more happy in the virtual life? Or is it escape from an emotional distress? So based on that, we will have to plan what is the alternate mechanisms or alternate ways in which they can cope up with the problematic screen use. And then the last one is confronting an adolescent is not going to help, because it is only going to backfire, and motivational interview techniques is something that is going to help. install at the level of the clinic, depending on the individual and what is the reason for somebody to using the mobile phone. Only in an extraordinary rare cases where there is a risk of self-care where we may need to consider an inpatient care. So bringing it together, last slide, it is important to differentiate use from addiction. Not all internet use or a screen use converts into an addictive behavior. Behavioral addiction and reward deficiency syndrome share the same reward circuitry as the substance addiction. So if you take out one, they go into something else. So that is why it is very important that we follow an educative approach rather than a restrictive approach. Adolescent novelty seeking reflects normal brain, but at the same time, the maturation phase is very little. So that is where it becomes important that they have a high novelty seeking tendency. Legislation and restrictions are necessary but insufficient. Educative, collaborative, skill-building approach produces more durable, transferable, and behavioral change. So with this, I close my talk, and hopefully I stick to the time. Thank you.
Thank you, Dr. Naren. Next, we have our last speaker, Dr. Senthil.
Very good evening to all. At the outset, I would like to thank the organizers of Kachcon and Archana for providing this opportunity. It is always a proud moment for the teachers to share the stage with the student. Thank you, Dr. Sharani, for that. And without taking time, I will directly go to the topic. Technology today is not a tool for adolescents. It has become an ecosystem shaping the learning, communications, relationships. Post-COVID, we all have seen the increase in digital engagement among the adolescents. Adolescents are particularly vulnerable, as reiterated by Dr. Naren, because of developmental, social, and emotional transitions. The challenge is no longer a technology access, but promoting healthy and meaningful digital engagement. Now, what does the epidemiological evidence shows? Post-COVID, when we have conducted a survey among 816 school-going adolescents in Bangalore, it is found that technology use is universal. Nearly 95% of them have access and also have used internet things. What is more troubling is for every 3 children, 1 child is found to have a problematic or addictive technology use. And we have found that bedtime technology use, social networking, psychological distress, parental violence, and school connectedness were found to be associated with the technology addictions. We also found that the government schools have higher prevalence of technology addictions when compared to the aided and the unaided schools, which have its own reasons related to the parental support as well as the parental regulations. So technology overuse does not restrict only to the technology, it moves beyond addictions. A subsequent study, researchers have found that demonstrated increasing concerns related to the loneliness among adolescents, sleep disturbances to nomophobia. Healthy technology use should therefore be viewed not only as a behavioral problem, but purely public health issues because it spans across different aspects of the development of the adolescents. So we didn't stop with the numbers. We tried to understand the underpinnings as well as the meanings of the numbers that we got in the survey related to the addictive and the behavioral use. Technology is more than a device for the adolescents. Students describe technology as a learning companion, a social lifeline, and an emotional necessity. So the verbatims are given here at the end. Adolescents also have reported a series of consequences starting from physical, mental, and also the social things, starting from sleep disturbances to anxiety when separated from the phones. It also have led to family conflicts. Some of the students are saying that sometimes when parents call us during chats, we get angry and shout at them. It starts having a family conflicts also. So it has a multiple dimensions and multiple consequences related to that. So teachers also view the same problems. Teachers consistently observed a range of challenges starting from academic, behavioral, and things. Teachers mention message is that technology is both a tutor as well as a trap. Teachers also highlighted the need for parent engagement, digital literacy, healthy digital environment, and school policies for regulating a healthy use of technology. So the findings clearly highlight that there is a need for addressing technology at multiple levels, and there is a need for a multi-level public health approach ranging from adolescents, parents, schools, and also community and technology providers, with the range of approaches ranging from digital self-regulations to privacy and child safety protections. So the evidence from our research have clearly highlighted the following policy priority. Digital well-being is a school health priority. There is no doubt about it, because every 1 in 3 children have problematic or internet addictive use. Capacity building, parent engagement, school-level digital wellness policies as treated by the teachers, yearly identification and counseling, and more importantly, the multi-stakeholder approach. It is, we are very glad that concurrently the government of Karnataka have also come up with a draft policy on responsible digital use among adolescents to 2026, targeting children's classes 9 to 8. It was developed by the Health Department of Government of Karnataka and also by NIMHANS. It combats mobile addictions and mental issues by limiting recreational screen time to 1 hour daily, though it is a debatable one for because the duration of screen time is always not a criteria for addiction things. Setting technical curfews and creating tech-free zones at homes and schools. So broader discussions proposing a ban on social media use for children is also under considerations. So I will not take much time. So the take-home message is technology is not the enemy, especially for the adolescents. Healthy digital engagement, not digital restrictions, should be our goal. Adolescents need support, not surveillance. Families, schools, health systems, and policymakers must work together. Promoting healthy technology use now is an essential component of adolescent health promotions. These are my references. And thank you. Hope I completed that within time.
Thank you so much, sir. So since we are running out of time, I don't think so we'll have time for the questions or even for the audience Q&A. So I'll just summarize and thank all the speakers for sharing their experiences. And of course, adolescent health needs to be prioritized, and as evidence tells, investment in adolescent health bring in triple dividends. It's good for adolescents, for them as the future adults, and also to the next generation. So with this, I would like to conclude the panel discussion, and over to the organizers. Thank you.
Thank you, panelists and moderator. Thank you, ma'am, for sticking to the time. And I request Archana Sidaya, ma'am, to hand over the mementos to the speakers. Dr. Charini, ma'am. I request the panelists and the moderator to come to the center of the dais. Dr. Naren Rao, sir. Dr. Santil Amulan, sir. Dr. Melvin, sir. I call upon Dr. Sunil, sir, to hand over the memento to the chairperson, to the moderator, Archana Sidaya, ma'am.
Moving on to the next scientific session, the moderator, Dr. Ravindra Reddy, Vice President, Karnataka Association of Community Health, Professor, Vaidehi Institute, Medical Sciences and Research Center. To introduce the speakers, Dr. Bazarraj Dabari, Deputy Director, Child Health, Dr. Indira Kabadi, Deputy Director,